மைக் வேண்டாம்.
மீடியா
இது சவுண்ட் வெளியில கேட்கும். அவங்க இல்லாம
Whatever language you're comfortable with, English?
Oh, yeah.
You just want to English, okay. All right. Okay.
Who is organizing? I think you know me, right?
Yes, sir.
You can ask me.
Now, give the mic to doctor.
Yeah. Can you have it, doctor? Can you take it from him?
Yeah.
Okay.
Just ensure live is yeah.
All right. So with me now I have Dr. S.N. Narasimhan, the Vice President of World Hypertension League. Good to see you here, doctor.
Thank you. Yeah.
So I see so many eminent doctors today. We've been interacting so much with them about hypertension. So tell us the reason behind this initiative. What got it started? How did it initiate?
In fact, I would like to tell you that I'm currently holding the post as a Vice President of the World Hypertension League. You may be wondering what is this World Hypertension League, because many of the doctors also, they are not aware what is World Hypertension League. Actually, this consists of more than 100 societies under its banner. Each society probably will be operating in one country. In fact, we had conducted a big congress about 3 months back. In the month of March, we conducted here, where we had about 35 to 40 international speakers who had come from different countries. Under the banner of World Hypertension League, we conducted the big congress here and to disseminate the information in the field of hypertension. Yesterday was a day of World Hypertension Day. Why this World Hypertension Day? Way back 2005, on May 14th, they had started this World Hypertension Day, mainly to create awareness among people. So finally it was switched over to 17th May of every year. And in fact, no, I have to tell you that it's about 20 years of this anniversary of World Hypertension Day is today's 20th anniversary. So we have been disseminating this information through World Hypertension League and through various societies. When an information comes from World Hypertension League, almost all these 100 societies tend to follow the same mission and vision of World Hypertension League, and they take it forward to spread the information on hypertension. The mission and the vision of World Hypertension League is that detect very, very early and prevent onset of hypertension. If you diagnose the hypertension, try to control it properly, and then you allow the patient to live for a longer period, and at the same time see whether the patient has already got a damage in the brain, a damage in the heart, a damage in the peripheral vessels, or a damage in the kidney. Try to identify all these complications and then try to pick up such patients and aggressively treat so that they will not get into complications including death. So these are the main aims of World Hypertension League, which we thought it should be disseminated across the country, particularly for Tamil Nadu, because yesterday we started the Tamil Nadu Association of the Indian Society of Hypertension, in which we are going to have a lot of information to the people who are working in villages, who are working in taluk headquarters, who are working in district headquarters, where people may not be updated to that extent what we know now. Probably they should be in a position to grasp some information from us so that will be percolated among the public, among the doctors or colleagues.
Definitely a great initiative by WHL, there's no doubt about it, and thanks to all the doctors who've contributed towards being a part of this community. And also we're standing right next to the I will pledge to reduce the salt in my diet. So what do you think is the significance and the role that salt plays when it comes to hypertension, doctor?
Yeah, the salt has got a close link with the onset of hypertension. In fact, if you look into the data that is available with us today, the salt consumption, excess salt consumption is directly correlated with the onset of hypertension, number one. Number two, the kidney problems can get worsened. The heart problem can get worsened, including heart failure. And the patients can also get into problems of stroke and the dementia or the forgetfulness. These are all the complications of high blood pressure. So directly, this increases the blood pressure. This increases the heart rate. People have found now that if you are controlling the intake of salt in the diet, if you are going to get down to the levels of less than 5 grams, because in our country people try to take salt more than 10 to 12 grams or so in our country, that has to be reduced. If it is reduced to less than 5 grams per day, it is possible to reduce the onset of hypertension, the onset of hypertension complications. We can prevent all these complications to the maximum extent, and these patients probably will live for a longer period. A simple modification, a housewife can do it, because she does not know that there are many vegetables which contains little amount of salt. That is not being recognized by our own people. So they try to add more salt, more salt. That is for the taste. Our taste buds now are used to salt consumption. If you don't take salt for the next 10 days, your taste buds will get altered to the no salt concept, even in the tongue. So in fact, no, in UK, up to the age of 8 years, the children are not allowed to take salt in their diet.
Okay.
So that is a methodology by which the children are being brought up in United Kingdom. I think such sort of messages should go to the common people here, so that no things will go in the right direction and they will not get into the problems of high blood pressure in future. In fact, no, in United Kingdom there was one study where the bread contains salt. So they reduced without informing the people who are consuming this bread. So when they went to the grocery, they brought the new set of bread pieces and then started eating for the next 2 years. Without their knowledge, the salt consumption was reduced. And they were surprised to see that the people lived comfortably with the reduction of salt. They did not ask for more salt. So your taste buds will get altered if you are going to reduce it. That's the most important information, what I thought I should probably share it with everyone.
I'm sure through this video it's going to get communicated very effectively to all the audience
Yeah.
watching this right
Yeah,
now.
yeah.
Also, we have a lot of people coming from different parts of the city to attend this event today to do their checkup.
Yeah, in fact, yesterday we had actually started the Tamil Nadu state chapter of the Indian Society of Hypertension. So this is the first time now we are starting this society. This society will have a number of doctors who had joined this society from Tamil Nadu, and they are all now officials. Of course, we are going to induct more members into the fold of Indian Society of Hypertension Tamil Nadu. That probably will take the lead to percolate the information what all we are now trying to spread.
Okay, and also can you say a few words about the kind of response you've been getting over the years for this event, sir?
No, in fact, I had been involved in my own way in the past, but for the past 3 years, I think today is I think this is the third year. I need to acknowledge the support that has been given by IPCA laboratories. They had been very, very comfortable with us, and they had been actually responding to our request to spread the knowledge to the people here. And in fact, I really liked the way in which things are being done as per my requirement.
So it's a wonderful combined effort by IPCA and WHL. I hope this continues forever. Thank you so much.
So nice. Thank you
Thanks,
very much.
doctor. Thank you.
Thank you. He is actually the president of the Indian Society of Hypertension.
Hello, doctor.
So yesterday only I said no, the society was started.
Okay.
So he is the national president.
Okay.
So you can probably sign it.
Yeah, you can talk.
Yeah, we're just getting the battery ready. Just a moment. No problem.
Let's to reduce.
She is going to talk to you. She will be probably questioning you. And
I'm just
you
going to
can
ask a
really-
few words.
Related to public awareness, right?
Definitely,
So I
sir.
would confine myself to straight.
Yeah, sure, definitely, sir. Whatever you're comfortable talking about, yeah.
one thing that I would like to tell you before you interact with him.
Yes, doctor.
Because he was a past president of the Research Society for the Study of Diabetes in India.
Okay.
So he was a past president. So
Okay.
you can try to ask questions whether
Okay.
diabetic persons have hypertension, how often it comes.
Perfect.
Like that, no, you
Is
can
it necessary that a diabetic person should have hypertension?
yeah,
Okay.
all those details.
Perfect, doctor. Thanks for the input.
Your communication will be related to diabetes and diabetes because you are
Let's talk about it. Ask him what is the importance of salt.
Yeah, yeah.
Just have to say Dr. Vasant Kumar from Hyderabad.
Vasant Kumar from Hyderabad. Okay.
The sound has to go.
YouTube live లో గానే ఉంది.
Sorry. Dr. Vasant Kumar from Hyderabad. Just come all the way from Hyderabad.
Hello.
You come all the way from Hyderabad for the event, sir?
Yes, yes.
Perfect.
So since
I
I am
mentioned
the
that.
president of this,
And also he's the
I have to
president of Indian Society of Hypertension. Okay.
It's
So
a
with
m-
us we have a very, I'll just give a lead doctor.
okay.
With us we have a very eminent doctor among. It's a privilege to have you here among
It's my
us
pleasure
today.
too.
So we have Dr. Vasant Kumar. He's the vice president of the Indian Society of Hypertension. He's come all the way from Hyderabad. Thanks for that. And tell us about your experience being here today, sir.
Experience here?
Once again, I'll do one. Oh, sorry.
Yeah.
Okay, one.
Yes. No.
One,
Doesn't-
one more.
doesn't
Doctor.
matter.
Sorry.
Doesn't
no,
matter.
no, doctor.
We'll repeat.
Yeah. All right, we have with us a very eminent doctor, Dr. Vasant Kumar, all the way from Hyderabad, who is the president of ISH, Indian Society of Hypertension. Glad to have you with us, doctor. So please tell us about your experience being here today.
Wonderful. It's a huge initiation by the Tamil Nadu chapter of Indian Society of Hypertension. Yesterday we had a meeting of doctors where we discussed about the academics of hypertension, the problems of hypertension, how to handle it in our country. Today we have the program here where we are creating more awareness through you and through other channels, and that's the thing. So it's wonderful. I am hoping that rest of our country will follow what Tamil Nadu is doing, so that we reach out to every person.
Great, doctor. And also considering your in-depth knowledge in diabetics, I would like to ask you something, a layman's question I might say. Is it necessary that a diabetic person should have hypertension? How does it work, doctor?
So the important point that you mentioned, one thing is, before I answer your question, we all know that diabetes itself is increasing by leaps and bounds in India. And then it's unfortunate that more than half of diabetics will have high blood pressure compared to non-diabetics. As it is, hypertension is so common. It has become common. In diabetics, you find it more common. So somebody is diabetic, so they need to be very careful. They need to check the blood sugars, blood pressure. And once they have blood pressure, they need to be treated carefully to keep the blood pressure under control, along with the blood sugars, so that they lead healthy and also long life.
And also, we've understood from the other doctors as well that salt plays a vital role when it comes to
Absolutely.
increasing hypertension.
Absolutely.
We also have a board put up here pledging that we will reduce the intake of salt in the diet.
I
so
know.
what would you like to say about it? What the baby steps one can take to reduce
I know.
salt?
Finally, it should reach out to the people, as you said.
That's right.
That salt is not good, too much of salt is not good. Unfortunately, in India, we consume more salt in so many forms, right? Most of the food that we eat outside, what we call junk food, has obviously more salt. And then we are all pickle lovers, most of us, especially South India. So even if you take a little bit of pickle, there's a lot of salt. So we need to reduce our salt, and we need to teach this to our children right from that age, and make sure that less salt is used by the homemaker. And second thing is older people.
Okay.
So we have geriatric population, which is about 20% now, and most of them have high blood pressure, and most of them have been eating salt all their life, right?
Okay.
So it's not so easy to cut down their salt, but we need to impress on them the importance of taking less salt. That's the point.
So my understanding from whatever you're saying is that it's more of a lifestyle change one has to get accustomed to since childhood itself. That's right.
Absolutely. If you see most of these non-communicable diseases, what we call today, whether it's diabetes or high blood pressure, what we call it hypertension, and people developing heart diseases, all of these are mostly related to our lifestyle.
True.
Because people are becoming overweight, people are consuming a lot of food from outside, as I mentioned. So you just imagine what will happen, for example, 10 years down the line. People who are in 20s now are consuming all these things. They're stressful, less sleep, eating food outside. And then most of them, now you're seeing hypertension, that is high blood pressure, amongst the young people. That's why we say everybody after the age of 30, kindly check your blood pressure, whoever they are. And also remember, you see hypertension and diabetes even in the rural people. So that's a huge challenge for we, the doctors, how to reach out to them in their local language and see.
Okay. Thank you so much, Doctor.
Thank you.
I'm sure everyone is going to take a pledge today to reduce
Sure.
salt intake and work towards a hypertension-free world. Thank you so much for your
Thank you.
inputs.
Thank you for having me. Thank you. Thank you.
Sir, super, sir. Sir, phone. Give your phone, sir. I'm taking your. Come very flat. जी नागराज सर
என் டீம்ல இருந்து வருவாங்க அவங்க கிட்ட
என்னப்பா இது என்னப்பா
என்னங்க
No camera.
call the anchor. She has to.
Just coming in minutes, sir.
Huh?
Just coming in minutes.
1 minute. Sachin, you have that bouquet, ಇಲ್ಲ?
Check. Check. Good morning, ladies and gentlemen, present here today on a beautiful sunny Sunday morning. And we're here at Chettinad Vidyashram for a purpose, for a cause you all must be knowing by now. We are here to talk about hypertension, which is a thriving topic right now. And we all know that hypertension is a heart disease due to high pressure, due to fast-paced life and sedentary lifestyle this is being caused, and it also can lead to fatal consequences and cardiac arrest in the recent times. It's been happening a lot, especially in India. You'll be surprised to know that, as per World Health Organization report, with focus on India alone, it is estimated that 1 out of 4 adults have hypertension. So how many of you are aware of this fact? How many of you knew this before? Out of 4 adults, 1 of us definitely have hypertension. Did you all know this before? Can I hear some response, please? Okay, I can hear a few people saying yes over here. And also, about 12% of them have their blood pressure under control, and the rest of them do not have it under control. So India has set a target of 25% relative reduction in the prevalence of hypertension or high blood pressure by 2025. So keeping all of this in mind, keeping this goal of hypertension awareness and control in India, World Hypertension League, under the aegis of Dr. S.N. Narasingan, with us we have him. Give him a big round of applause, please. He's the Vice President of World Hypertension League. He's collaborated with Indian Society of Hypertension, represented by the President himself, C.H. Vasant Kumar. He's also with us. A big round of applause to Dr. Vasant Kumar. And the Tamil Nadu State Chapter of Indian Society of Hypertension, represented by its chairman, Dr. K. Kannan. Let's give him a big round of applause, please, to Dr. K. Kannan for being here today. And the secretary, Dr. S. Chandrasekhar. A big round of applause for him. And they all came together to begin this initiative to educate Indian masses about increasing risk of hypertension. So we're going to be seeing a lot of insights. We're going to be informed about a lot of things about this topic today. But before that, I would like to call upon stage. So let me take the privilege of calling upon stage a few esteemed leaders and panel members. Dr. S.N. Narasingan is already here with us, the Vice President of WHL, as I said earlier. With him, we have other eminent doctors, Dr. C.H. Vasant Kumar, Dr. K. Kannan, Dr. S. Chandrasekhar would be joining them on stage. And also, last but not the least, I request Mr. Sachin Nair, the General Manager of Marketing, IPCA Laboratories Limited, to join them on stage. A good round of applause for them, please. We have such reputed, eminent doctors among us today to be a part of this wonderful initiative. So before we get the event kick-started today, I request you all to raise up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I request you all to stay back for the Tamil Thai Varthu, please. Please raise up for the Tamil Thai Varthu.
எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனே தமிழனே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you. And for a beautiful start to this event today, I request you all to jointly light up the lamp. Can we have the Kuttuvelakku lighting ceremony and begin the event today? I request all the doctors to join them on stage, please. I request all the doctors present here. I request all the doctors to join them for the Kuttuvelakku lighting ceremony. It's a beautiful start to the wonderful occasion today. I request Dr. S.S. Lakshmanan, Dr. A. Aravind, Dr. P. Parandaman, Dr. K. Shanmugan, Dr. K. Dhananjayan, Dr. D.B.D. Satish Kumar, Dr. Namita Narayan, Dr. J. Nambirajan, Dr. M. Natraj. I request all of you to come up on stage, please, and do the honors. Dr. R.P. Rajesh, Dr. C. Balaji, Dr. K. Venkatagiri Krishnan, Dr. Aravind. I request you all to jointly light up the wonderful Kuttuvelakku present here. It's also a wonderful moment to be captured. We have all the eminent doctors with us present on this prestigious, dignified stage today. A big round of applause to everyone present here. Thank you so much. It's so good to see all the doctors today on the stage for a wonderful cause put together. Thank you so much, doctors. Can we have you all light up the Kuttuvelakku, please? While 5 of them light up the Kuttuvelakku, the rest of them can join them. That's Dr. Narasinhan doing the honors. The president of WHL World Hypertension League doing the honors and lighting up the Kuttuvelakku today and inaugurating the event. Thank you so much, sir. Up next, we have Dr. Vasant Kumar, all the way from Hyderabad. Thank you for taking the time out to be here today with us, sir. Thank you so much for your presence and doing the honors. It's a beautiful sight to behold. We have some of the most eminent doctors in and across India with us today, doing the honors of inaugurating this wonderful event, a beautiful cause. Thank you, doctors. Thank you so much. May now request Dr. S.N. Narasinhan, sir, for the further proceeding and interaction with the audience. We are also going to be having a Q&A session where you can shoot your questions to the doctor and he's going to get your queries cleared. Over to sir.
I'm requesting all the doctors to be here with us. If you don't have seats here, probably you can occupy the front row also. My plan is to actually engage you for a public interaction in the first 15 minutes or so. After that, the next 15 minutes, the other people will come here. We will all go down. So like that, that's a way of doing it. So people who have gone down, please come back and occupy the chairs, please. People who have gone down, please come back, occupy the chair. You can occupy the chair so that they will see whether the seat is there or not. Please. If you have seats here, be comfortable. Two more people here, yeah. No problem. Come. Why is so That's enough. There's no need for me, don't worry. You can make Chandru, you come with me. You need not sit. It's another way of exercise for us, no? This morning we did not do any exercise. You can stand. Yeah. I think you are comfortable now. Are you all comfortable? Good. Yeah, good morning, everyone. In fact, the World Hypertension League, which has got more than 100 organizations under its banner, had been spreading information on hypertension. Not only prevention of hypertension, but the detection at the early stage and preventing the complications at the early stage and make the people's lives better. That is the motive of World Hypertension League, which had been doing this wonderful job for so many years. In way back 2005, the World Hypertension League started as commemorating this day called World Hypertension Day, and subsequently it was changed to 17th May, then from the next year on. So it's going on for the past 20 years. So 2005 it was started, now it is 20 years over, and we are now on 20th anniversary of World Hypertension Day. So the World Hypertension League had been associated with so many organizations worldwide. In fact, number of organizations are part of this organization. One is the World Heart Federation, World Stroke Federation, International Society of Nephrology, PATH, and then the other, that is about the WASH, PATH, and then the Resolve to Save Lives. All these associations were giving support, continue to give support, apart from International Society of Hypertension, which is with us. CDC is also with us. So many international organizations who are involved in research activities in the field of hypertension are also part of World Hypertension League. Or I can say this way, the World Hypertension League is associated with so many organizations. And in fact, all of you know that we had conducted a big congress here in Chennai in the month of March under the aegis of World Hypertension League, Indian Society of Hypertension. In fact, the Indian Society of Hypertension president is here, Dr. Vasant Kumar, and he has come all the way from Hyderabad and he has responded to our request to take part in this meeting. In fact, yesterday we had a meeting at Hotel Hyatt Regency, Chennai, where we had deliberations from some good experts in the field of hypertension. Subsequently, we also had commemorated the World Hypertension Day. In addition, what is important here is to tell you that the Indian Society of Hypertension, which is responsible for our activities, now had started spreading the wings to various other states also. For example, the Jammu Kashmir started a chapter, UP started another chapter, Rajasthan chapter, Telangana chapter, and Chennai, that is the Tamil Nadu state chapter. The state chapters are now being encouraged, not the branches. So the state chapter will be responsible to take the lead to convey the information to the general public, to spread the knowledge among the experts in the field of medicine, in the field of cardiology, in the field of neurology and nephrology, so that all of them will put their heads together to combat the menace of hypertension. In fact, today we have so many people seated here. I think Chandrasekhar will be in a position to tell who is who, though I also know them. But Chandru, being the secretary for the Tamil Nadu State Chapter of the Indian Society of Hypertension, who was elected yesterday as a secretary. Dr. Kannan is here. He has just now arrived. Dr. Kannan is the president. Currently, he is actually the professor of medicine, professor of cardiology, Institute of Cardiovascular Medicine at Madras Medical College. And I'm really happy that all people who have adequate knowledge in the field of hypertension are all seated here. And though they are having their own specialty, like diabetes or cardiology or neurology, whatever is the specialty, super specialty that you have, but the basic foundation is medicine. In medicine, we are now trying to take out one branch, and that is hypertension. All of you know that people had been giving a lot of importance to only diabetes. Dr. Vasantakumar, you must excuse me now. Dr. Vasantakumar, you must excuse me now because I'm just talking about people are giving importance to diabetes and had been giving importance in the past also, thinking that that is a big problem. No doubt. But the people were actually embarking on this issue of diabetes and its complications. So people are very much aware about diabetes. But many people have forgotten about another entity called hypertension. It is a silent killer. All of us know that there won't be any symptoms with respect to hypertension. The moment you go to a doctor, the blood pressure probably can be assessed there and you diagnose hypertension, and the hypertension is again confirmed by other methodology by the doctors, so that the person comes under the label of hypertensive individual, and during which time probably the doctor is likely to advise lifestyle modification as well as the pharmacotherapy. So today, the public, only very few people, in fact, the doctors are ready to talk to the people, but the people are not ready to listen to them. They are not coming in larger number. That's a pity. And I don't think such an attitude should be there from the general public. Tamil Nadu State Chapter, under the guidance of Dr. Kannan and Dr. Chandrasekhar, probably will take the lead to create more awareness among the public, to call more number of people for interactive sessions so that they will come to know what is what about hypertension. With these few words, I think Dr. Chandrasekhar will introduce one after the other. After that, we'll take questions from the floor also. You can raise any question. Even the doctors can raise questions, or the people who are seated on the back row can also raise questions. If I don't get any question from you, probably I'll be asking them. Okay? Fine.
So good morning, ladies and gentlemen. It's my pleasure to introduce each of the panelists. Dr. DBD Satyakumar is a senior consultant and director of Sugam Hospital. Dr. Prince T. Kumar Payas from Kanyakumari. So he is the previous dean of Kanyakumari Medical College. Professor K. Dhananjayan, Professor of Medicine, Stanley Medical College. Professor Venkatakrishnan, he is the Senior Professor of Medicine in Ramchandra Medical College. We have Dr. J. Nambirajan, Cardiologist, Head of the Department from Coimbatore Medical College. We have Professor P. Parandaman, Retired Professor of Medicine from Kilpauk Medical College. We have a Senior Physician, Dr. S.S. Lakshmanan, Director of Priya Nursing Home. We have another senior professor with us, like Dr. K. Shanmugam. She is the senior consultant at Stratford Hospital. I think all of us know Dr. C.H. Vasant Kumar, the President of Indian Society of Hypertension. We have Dr. R.P. Rajesh, diabetologist from Chennai. We have Dr. C. Balaji, diabetologist from Kumbakonam. And finally, we have Dr. Namita Narayanan, Professor of Medicine from Madras Medical College. Shall I introduce, sir? Yeah. Professor K. Kannan, sir, please, Professor of Cardiology. He is the Chairman of Indian Society of Hypertension. Dr. A. Arvind, Dean, Omandura Medical College. Dr. Siranjeevi, nephrologist from Chennai. Dr. Aditya, Professor of Medicine, Panimalar Medical College. We have Dr. R. Kannan, Professor of Medicine, Savita Medical College. We have Dr. M. Natraj, Professor of Medicine from Thiruvarur Medical College. We have Dr. Arvind Durvasal, Interventional Cardiologist from Armora Heart Care. We have Dr. S. Seduraman, Senior Physician from Tiruchi.
What I will do now, we will try to take some questions from the floor and ask these specialists. Once when the 15 minutes time gets over, probably they will go down. And those people who have introduced just now, who are occupying the first row as doctors, they can come here and answer the questions which are going to be raised by the people here. So I think the diet plays an important role. Do you have any question pertaining to diet on hypertension? Please ask. வாழ்க்கை நெறிமுறைகள் மாறும்போது பிளட் ப்ரெஷருடைய லெவலும் மாறுது. பிளட் ப்ரெஷர் வர்றதுக்கான முக்கியமான காரணம் ஜெனட்டிக்ஸ்னு சொல்கிறாங்க. ஜெனட்டிக்ஸ் ஒன்லி அபவுட் 7 to 10%. மீதி எல்லாமே என்விரான்மெண்டல் ஃபேக்டர்ஸ் மெயினாக. ஸோ இந்த என்விரான்மெண்டல் ஃபேக்டர்ஸ்லாம் ரொம்ப இம்பார்ட்டன்ட் ஃபேக்டர் இஸ் டயட்டு. என்ன டயட்டில் என்ன ப்ராப்ளம் கனெக்ஷனில் வித் ஹைப்பர் டென்ஷன், இதுதான் ரொம்ப முக்கியமான விஷயம். அதுக்கு ஐ கேன் ஆஸ்க் சத்யகுமார் to tell something about diet and hypertension. Confine yourself only to with a very short answer, please.
உணவு கட்டுப்பாடுங்கிறது வந்து
மைக் ஆன்.
அதாவது டேஷ் டயட்னு சொல்லுவாங்க. அதாவது டயட்ரி அட்வைஸ் டு ஸ்டாப் ஹைப்பர் டென்ஷன் ஷார்ட்டாக சொல்கிறது. அதில் ஷார்ட்டாக சொல்கிறதுனா ஹோல் கிரெயின்ஸ், அதாவது அன்பாலிஷ்டு கிரெயின், அதுக்கப்புறம் நிறைய வெஜிடபிள்ஸு, நிறைய ஃப்ரூட்ஸ், நட்ஸ் அண்ட் கிரெயின்ஸ், நட்ஸ் அண்ட் சீட்ஸ், இதுதான் மெயின் பார்ட் ஆஃப் டயட் இருக்கணும். நான் வெஜிடேரியன் சாப்பிட்றவங்க வந்து லீன் மீட், அப்புறம் ஃபிஷ், அந்த மாதிரி சிக்கன், இந்த மாதிரி மீட் வகைகள் சாப்பிட்டுக்கலாம். அண்டு ஆல்கஹால் இருக்கக்கூடாது. இன் ஷார்ட் சொல்லப்போனால் நிறையா ஃப்ரூட்ஸ், வெஜிடபிள்ஸ் அண்ட் லீன் மீட் வித் சால்ட் ரெஸ்ட்ரிக்ஷன். சால்ட் வந்து ஒரு நாளைக்கு வந்து லெஸ் தென் 5 grams ஆஃப் சால்ட் அல்லது 2 grams ஆஃப் சோடியம், அதுதான் டயட். திஸ் ஹேஸ் டு பி ஃபாலோ.
ஐ திங்க் 5 grams ஆஃப் சால்ட்னு அவர் சொன்னது வந்து சோடியம் குளோரைடு. கடைசியில் சொன்னார் 2 grams ஆஃப் சோடியம். அது நீங்கள் 2 grams ஆஃப் சோடியம் ஞாபகம் வச்சுக்க வேண்டிய அவசியம் இல்லை. எல்லாருமே 5 grams ஆஃப் சால்ட், சோடியம் குளோரைடு ஞாபகம் வரும். I think Satyakumar, can you just tell us something about potassium, which is very important for prevention of hypertension? Can you?
பொட்டாசியம் வந்து ரொம்ப மெயின் ரோல். அதனால இப்போ நிறைய நேரம் சால்ட்டு சப்ஸ்டியூட் கூட பொட்டாசியம் சால்ட்ஸ் யூஸ் பண்ண சொல்கிறாங்க. அது மாதிரி நீங்கள் நேச்சுரலாக அக்கரிங் வந்து நீங்கள் சப்ளிமெண்ட் பண்ணி சாப்பிடணுன்னு அவசியம் இல்லை. நம்ம நிறையா ஃப்ரூட்ஸ், லைக் இப்போ நிறையா ஃப்ரூட்ஸில் வந்து பனானாவில் நிறையா பொட்டாசியம் இருக்கும், அது மாதிரி டேட்ஸில் நிறைய பொட்டாசியம் இருக்கும், அது மாதிரி ஃப்ரூட்ஸ் நிறைய சாப்பிடலாம். டெண்டர் கோகனட், இதெல்லாம் வந்து பொட்டாசியம் நிறைய இருக்கக்கூடிய ஃப்ரூட் ஸ்டஃப். ஸோ நல்ல ஃபுட்ஸ் வித் கண்டெய்னிங் பொட்டாசியம் லைக் ஃப்ரூட்ஸ் நிறைய சாப்பிடும்போது இந்த மாதிரி சப்ளிமெண்ட்ரி பொட்டாசியம் அவசியம் இருக்காது. பட் சால்ட்டுக்கு மட்டும் நீங்கள் நிறைய சால்ட் சாப்பிட்றவங்க அல்லது சால்ட் சேர்க்கணும்னு நினைக்கிறவங்க பொட்டாசியம் சப்ளிமெண்ட் சால்ட்ஸ் இப்போ வருது, அதை யூஸ் பண்ணிக்கலாம்.
தேங்க்யூ வெரி மச்.
உங்களில் யாராவது ஃபிசிக்கல் ஆக்டிவிட்டி பற்றி எதுவும் டவுட்ஸ் இருக்கா உங்களுக்கு? அதாவது ஒருத்தங்களுக்கு பிபி வந்துச்சுன்னா எப்படி அவங்க வந்து உடற்பயிற்சி செய்யணும் அப்படின்றத பற்றி உங்களுக்கு குறித்து ஏதாவது டவுட் இருக்குங்களா உங்களுக்கு? அது இருக்கணுமே, நம்ம எப்படி எக்ஸசைஸ் பண்ணணும்னு தெரிஞ்சுக்கணும்ல. சரி, அப்போ நம்ம ப்ரொஃபஸர் பிரின்ஸ் ஸ்ரீகுமார் பாயஸ் ஃப்ரம் கன்னியாகுமரியிலேருந்து வந்திருக்காரு. ஸோ அவர்கிட்ட வந்து ஒரு பேஷண்ட்டுக்கு வந்து அதிக அளவு ரத்த அழுத்தம் இருந்துச்சுன்னா அவர் வந்து என்ன மாதிரியான உடற்பயிற்சின்றது பண்ணணும், உடற்பயிற்சியில் நிறைய வகைகள் உண்டு, அதில் வந்து எப்படி ஒவ்வொருத்தங்களுக்கும் ஒவ்வொரு ஏஜ் குரூப்புக்கும் எப்படி பண்ணணுன்றது உங்களுக்கு விளக்குவார்.
ஆக்சுவலி இந்த உடற்பயிற்சின்றது வந்து இண்டிவிஜுவலைஸ்ட். அதாவது அந்த இண்டிவிஜுவல் என்ன ஒர்க் பண்ணுறாரு, அவர் மேனுவல் ஒர்க்கர்னா அவருக்கு வந்து மேபி அந்த உடற்பயிற்சின்றது தேவைப்படாது. உடற்பயிற்சின்றது வந்து நம்ம உடனே சொன்ன உடனே எல்லோரும் எல்லாம் நினைக்கிறாங்க அப்படின்னா காலையில் எழும்பி ஓடுறது இல்லைன்னா நடக்கிறது, அது மட்டும்தான் உடற்பயிற்சி அப்படின்னு நினைக்கிறாங்க. உடற்பயிற்சின்றது வந்து எப்போ வேணாலும் நம்ம பண்ணலாம். நம்ம 24 hours டைம் இருக்குது, எப்போ வேணாலும் பண்ணலாம். நிறைய பேர் என்ன பண்ணுவாங்க, டைம் இல்லை, டைம் கிடைக்கிறது இல்லை எங்களுக்கு, இதுதான் அப்படி சொல்கிறாங்க. வாட் எவர் டைம், எப்போ உங்களுக்கு டைம் கிடைக்குதோ அந்த டைம். சரி, ஃபார் எக்ஸாம்பிள் நீங்கள் ஃபோன் பேசுகிறீங்க, அது நடந்துகிட்டே கூட ஃபோன் பேசலாம், அதே ஒரு எக்ஸசைஸ். அதே மாதிரி நீங்கள் உங்கள் அலுவலகத்தில் வேலை செய்கிறீங்க, லிஃப்ட் யூஸ் பண்ணாமல் ஸ்டேர் கேஸில் நடக்கலாம், அதே ஒரு எக்ஸசைஸ். மற்றபடி கார்டியோ எக்ஸசைஸ் அப்படின்றத வந்து நீங்கள் நடக்கும்போது உங்களோட ஹார்ட் பீட் வந்து 220 - ஏஜ், அந்த அளவுக்கு வந்து ஹார்ட் பீட் இருந்ததுன்னா தட் இஸ் கால்ட் கார்டியோ எக்ஸசைஸ். அந்த எக்ஸசைஸ் பண்ணணும்னா கொஞ்சம் ஸ்பீடாக நடக்கணும், நம்ம மூச்சு வாங்குற மாதிரி கொஞ்சம் ஸ்பீடாக நடக்கணும். இந்த எக்ஸசைஸ் வந்து ஃபஸ்ட்டு கொஞ்சம் ஸ்லோவாக நடக்கணும், அதுக்கப்புறம் கொஞ்சம் ஸ்பீடாக, தென் ஸ்லோ, ஃபாஸ்ட் அண்ட் ஸ்லோ இந்த மாதிரி நடந்தீங்கன்னா கொஞ்சம் கூட நல்லது. இன்னும் அந்த மசில் இல்லை அந்த ஜிம்லெலாம் பண்ணி எக்ஸசைஸ் பண்ணுவாங்கல்ல, அந்த மாதிரி மசில் பில்டிங் எக்ஸசைஸ் இதுவும் ரொம்ப நல்லது. எக்ஸசைஸுக்கு ஒரு பர்டிகுலர் டைம் கிடையாது, எப்போ வேணாலும் பண்ணலாம். டான்ஸிங் இஸ் ஆல்சோ எ பெஸ்ட் எக்ஸசைஸ். நீங்கள் வந்து வீட்டில் சும்மா இருக்கும்போது டிவியை போட்டு சும்மா கொஞ்சம் டான்ஸ் ஆடினா கூட தட் இஸ் எ வெரி குட் எக்ஸசைஸ். அது மாதிரி வாக்கிங் பண்ணுறதுக்கு இடம் இல்லை அப்படின்னா யூ கேன் வாக் இன் த ரூம் இட் செல்ஃப். உங்கள் வீட்டிலேயே கூட நடந்துட்டு ஸ்டேர் கேஸில் மேலே ஏறி மொட்டை மாடியில் கீழே நடந்து ஆக்சுவலி ஐ டூ எக்ஸசைஸ் லைக் தட் ஒன்லி. இன் மை ஹவுஸ் ஐ யூஸ் டு கிளைம்ப் த ஸ்டேர்ஸ். அப்படியே மொட்டை மாடியில் ஒரு 2 ரவுண்ட் அடிப்பேன், திருப்பி கீழே வருவேன், கீழே வீடை சுற்றி நடப்பேன். ஸோ இந்த மாதிரி எங்கே வேணாலும் நடக்கலாம். நமக்கு வந்து நடக்கிறதுக்கு மனசு மட்டும்தான் வரணும். நீங்கள் வந்து நம்ம எல்லாருமே வந்து இந்த மாத்திரை மருந்து எடுத்துக்கிறதுல தான் வந்து குறியாக இருப்போம். இந்த மாதிரி லைஃப் ஸ்டைல் மாடிஃபிகேஷன், எக்ஸசைஸ், டயட் இதில் வந்து கான்சன்ட்ரேஷன் கம்மி. இதை வந்து நீங்கள் பண்ணீங்கன்னா இன்னும் நல்லா உங்களோட பிபியை கண்ட்ரோல் பண்ணலாம்.
தேங்க்யூ சார், தேங்க்யூ வெரி மச். ஐ திங்க் யூ மென்ஷன்ட் அபவுட் கார்டியக் exercise. Nambirajan is here, professor of cardiology. So let him say a few words on this.
கார்டியாக் எக்ஸசைஸ்ங்கிறது உங்களுக்கு நார்மலாக ஏரோபிக் எக்ஸசைசஸ்ஸு. அது வந்து சைக்கிளிங், வாக்கிங், ஸ்விம்மிங் இந்த மாதிரி இருக்கிறது வந்து உங்களுக்கு ஹார்ட் ரேட்டை இன்க்ரீஸ் பண்ணிவிட்டு ஹார்ட்டுக்கு ஸ்ட்ரெயின் இல்லாமல் இருக்கும். வெயிட் லிஃப்டிங் பண்ணுறது இதெல்லாம் வந்து நான் ஏரோபிக் எக்ஸசைசஸ்ஸு. அதெல்லாம் வந்து கொஞ்சம் ஹார்ட்டுக்கு ஸ்ட்ரெயின் அதிகமாகும். ஸோ டிபெண்டிங் அப்பான் த ஏஜ், யுவர் பாடி கண்டிஷன் வந்து நீங்கள் எவ்வளோ தூரம் நடக்கலாம், எவ்வளோ தூரம் சைக்கிளிங் பண்ணலாம் அப்படிங்கிறத டிசைட் பண்ணிக்கணும். ஸோ இப்போ ஒரு 20 வயசில் இருக்கிறவங்களும் ஒரு 40 வயசில் இருக்கிறவங்களும் ஒரே மாதிரி பண்ண முடியாது. ஸோ கோமார்பிட் கண்டிஷன் சொல்கிற மற்ற பிபி, ப்ளட் ப்ரெஷரோ சர்க்கரையோ இருக்கிறவங்க, ஹார்ட் ப்ராப்ளம் இருக்கிறவங்களுக்கெல்லாம் கொஞ்சம் வந்து நம்ம அந்த வாக்கிங் இதெல்லாம் வந்து ரெஸ்ட்ரிக்டடாக வச்சுக்கணும். 30 minutes ஆஃப் ரெகுலர் வாக்கிங் பர் டே இஸ் மோர் தென் எனஃப் உங்களுக்கு. ஸோ சார் சொன்ன மாதிரி அந்த டார்கெட் ஹார்ட் ரேட் இதெல்லாம் வேண்டாம். ஸோ எனி டைம் யூ கேன் வாக். எஸ்பெஷலி வந்து வாக்கிங் இஸ் மோஸ்ட் இம்பார்ட்டன்ட். சைக்கிளிங்கும் பண்ணலாம் வித் த அட்வைஸ் ஆஃப் யுவர் டாக்டர். நீங்கள் கார்டியாக் பேஷண்ட்டாக இருந்து ஒரு ஹார்ட் அட்டாக் பேஷண்ட் வந்து இருக்கீங்க அப்படின்னா எவ்வளோ தூரம் நீங்கள் பண்ணலாம் அப்படிங்கிறத ஒரு ட்ரெட்மில் டெஸ்ட் பண்ணி ஈஸியாக அசஸ் பண்ணிடலாம். ஸோ நீங்கள் கார்டியாக் பேஷண்ட்டாக இருந்தால் உங்களுடைய கார்டியாலஜிஸ்டோட அட்வைஸோடு தான் வந்து நீங்கள் எக்ஸசைசஸ் பண்ணணும். பேசிக் வாக்கிங்காக இருந்தாலும் சரி. ஏன்னா ஹார்ட் ஃபெயிலியரில் இருந்தீங்கன்னா எவ்வளோ தூரம் நடக்கலாம், அப்ஹில் எவ்வளோ தூரம் நடக்கலாம். திடீர்னு நீங்கள் ஒரு ஹில் ஸ்டேஷன் போயிருக்கலாம், ஊட்டி, கொடைக்கானல்ன்ட்டு. அங்கே பார்த்தீங்கன்னா கொஞ்சம் ஸ்டீப்பாக இருக்கும், ஆக்சிஜன் அளவு கம்மியாக இருக்கும். சடனாக பார்த்தீங்கன்னா உங்களுக்கு மூச்சு வர்றதுக்கு கஷ்டமாயிரும். ஸோ உங்களுக்கு பேசிக்காக உங்களுடைய எண்டூரன்ஸ்னு சொல்லுவோம், அண்டு எண்டூரன்ஸ் வைட்டல் கெப்பாசிட்டின்னு, அது வந்து உங்கள் டாக்டரோட ப்ரிஸ்கிரிப்ஷன் மாதிரி தான். ஸோ எனி கார்டியாக் பேஷண்ட் ஷுட் அண்டர்கோ இந்த எக்ஸசைஸ் வந்து ஒரு ப்ரிஸ்கிரைப்டாக உங்கள் டாக்டர் ஆலோசனைக்கு அப்புறம் பண்ணால் நல்லதாக இருக்கும். தேங்க்யூ சார்.
Dr. Dhananjayan, I think I can ask you one pertinent question about alcohol and high blood pressure.
இது வரைக்கும் நம்ம பார்த்தது வந்து நம்ம பழக்க வழக்கங்கள், உடற்பயிற்சி, அது லைஃப் ஸ்டைல் மாடிஃபிகேஷன் சொல்கிறோம். ஸோ முதல்ல அதை வந்து நம்ம ஒழுக்கம்தாங்க முக்கியம். இதில் ஆல்கஹால் கன்சப்ஷன், மதுபானம் அருந்துவது வந்து அறவே தவிர்ப்பது நல்லது. மதுபானம் அதிகமாக அருந்தினோம்னா அதுவே வந்து பிபி அதிகமாகிறதுக்கும் அத்ரோஸ்க்ளரோசிஸ் சொல்லுவோம், அதுவும் வந்து ஆக்சலரேட் ஆகும். நம்ம கொஞ்சமாக வரத்துக்கு அது அதிகமாக ஆகும்போது நம்மளுடைய ரத்த குழா வந்து ஸ்டிஃப் ஆகிடுது. ஸ்டிஃப் ஆகும்போது பிபி அதிகமாகிறதுக்கு வாய்ப்பு அதிகமாக இருக்குது. ஆனால் நம்ம நிறைய கைட்லைன்ஸு சொல்லிகிட்ருக்காங்க, மாட்ரேஷன் டு ஆல்கஹால்னு சொல்கிறாங்க. பட் நம்ம மேக்ஸிமம் பெனிஃபிட் இருக்கணும்னா மதுபான வகைகளை அருந்துவதை அறவே தவிர்ப்பது நல்லது. பட் மாட்ரேஷன் சொல்லும்போது 2 ட்ரிங்க் ஃபார் ஆண்களுக்கு, 1 ட்ரிங்க் பர் டே ஃபார் லேடிஸ்க்குன்னு சொல்லுவாங்க. ட்ரிங்க்குன்றது பர் கிராம் 10 கிராம் ஆஃப் ஆல்கஹால்னு சொல்லுவாங்க. அது என்ன வகையான மதுபானம் நீங்கள் குடிக்கிறீங்களோ அதை பொறுத்து அமையும். பட் மதுபானத்தை தவிர்ப்பது அறவே தவிர்ப்பது நல்லது. இன்னொன்று, நீங்கள் அதுக்கு அடிமையாகி இருந்தீங்கன்னா அதுலேருந்து வெளியே வரும்போதும் டாக்டரோட அறிவுரைப்படி இருக்கணும். இல்லைனா அது ரீபவுண்டாக வந்து பிபி பேஷண்ட் கொஞ்சம் டேஞ்சரஸாக அமையும்.
I think I'm seeing Dr. Chiranjeevi in the audience. Dr. Chiranjeevi, can you just come here, please? Can you just tell us how early you can detect the kidney injury due to uncontrolled hypertension? High blood pressure வந்துருச்சு, கிட்னியில் பாதிப்பு வந்துருச்சு அப்படின்றது ரொம்ப எளிதாக அவங்களுக்கு புரிகிற மாதிரி தமிழில் சொல்லிடுங்க.
Blood pressure earlier கண்டுபிடிக்கிறது நார்மலாக ஆல் பேஷண்ட்ஸ் ஷுட் பி செக்ட் ப்ராப்பர்லி ஃபார் த blood pressure. அது பிபி செக் பண்ணுறதுக்கும் there are certain methodology. They should be made sit for 5 to 10 minutes rest, lean in the chair and keep the legs down, and you have to apply the cuff and then record the blood pressure. If the blood pressure is there for a long time, it will start affecting the kidney by way of increasing the protein excretion. There is a glomerular filtration, there is a lot of protein will be filtered. This protein excretion produces interstitial fibrosis and damage of the glomeruli and nephron. And thereby slowly, when there is a glomeruli are undergoing sclerosis, you will slowly losing your glomerular filtration rate and develop a renal failure. It is better to assess the blood pressure at the earliest stage and control the blood pressure to the normal range.
Blood pressure, thank you, sir. Thank you. High blood pressure and cardiac complications. I think I should ask Venkatakrishnan, because he is the teacher for many of the people here. So he will be giving us information in a very, very crisp manner.
ஸோ இந்த உலக உயர் இரத்த அழுத்த தினத்தில் நாம் புரிந்து கொள்ள வேண்டியது என்னென்னால், இவ்வளவு முயற்சி எடுத்து இவ்வளவு மிகப்பெரிய பேராசிரியர்கள் அனைவரும் ஒன்று கூடி உயர் இரத்த அழுத்தம் வரக்கூடாது என்று சொல்வதற்கு முக்கிய காரணம், நமது உறுப்புகள் எது வேணாலும் பாதிக்கப்படலாம், அதில் முக்கியமாக இருதயம். இப்போ இருக்கிற சூழ்நிலையில் ஒரு ஸ்ட்ரெஸ் வாழ்க்கையில், நிச்சயமற்ற வாழ்க்கையில், எப்போ வேலை போய்டுன்ற வாழ்க்கையில், அந்த மாதிரி இருக்கிற வாழ்க்கையில் ஏற்கனவே இருதயம் ரொம்ப பாதிச்சிருக்கும். அதற்கு மேல் உயர் இரத்த அழுத்தம் என்னென்ன பாதிப்புகள் ஏற்படுத்துன்னு, ஒரு டியூப்பில் தண்ணி போகிற மாதிரி தான். நல்ல டியூப்பில், அடப்பில்லாத டியூப்பில் நல்லா போகும் தண்ணி. நல்லா டைட்டாக போச்சுன்னா என்னாகும், தண்ணி ஸ்லோவாக போக ஆரம்பிக்கும், ரத்தம் ஸ்லோவாக, திசுக்களுக்கு ரத்த ஓட்டம் போகாது. இதுதான் கொரோனரி ஆர்டரி டிசீஸ், ஹார்ட் அட்டாக் வரத்துக்கான காரணம். இந்த இரத்த ஓட்டம் குறையும் போது இருதய ஃபங்க்ஷன், இருதயம் துடிப்பதும் இருதயம் சுருங்கி விரிவதும் குறைபாடு வரும். இதுதான் ஹார்ட் அட்டாக் ஆன பேஷண்ட்ஸுக்கு ஹார்ட் சுருங்கினதால் கொஞ்சம் தூரம் நடந்தாலே மூச்சு வாங்க ஆரம்பிக்கும். இது வராமல் தடுக்கிறதுக்கு எல்லாமே நாங்கள் சொல்லியாச்சு. இப்போ எதுவாக இருந்தாலும் அட்டாக்கு தான் முக்கியமான வியாதி. இருதயத்தால் அழுத்தம் கூடி நடக்கவே முடியாத நிலைமை வரலாம். அதை கட்டுப்படுத்துறதுக்கு எல்லாமே என்னென்ன பண்ணணும்னு சொல்லியிருக்காங்க.
ப்ரெக்னென்சியும் போது பிளட் ப்ரெஷர் ஏறுனா குழந்தைய பாதிக்குமா, அம்மாவை பாதிக்குமா? பிளட் ப்ரெஷர் முன்னாடியே இருந்து ப்ரெக்னென்ட் ஆனால் என்ன பண்ணணும்? இல்லை ப்ரெக்னென்சியும் போது தான் பிளட் ப்ரெஷர் கண்டுபிடிச்சிருக்காங்க, அப்போ என்ன பண்ணணும்? டெலிவரி ஆனதுக்கப்புறம் பிளட் ப்ரெஷருக்கு ட்ரீட்மெண்ட் தேவையா இல்லையா? நிறைய விஷயம் இருக்குது தெரியறதுக்கு. பட் இப்போ ஒரே ஒரு லேடி அங்கே உட்காந்துருக்காங்க, அந்த டாக்டர் நம்பிதா நாராயணன். அவங்கள நான் கேட்க போகிறது ஒன்று, ரொம்ப நாளாக பிளட் ப்ரெஷர் இருக்குது, பட் 30 வயசுக்கு அப்புறம் தான் அவங்க ப்ரெக்னென்ட் ஆனாங்க, என்ன செய்யணும்?
எஸ் சார், ஏற்கனவே பிபி இருக்குது, அதுக்கப்புறமா கன்சீவ் ஆகிருக்காங்கன்னா அதுக்கான மாத்திரைகள் நம்ம தொடர்ந்து போட்டுன்னு தான் இருக்கணும். ஆனால் ப்ரெக்னன்சி அப்போ ஒரு சில மாத்திரைகள் போடலாம், ஒரு சில மாத்திரைகள் போட முடியாது. ஸோ ஏற்கனவே ப்ரெக்னன்சி பிளான் பண்ணிகிட்ருக்காங்கன்னா அந்த டைம்லேயே அந்த ரத்த அழுத்தத்துக்கான மாத்திரைகளை மாற்றி அந்த ப்ரெக்னன்சி டைமில் போடுறதுக்கு ஜென்ரலி சேடு இல்லை பீட்லால், நெஃபிடபின் 2-3 மாத்திரைகள் போட முடியும். ஸோ அந்த மாத்திரைகளை முன்னாடியே உட்கொள்ளலாம். உட்கொண்டதுக்கப்புறமாவும் எவ்ரி மந்த் தேல் ஹாவ் டு கம் அண்ட் செக்அப். ஸோ 120/80 தான் நம்ம ஜென்ரலாக சொல்லுவோம் எல்லாருக்கும் ஒரு நார்மல் பிபிங்கிறது. ப்ரெக்னென்ட் ஆனப்போ ஒரு 140/90 எல்லாம் வந்ததுனாலே அது ரொம்ப ஜாஸ்தி. ஸோ அது அவ்வளோ வராமல் இருந்து குழந்தைக்கு கண்டிப்பாக பாதிக்கக்கூடிய இருக்குது. மோரோவர் ப்ரெக்னெண்ட்டாக இருக்கும்போது பிபி இருந்ததுன்னா கூடவே சுகரும் வர்றதுக்கான வாய்ப்புகள் இருக்குது. ஸோ கண்டிப்பாக மாத்திரைகள் தொடர்ந்து போடணும். அதுக்கு ஏற்ற மாதிரி ஏற்கனவே பிபி இருக்கிறதுனால உப்பு கம்மியாக சாப்பிடலாம், எக்ஸசைஸ் எல்லாமே பண்ணிட்டு இருப்பாங்க. ஸோ க்ளோஸ் மானிட்டரிங் அண்ட் செக்அப் வித் கண்டினியூஸ் டேப்லெட்ஸ் இஸ் நெசசரி. எஸ்,
தேங்க்யூ. ஐ திங்க் நம்ம ஃப்ரெண்ட் இருக்கார் டாக்டர் லக்ஷ்மணன், அவர் வந்ததுலேருந்து பார்த்துட்டு இருக்க அந்த ஃபோனை இப்படி 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 பண்ணிகிட்டே இருக்கார். ஃபோன் அடிக்கடி பார்க்குறதுனால ப்ளட் ப்ரெஷர் ஏறுமா, சைக்கோ சோஷியல் ஃபேக்டர்ஸ் அஃபெக்ட் ஆகுமா, தூக்கம் போயிடுமா? நீங்கள் தான் சொல்லணும். சொல்லுங்கள்.
புத்திமதி சொல்கிறது ஈஸி, பட் கடைப்பிடிக்கிறது கஷ்டம். Of course, television and cell phones definitely affects, because you always sit and watch. You know, we cannot watch while you are walking or we are doing some exercise. But best thing is நீங்கள் டெலிவிஷன் கண்டிப்பாக பார்க்கணும்னு சொன்னால் கூட நீங்கள் ஒரு நிகழ்ச்சி போட்டு you can start doing exercise. I think that's the best way of doing. Cycling வச்சுக்கலாம். You can do some simple exercises while you are watching the television. Actually, we have a condition called TV diabetes. So you keep on watching the television more than few hours sitting without moving, then you become a diabetic. Same thing, blood pressure. Blood pressure needs walking and exercise. So when you are really watching something, you can keep doing the exercises. Of course, now it's becoming an addiction to children. Yesterday I made rounds. குழந்தைங்க 3 months 6 months அழுதா உடனே மொபைல் கொடுத்துட்றாங்க. ஸோ திஸ் சில்ட்ரன் கீப் ஆன் வாட்சிங் தி மொபைல், தே கெட் ஸ்பாயில்டு. வெரி டிஃபிகல்ட். வி புல் இட் அவுட், தே க்ரை லைக் மேட் திங். அது இந்த நம்ம வீட்டில் சொல்லிக் கொடுக்குறதெல்லாம் மறந்து போச்சு. ஐ ரிமெம்பர் எங்கள் தாத்தாலாம் வந்து சாப்பிடும்போது ஜன்னல் திறந்து வச்சு கீழே உட்கார வச்சு பிரைட் லைட்டு அந்த ஹேபிட்ஸில் நம்ம சொல்லிக் கொடுக்குறதே இல்லை. ஐ ஸ்டில் ரிமெம்பர் சண்டே ஆனால் கோமணம் கட்டிட்டு ஆயில் ஃபுல்லாக தேய்ச்சிட்டு வெயிலில் நிற்க வச்சுருவாங்க. they may not know what is vitamin D3, but they have done it so brilliantly. See, அது நம்ம எத்தனை பேர் பண்ணியிருக்கோம் அது? How many of our children we have done that? We have not done our children. We all live in an AC room. And then, so try to avoid mobile watching and the television watching, and can have a control on your thing. Sorry, once again, keep watching the television.
Thank you. You will not touch the phone now.
Habits die hard.
ஓகே. சண்முகம் உட்காந்துருக்காரு. அவர் வந்து கொஞ்சம் ஒபிஸாக தான் இருக்கார். வெயிட் சர்க்கம்ஃபரன்ஸ் ஹையாக இருக்குது. ஸோ why not you tell us something about abdominal adiposity?
பொதுவாக இப்போது ஒரு ஆள் குண்டாக இருந்தால் பார்த்தோன்னா சரி அவன் குண்டாக இருக்கான்னு சொல்லிட்டு விட்டுறோம். திஸ் மே நாட் பி ஸோ மச் இம்பார்ட்டன்ஸ் ஃபார் த ஹெல்த்து. அதுக்காக இப்போ என்ன பண்ணியிருக்காங்கன்னா, இப்போ காலையில் கூட ஒரு டேப் போட்டுட்டு என் பாக்கெட்லேயே இருக்கு ஒன்று. ஃபோர் திஸ் வெரி வெரி இம்பார்ட்டன்ட். அதாவது ஒரு வீட்டில் நம்ம யார் வேணால் பண்ணிக்கலாம். ஒரு இன்ச்சு டேப்பு இல்லைன்னா சென்டிமீட்டர் டேப் இருக்கும். இந்த தொப்புள் கொஞ்சம் பக்கத்தில் நம்ம எப்படி சர்க்கம்ஃபரன்ஸ் பார்த்து எவ்வளோ சென்டிமீட்டர் இருக்குதுன்னு பார்த்தா, பெண்களுக்கு வந்து 80 சென்டிமீட்டருக்கு மேலே இருந்துச்சுன்னா அது வந்து நல்லதல்ல, விசரல் அடிப்போசிட்டி இருக்குதுன்னு அர்த்தம். அது வந்து நிறையா ப்ராப்ளம் வருது. அதே மாதிரி ஆண்களுக்கு 90 சென்டிமீட்டருக்கு மேலே இருந்துச்சுன்னா அதுவும் நல்லதில்லை. அப்படி இருந்துச்சுன்னா வி கால் தம் ஆஸ் விசரல் அடிப்போசிட்டி. குண்டாக இருக்கிறத விட இதுவும் சேர்ந்து இருந்துச்சுன்னா இன்னும் அதிகமாக இருக்கும். இதனால் என்ன ஆகுதுன்னா பல வியாதிகள் வருது. அதில் ஒரு வியாதி நம்ம இரத்த கொதிப்பு, இன்னொன்று சர்க்கரை வியாதி வரும். அதே மாதிரி பல வியாதி, அதாவது கொழுப்பு சம்மந்தமாக உள்ள வியாதி வரும். இதனால் வந்து வெங்கடகிருஷ்ணன் மற்றவங்களாம் இவர் சார் சொன்னார்ல, ஹார்ட் அட்டாக், தென் மூளை அட்டாக்கு, கிட்னி அட்டாக், எல்லா அட்டாக்கும் வரும். ஃபோர் பருமன் குறைத்தல் வந்து ரொம்ப இவர் இப்போ தான் சொன்னார். அவர் நான் என்ன சொன்னேன், நீ நொறுங்க தின்றால் உடம்புக்கு நல்லதுன்ட்டு. அதே மாதிரி நான் சொன்னேன் உண்டி சுருக்கள் பெண்டிற்கு அழகுன்ட்டு. நம்ம அந்த காலத்திலே சொல்லி வச்சுருக்காங்க. அதனால் அது சாப்பாட்டு வகையில் வந்து முதல்ல கவனம் செலுத்து. அதில் வந்து ரொம்ப கார்போஹைட்ரேட், அதாவது மாவு சத்து உள்ள பொருளெல்லாம் நம்ம சேர்த்துக்கூடாது. இனிப்பு பொருள் இப்போ எல்லா இடத்துலையும் ஸ்வீட் கடை தான் நிறையா இருக்குது, இல்லாட்டா பிரியாணி கடை தான் நிறையா இருக்குது. இப்போ வி ஆர் ஃபோர்ஸ் டு டேக் ஆல் தீஸ் திங்ஸ். ஏன்னா அது என்னென்னா இப்போ நம்ம எல்லோரும் நல்லா சம்பாதிக்கிறோம், காசு இருக்குது, குழந்தைகளையும் அங்கங்கே கூட்டிகிட்டு போயிடும், வீட்டில் சமைக்கிறதில்ல. இதனால் ப்ராசஸ்டு ஃபுட்டு, இந்த ப்ராசஸ் ஃபுட்டு வந்து வில் இன்க்ரீஸ் அவர் ஃபேட் டெஃபினட்டாக. அதனால் அதை அவாய்ட் பண்ணணும். அதுக்கு மேலே வந்து அவங்க எக்ஸசைஸ் பண்ணி சொன்னாங்க, அந்த எக்ஸசைஸ் பண்ணாலும் உடம்பு பருமன் குறையும், அந்த அடிப்போசிட்டியும் குறையும், அதனால் நம்ம நல்லா வாழலாம். இது ரொம்ப முக்கியம். அதனால் உணவு பழக்கம், அதுக்கப்புறமேல் வந்து உடற்பயிற்சி பழக்கம், அதிகமாக ஆல்கஹாலும் கூடாது, ஸ்மோக்கிங்கும் கூடாது. இதெல்லாம் இருந்துச்சுன்னா கொஞ்சம் எல்லா விதத்துலேயும் நமக்கு நன்மை ஏற்படும்.
சார் தேங்க்யூ. எங்கே ஒரு கொஸ்டின் கூட வரமாட்டேங்குது. பின்னாலேருந்து யாராவது ஒரு கொஸ்டின் கேட்டுங்க, நாங்களே கேட்குறோம், நாங்களே பதில் சொல்லிக்கிறோம். அது ஐ திங்க் அரவிந்த், why not you tell?
I think first we should not take heavy food. Yes.
No.
Walking after food.
Yeah.
It will bring down your postprandial blood sugar.
Yeah.
Somebody is capable of walking. Cardiac problem illa, they are fit to walk. The postprandial sugar is not coming down. Postprandial sugar will come down when you do exercise. So we can definitely do exercise, probably provided your cardiac doctor says you are fit to walk after your food. Sometimes the asthmatics we give steroid tablets கொடுப்போம், 5 mg 10 mg. அவங்களுக்கு அந்த postprandial sugar rise ஆகிடும். I tell them to go for a walking after the breakfast. It really brings on the exercise. Of course, full stomachல பண்ணும்போது elderly people got a cardiac compromise, we should tell them to avoid. So it depends on how much is the ejection fraction, how much is your cardiac capacity to do the exercise.
Thank you. I think எக்ஸசைஸ் பண்ணும்போது பார்த்தீங்கன்னா சில பேர் இப்போல்லாம் ஜிம்முக்கு போகிறாங்க, ஜிம்முக்கு போனோன்னு சடன் டெத் வந்துடுது. அது நிறைய ஆக்டர்ஸ்க்கெலாம் கூட நம்ம பார்த்துருக்கோம், பேப்பர்ஸில் நிறைய இடத்துல பார்த்துருக்கோம். அது மாதிரி ஏன் சடன் டெத் வருது? அரவிந்த் துர்வாசன்.
சார் ஃபர்ஸ்ட்டு சாரோட கொஸ்டனுக்கு, postprandial in cardiac பேஷண்ட்டில் வந்துட்டு we would not suggest to walk immediately after having the food சார். எஸ்பெஷலி ஆல்ரெடி ஒரு இஸ்கெமிக் லீஷன்ஸ் இருக்குது, ஒரு ஈவன் 50% நான் அப்ஸ்ட்ரக்டிவாக வந்துட்டு ஒரு லீஷன் இருக்குன்னா கூட we would not suggest them to walk. ஏன்னா ஒரு ஸ்டீல் ஃபினாமினன் இருக்கும், they'll have அந்த டைமில் வந்துட்டு ஒரு இஸ்கெமிக் ஒரு பெயின் வரதுக்கான சான்சஸ் இருக்குங்க சார். ரெண்டாவது, திஸ் எக்ஸசைஸ் அண்ட் கார்டியாக் அரெஸ்ட் விச் we are seeing lot now. இது ஒன்று சோஷியல் மீடியா அவேர்னஸ்ஸு, நிறைய நமக்கு இமேஜஸ் கிடைக்கிது, ஷேர் பண்ணுறாங்க. திஸ் ப்ரிடாமினெட்லி திஸ் அரெஸ்ட் ஹேப்பன்ஸ் பிகாஸ் ஆஃப் அன் ஆல்ரெடி எக்ஸிஸ்டிங்காக அண்டர்லைங்காக இருக்கிற ஒரு ப்ராப்ளம் தான் அந்த டைமில் நமக்கு ட்ரிகர் ஆகிட்டு நமக்கு ஒரு அரெஸ்ட் மாதிரி மேனிஃபெஸ்ட் ஆகுது. ஒன்று, இந்த மேசிவ் கார்டியாக் அரெஸ்ட் வந்து ஆல்வேஸ் நாட் நெசசரிலி கொரோனரி ஆர்டரி ப்ராப்ளம் தான் இருக்கணும்னு அவசியம் கிடையாது. நிறைய கன்ஜெனிட்டல் ப்ராப்ளம்ஸ் இருக்குது. ஒரு ஹைப்பர்ட்ரோஃபிக் கார்டியோமயோபதி மாதிரி ஒரு கண்டிஷன் இருந்து அது அன்டயக்னோஸ்டாக இருந்து அவங்க போய் ஒரு எக்ஸசைஸ் பண்ணும்போது அந்த டைமில் இட் கேன் ட்ரிகர் அண்ட் இட் கேன் காஸ். நிறைய அரித்மிக் கண்டிஷன்ஸ் இருக்குது. நமக்கு எக்ஸ்ட்ரீம் ஹார்ட் ரேட்ஸ், இப்போது எக்ஸசைஸ் பண்ணும்போது ஏஜை வந்து 220 மைனஸ் பண்ணுங்கள், உங்களோட டார்கெட் ஹார்ட் ரேட்டை ரீச் பண்ணணும் ஒரு கார்டியாக் ஆக்டிவிட்டிக்காக பண்ணும்போது ஒரு ஆக்சசரி பாத்வேஸ்லாம் உங்களுக்கு இருக்குதுன்னா அந்த மாதிரி பேஷண்ட்ஸ் வந்து வில் கெட் ட்ரிகர்ட் ஃபார் அரித்மியாஸ் அண்ட் தே கேன் கோ ஃபார் டெத். ஸோ யார் ஒருத்தருக்கு ஒரு ஃபேமிலி ஹிஸ்ட்ரி ஆஃப் சடன் கார்டியாக் டெத் இருக்கோ ஆர் ஃபேமிலி ஹிஸ்ட்ரி ஆஃப் ஒரு ஹார்ட் டிசீஸ் இருக்கோ அவங்க வந்து உங்களோட கார்டியாலஜிஸ்ட்டை பார்த்து ஒரு பேசிக் ஸ்க்ரீனிங் பண்ணிவிட்டு ஒரு ஃபாஸ்ட் ஸ்க்ரீனிங் பண்ணிவிட்டு அதுக்கப்புறமா இந்த ஹை இன்டென்சிட்டி ட்ரைனிங் பண்ணுறதெல்லாம் வந்து பெட்டராக இருக்கும் சார்.
Thank you. I think Namita was talking about pregnancy hypertension. There are certain modalities by which one can go on treating gestational hypertension. I think Parandaman will tell us what to do, what not to do during gestational hypertension.
அதாவது ஒருத்தர் மேரேஜ் கல்யாணம் பண்ணனாக்கா உடனே குழந்தை பிறக்கணும், குழந்தை பிறந்தால் அது மல்டிபிள் அந்த ஆக்ஷன்ஸ் வந்து இருக்கும். இப்போ வந்து ரொம்ப கொஞ்சம் ஒன்லி சில பேருக்கு வந்து கல்யாணம் பண்ணால் கூட குழந்தை பெற மாட்டேது. அது காரணம் வந்து என்னன்னாக்கா லைஃப் ஸ்டைல். ஒரு வேர்ல்டு சாம்பியன் அவர் ஃபஸ்ட்டு மெடல் வாங்கிறதுக்கு முன்னாடி அவர் ப்ரிப்பேர் பண்ணுவார். இட்ஸ் கால் ப்ரிப்பரேஷன். டெய்லி எக்ஸசைஸ் பண்ணுவார், டெய்லி ப்ராக்டிஸ் பண்ணுவார், டெய்லி இது பண்ணுவார். அது மாதிரி மேரேஜுக்கு முன்னாடி அவங்க வந்து ப்ரெக்னென்ட் உமன் வந்து போகிறதுக்கு முன்னாடி ப்ரெக்னன்சிக்கு ப்ரிப்பேர் பண்ணணும். தட் இஸ் வெயிட் கண்ட்ரோல், டயட் கண்ட்ரோல், ஸ்ட்ரெஸ் கண்ட்ரோல் எல்லாத்தையும் அவங்கள ரெடி பண்ணணும். பிஃபோர் மேரேஜ் அவங்க ரெடி பண்ணிடணும். அப்போனாக்கா மேரேஜ் வந்தோடனே அந்த இஷ்யூவே இருக்காது. சப்போஸ் மேரேஜுக்கு முன்னாடி அவங்களுக்கு வந்து இந்த லைஃப் ஸ்டைல் பண்ணலனாக்கா ப்ரெக்னன்சி டிலே ஆகும், பிபி அதிகமாகும், அதுக்கு பிறகு கான்சிக்வன்சஸ் வந்து கொஞ்சம் டிஃபிகல்ட்டாக இருக்கும். சம்டைம்ஸ் ஸோ மெனி அதர் காம்ப்ளிகேஷன்ஸ்லாம் வரும். ஸோ அப்போ அதை மாதிரி சுச்சுவேஷனில் அது வராமல் பார்த்துக்கணும். அப்படி வந்துருச்சுனாக்கா நம்ம கரெக்டாக ப்ளட் ப்ரெஷர் டாக்டர் பார்த்து பிபி செக் பண்ணிக்கணும். அதுக்குண்டான ஸ்க்ரீனிங் டெஸ்ட்டெல்லாம் இருக்குது. அதெல்லாம் பண்ணிவிட்டு டாக்டரெல்லாம் பண்ணணும். எப்படி பேபி எப்படி இருக்குது, பேபி ஃப்ளோ எப்படி இருக்குது, பிபி எப்படி இருக்குது, பிபி கண்ட்ரோல் இருக்கா இல்லையா, அதை பார்த்து மருந்து கொடுத்தணும். அவர் வந்து இது வந்து ஜஸ்ட் லைக் நம்ம நினச்சா மாதிரி மாத்திரை போட்ட முடியாது. இதுக்குன்னு ஸ்பெஷலிஸ்ட் போயிட்டு அவங்க வந்து டாக்டர் ஃபிசிஷியன் பார்த்து அது என்னென்ன மருந்து கொடுக்கணும்னு கணக்கு இருக்குது. அந்த மருந்து கொடுத்து ஃப்ரீக்வெண்ட்டாக பார்க்கணும். ஏன்னா அது ப்ரெக்னன்சி டைமே 9 months தான். ஸோ ஃப்ரீக்வெண்ட்டாக பார்க்கணும். அதை பார்த்துட்டு லெவல் கண்ட்ரோல்லே வச்சுக்கணும். ஹை பிபியாக இருந்தாக்கா மதருக்கு காம்ப்ளிகேஷன் வர வாய்ப்பு இருக்குது. இதே ஹை பிபி வந்து நான் ப்ரெக்னென்ட் இல்லாமல் இருந்தால் அந்த பிபிக்கு காம்ப்ளிகேஷன் வராது. அது ப்ரெக்னென்ட் இருக்கும்போது அதில் சில ஹார்மோனல் சேஞ்சஸ்லாம் இருக்கும். அதனால் கொஞ்சம் ஹையானாலே காம்ப்ளிகேஷன் வரதுக்கு வாய்ப்பு இருக்குது. அதனால் பிபி கொஞ்சம் டைட் கண்ட்ரோல் வச்சுக்கிட்டு ஸோ மருந்து கரெக்டாக சாப்பிட்டுதானா த்ரூ அவுட் த ப்ரெக்னன்சி ப்ராப்ளமாக இருக்காது. அது என்ன மதம் சாப்பிடணும், எப்படி மதம் தெரியும். அதுக்கு பீரியாடிக்காக நம்ம வந்து பிளட் ப்ரெஷர் பார்க்கணும், அல்ட்ராசவுண்ட் ஸ்கோனோகிராஃபி பண்ணணும், எக்கோகார்டியோகிராஃபி பண்ணணும், ஃபீட்டல் மானிட்டரிங் பண்ணணும். இதெல்லாம் பண்ணிவிட்டு அது பிளட் டெஸ்ட் பண்ணிவிட்டு த்ரூ அவுட் ப்ரெக்னன்சி கொஞ்சம் கேர்ஃபுல்லாக இருக்கணும். லைஃப் ஸ்டைல் தான் இது மெயின் ட்ரீட்மெண்ட்டு. லைஃப் ஸ்டைல் கரெக்டாக பார்த்துட்டு மாத்திரை சாப்பிட்டுட்டு கரெக்டாக மானிட்டர் பண்ணுறானாக்கா இந்த காம்ப்ளிகேஷனே வராது. அதுக்கு பிறகு நமக்கு இதையும் மீறி நமக்கு ஒரு காம்ப்ளிகேஷன் வருதுன்னு சொன்னாக்கா நம்ம அதுக்கு ஸ்பெஷலிஸ்ட்டுகளை கேட்டு நம்ம அது ப்ரெக்னன்சி எப்படி பண்ணுறது ஃபாலோ பண்ணலாம்.
Yes. Thank you, Parandaman. I think we talked about gestational hypertension. There are 2 diabetologists who are sitting there. Rajesh, why not you tell something about the so-called gestational diabetes? Do you see people with the gestational diabetes also having gestational hypertension? Is that common or uncommon? If it is common, what is your explanation?
ஜெஸ்டேஷனல் டயபெட்டிஸ் இருக்கிறவங்களுக்கு ஜெஸ்டேஷனல் ஹைப்பர் டென்ஷன் வந்து காமனாக தான் வருது. என்னன்னு பார்த்தீங்கன்னா நார்மலாக இருக்கிறவங்களோட நார்மல் ப்ரெக்னென்சியில் இருக்கிறவங்களோட ஜெஸ்டேஷனல் டயபெட்டிஸ் இருக்கிறவங்களுக்கு பார்த்தீங்கன்னா இந்த ரிஸ்க் வந்து கொஞ்சம் கூடுதலாகவே இருக்குது. நம்ம அதுக்கு தான் நம்ம என்ன பண்ணணும்னா அதுக்கு ப்ரிவென்ஷன் சார் ஏற்கனவே பரந்தாமன் சார் சொன்ன மாதிரி முதல்ல நம்ம அவங்களுக்கு இதெல்லாம் அவங்கக்கிட்ட சொல்லிடணும். உங்களுக்கு வந்து நீங்கள் வந்து 20 வாரத்தை தாண்டும் போது உங்களுக்கு வந்து பிபி ஏறுறதுக்கான வாய்ப்புகள் இருக்குது. ஸோ அப்போ நீங்கள் வந்து பிளட் சுகருக்கு நீங்கள் என்னென்னலாம் பண்ணுறீங்களோ மொடாலிட்டிஸ், நல்ல உடற்பயிற்சி, நல்ல ஆரோக்கியமான உணவு முறைகள், இதெல்லாம் நீங்கள் என்னென்னலாம் பண்ணுறீங்களோ அது உங்களுக்கு சுகரை மட்டும் கண்ட்ரோல் பண்ணுறதுக்கு உதவாது, உங்களோட பிபியும் கண்ட்ரோல் பண்ணுறதுக்கு உதவுன்ற எக்ஸ்ப்ளனேஷன்லாம் கொடுத்து அவங்கள நல்ல லைஃப் ஸ்டைலில் நம்ம அவங்கள ஃபாலோ பண்ண வைக்கணும். பட் நம்ம அவங்கள தொடர்ந்து கண்காணிச்சுக்கிட்டே வரணும். எஸ்பெஷலி 20 வாரத்துக்கு மேலே பார்த்தீங்கன்னா அவங்களுக்கு பிபி ஏறுறதுக்கான வாய்ப்புகள் இருக்குது. ஏறுச்சுன்னா நம்ம அதுக்கேற்றாப்புல நம்ம நடவடிக்கைகள் மறுபடியும் உணவில் கொஞ்சம் மாற்ற வேண்டியது இருக்கும். தேவை இருந்ததுன்னா ஒரு குறிப்பிட்ட அளவுக்கு மேலே அது போகுதுன்னா நம்ம மாத்திரைகளை நம்ம வந்து கொடுக்க வேண்டியது இருக்கும்.
Thank you, Rajesh. I think Balaji is there. We talked about gestational diabetes, gestational hypertension. There's one condition called pre-hypertension, which I think I violated it. 120/80 normal, 120 to 139, 80 to 89 is pre-hypertension. I must ask Balaji, what is pre-diabetes? Many people think about that all the time when the patient seeks advice for obesity, complicating their own problems or the family history of diabetes. They come with the label that they have been diagnosed as a pre-diabetic. What are the criteria by which one can make a diagnosis from your end and for the patient's side also?
Yes. ஸோ இந்த ப்ரீ டயபெட்டிஸ் அப்படிங்கிறது சர்க்கரை நோய் அப்படின்னு சொல்கிறதுக்கு முன்னாடி வரக்கூடிய ஒரு சூழ்நிலை அப்படின்னு சொல்லணும். ஸோ சர்க்கரை நோயே அப்படியே ஒரு வியாதி கிடையாது. நம்ம உடம்புல உள்ள சர்க்கரையின் அளவு ஏறும்போது தான் இந்த சர்க்கரை நோய் அப்படின்னு சொல்கிறோம். ஸோ இந்த ப்ரீ டயபெட்டிஸ் அப்படிங்கிறது எக்ஸாக்டாக என்ன அப்படின்னு தெரிஞ்சுக்கிட்டிங்க அப்படின்னா, ஒரு மனிதனுக்கு வந்து சர்க்கரை நோய் அப்படின்னு சொல்லணும்னா அவங்க ரத்த அழுத்தத்தில் 2 விதமான விஷயங்களுக்கு, வெறும் வயிற்றில் ஒரு சுகர் எவ்வளோ இருக்குன்னு பார்க்குறது, சாப்பிட்டு 1.5 மணி நேரம் இல்லை 2 மணி நேரம் கழிச்சு உங்கள் சர்க்கரையின் அளவு எப்படி இருக்குது அப்படின்னு. ஸோ வெறும் வயிற்றில் 126க்கு மேலே போனாலும் சாப்பிட்ட பிறகு 200க்கு மேலே போனால் தான் சர்க்கரை நோய் அப்படின்னு சொல்கிறோம். இந்த ப்ரீ டயபெட்டிஸ் அப்படிங்கிற கண்டிஷன் வந்து 2 விதமாக இருக்கலாம். ஒன்று உங்களுடைய ஃபாஸ்டிங் லெவல் அந்த 100க்கு மேலே அந்த 126 கீழே அப்படிங்கிறதுல இருந்தது அப்படின்னா அந்த இது. இன்னொன்று பார்த்தீங்கன்னா சாப்பிட்ட பிறகு 140லேருந்து 200 ஆனால் 200க்கு மேலே போகாது, பட் 140க்கு மேலே 200க்குள்ளே. ஸோ அவங்களுக்கெல்லாம் என்னென்னா பிற்காலத்தில் அவங்க வந்து இந்த நம்ம இப்போ இவ்வளோ நேரம் சொன்ன மாதிரி வாழ்க்கையில் உள்ள நெறிமுறைகள், நம்மளுடைய அன்றாடம் செய்யக்கூடிய வேலைகளில் மாற்றங்கள், உணவு இதில் மாற்றங்கள், உடற்பயிற்சி இதெல்லாம் பண்ணால் இந்த ப்ரீ டயபெட்டிஸ்லேருந்து டயபெட்டிஸ் போகாமல் தள்ளி போடலாம், அதை தவிர்க்கலாம். ஸோ இதெல்லாம் பண்ணாமல் அப்படியே கன்டினியூ பண்ணாங்கன்னா அவங்க பிற்காலத்தில் சர்க்கரை நோயாக மாறுவதற்கான வாய்ப்புகள் உண்டு. ஸோ இதுதான் இந்த இடைக்கட்ட காலத்தில் உள்ளவங்க தான். ஸோ அந்த ஃபாஸ்டிங் லெவல் 100லேருந்து 126, சாப்பிட்ட பிறகு 140லேருந்து 200, இந்த அளவுகளில் உள்ளவர்கள் எல்லாருமே ப்ரீ டயபெட்டிஸ்ன்னு சொல்லுவோம். ஸோ அதே மாதிரி இந்த 3 மாத சராசரி அளவு HbA1cன்னு சொல்லுவோம். ஸோ அதை பார்த்தீங்க அப்படின்னா when it is above 6.5 டயபெட்டிஸ் அப்படின்னு சொல்லுவாங்க. ஸோ 6லேருந்து 6.5 வரைக்கும் இருக்கிறவங்க தான் அந்த ப்ரீ டயபெட்டிஸ். ஸோ இந்த ப்ரீ டயபெட்டிஸுங்கிற டேர்ம் எதுக்கு கொடுத்தாங்க அப்படின்னா, ஒரு சர்க்கரை நோய் அப்படின்னு ஒரு மனுஷனுக்கு வரும்போதே அவங்க உடம்புல உள்ள பாதிப்புகளும் சேர்ந்து ஆரம்பிக்கும் அப்படிங்கிறது தான் இது. ஸோ அதனால் சர்க்கரை நோயை முடிஞ்ச அளவுக்கு தடுத்தோம் அப்படின்னா பிற்காலத்தில் அவங்களுக்கு எந்த பாதிப்பும் இல்லாமல் இருக்கிறது தான். ஸோ அந்த ப்ரீ டயபெட்டிஸ்லேயே நம்ம சரியான ஒரு பழக்க முறைகளை மாற்றி உடற்பயிற்சி செய்து உடம்புல அந்த மாற்றத்தை உருவாக்கினா கண்டிப்பாக பிற்காலத்தில் சர்க்கரை நோயும் தடுக்கலாம். அதனால் நம் உடம்புல உள்ள எல்லா உறுப்புகளையும் உள்ள பாதிக்கக்கூடிய தன்மைகளும் தவிர்க்கலாம் அப்படிங்கிறது தான்.
Thank you, Shan. I think we have finished the first row of experts. Thank you very much. I think those doctors who are seated in the first row and the second row who had been invited here to be part of the Tamil Nadu State Chapter of Indian Society of Hypertension can come here for a quick answers, quick questions and quick answers, please. ரங்கசாமி மேடம் ஒருத்தர் இருக்கு. மேடம் ரோகிணி வாங்க, சீக்கிரம் வாங்கம்மா, குயிக். சுபஸ்ரீ வாங்க, குயிக். Kannan is the president of the Indian Society of Hypertension Tamil Nadu State Branch. I will start with him. Kannan, we are all talking about the so-called hypertension, pre-hypertension, diabetes, pre-diabetes, gestational hypertension. The area of interest for me is on lipids. Tell me something about the cholesterol and hypertension connection.
I think you are the best person to answer this question, sir. Because you have interest in both and exponent in both. I mean,
tell the people how important it is to submit themselves for lipid profile.
So whenever we treat conditions which are contributing to cardiac and vascular health, namely diabetes and hypertension, we don't look it as an isolated treatment of diabetes or hypertension. We look at the overall risk factors in that patient. For example, if a patient is a diabetic, it's equally important or more important to take care of lipids and blood pressure. Similarly, when you're treating hypertension also, it's always important that you have to treat the lipids and diabetes, because this is a conundrum of things which contributes to the health. So in that way, lipids are very important, and it's very important that we check the lipids and see the treatment of lipids, or what we call as cholesterol and triglycerides, depends on the patient risk factor profile. If you are taking a high risk group patient, then we expect to have low values, and Dr. Narasimhan will tell that the LDL we want to keep it less than 50. That he is the founder, he is one of the main members of the Lipid Association of India, and we are looking at the LDL close to 50. So the values they give in the lab less than 100 does not hold good if you belong to the high risk group. Whereas if you don't have any other risk factor, then up to 100 we can accept with certain amount of, though we may not be entirely happy, but we will not be very unhappy also. So similarly in hypertension, if it comes to other factors, hypertension with ischemic heart disease, or patient has got heart blocks or treatment for that, then the recommendations of lipid are more stringent.
Thank you, Kannan sir. ஸோ நம்ம எல்லாத்துக்கும் நம்ம பேஷண்ட்ஸுக்கு எல்லாமே பிபி வந்துச்சுன்னா நிறைய இது பயப்படுறது வந்து அவங்களுக்கு வேறு ஏதாவது காம்ப்ளிகேஷன் வருமானது தான், ஹார்ட்டை பாதிக்குமா, கிட்னி பாதிக்குமா, மூளை பாதிக்குமான்றது தான். ஸோ ஒருத்தங்களுக்கு வந்து ரொம்ப ரொம்ப டிவாஸ்டேட்டிங்காக இருக்கும். ஒருத்தங்களுக்கு கிட்னி பாதிப்புன்னு சொல்லிட்டு வந்துச்சுன்னா, அது வந்தவங்கக்கிட்ட கேட்டு இல்லை அவங்களோட உறவினர்கள்கிட்ட கேட்டு தெரிஞ்சுக்கிட்டிங்கன்னா ரொம்பவே கஷ்டமாக இருக்கும் அவங்களுடைய இது பண்ணுறது. ஸோ அப்படி ஒருத்தவங்க பிபி வந்துச்சுன்னு சொல்லி தெரிஞ்சிச்சுன்னா பிபி கண்ட்ரோல் பண்ணுறது தவிர வேறு என்னென்னலாம் பண்ணணும்னா அவங்களுக்கு வந்து கிட்னி ப்ராப்ளம்ன்றது வராது. ஸோ இதை பற்றி நம்மளுக்கு விளக்கறதுக்கு டாக்டர் சுபஸ்ரீ இருக்காங்க, நெஃப்ராலஜிஸ்ட்டு. அவங்க சொல்லுவாங்க.
வெரி குட் மார்னிங் டு ஆல். சார் சொன்ன மாதிரி கிட்னி தொந்தரவுன்றது வந்து உங்களுக்கு ஒரு ஹார்ட் அட்டாக் வருதுன்ற பட்சத்தில் யூ ஹாவ் ஒரு செஸ்ட் பெயின், நெஞ்சு வலின்னு வந்து ஒரு கார்டியாலஜிஸ்ட் டைரெக்டாக போய் பார்ப்பீங்க. இதே ஒரு ஸ்ட்ரோக் வருது அப்படின்னா ஒரு வீக்னஸ் இருக்கும், கை தூக்க முடியாது, இல்லை ஃபேஸில் வந்து ஒரு ஏசிமெட்ரி இருக்கும். கிட்னி பாதிப்பு பொறுத்த வரைக்கும் எப்படின்னா இட் இஸ் அ வெரி சைலண்ட் டிசீஸ். தட் இஸ் வை ஜஸ்ட் லைக் ஹைப்பர் டென்ஷன் கிட்னி பாதிப்புக்குமே வந்து வி நீட் ஸ்க்ரீனிங். 2 இம்பார்ட்டண்ட் டிசீசஸ் இருக்க பேஷண்ட்ஸ் வந்து யார் கிட்னி பாதிப்பு இருக்கான்னு பார்க்க வேண்டியவங்க. ஒன்று ஹைப்பர் டென்ஷன், இன்னொன்று டயபெட்டிஸ். ஸோ பிபி இருக்குது, ஹைப்பர் டென்ஷன் இருக்குது, ஆன் டாப் ஆஃப் இட் கிட்னி தொந்தரவு இருக்குது அப்படின்ற பட்சத்தில் பிபி கண்ட்ரோலோட சேர்த்து ரொம்ப முக்கியமான விஷயம், இதுக்கு முன்னாடி சீனியர் நெஃப்ராலஜிஸ்ட் சிரஞ்சீவி சார் சொன்ன மாதிரி கண்ட்ரோலிங் சால்ட் இன்டேக். ஸோ சால்ட் இன்டேக் வந்து இட் இஸ் டைரக்ட்லி ரிலேட்டட் டு த பிபி. ஸோ எவ்வளோ கம்மியாக சால்ட் எடுக்க முடியுமோ as early as possible in your lifestyle, it is better. ஒன்று. ரெண்டாவது வந்து தி அதர் இம்பார்ட்டன்ட் திங் தட் இஸ் கான்ட்ரிபியூட்டிங் டு ஹை பிபி இன் கிட்னி ஃபெயிலியர் பேஷண்ட்ஸ் இஸ் லாட் ஆஃப் வாட்டர் இன்டேக். ஸோ பேஷண்ட்ஸ் வந்து நாங்கள் ஃபஸ்ட்டு ப்ரிஸ்கிரிப்ஷனில் எழுதுறது வந்து எவ்வளோ சால்ட் எடுக்கணும் நீங்கள். அண்ட் ஏற்கனவே எல்லா சீனியர் எக்ஸ்பர்ட்ஸ் சொன்ன மாதிரி இட் இஸ் less than 5 grams per day. 5 grams தான் பேஷண்ட்க்கு எப்படி புரியும்? இட்ஸ் ஜஸ்ட் 1 teaspoon of salt. It can be distributed all through your day in whatever form of food you want, you can take it. Second one is fluid intake. எவ்வளோ தண்ணி குடிக்கணும் அப்படின்னு பேஷண்ட் கிட்ட சொல்லுவோம். ஏன் கிட்னி வேலை செய்யலாம் யூரின் போக போகிறது இல்லை. ஸோ எவ்வளோ தண்ணி குடிக்கணும் அப்படின்றத இஸ் அ செகண்ட் லைன் இன் ஆர் ப்ரிஸ்கிரிப்ஷன். ஹவு வி டிசைட் இட் இஸ் we always tell patients உங்களுக்கு எவ்வளோ நீங்கள் யூரின் ப்ரொடியூஸ் பண்ணுறீங்கன்றது வந்து ஒரு 24 ஹவர்ஸில் கணக்கு எடுத்தீங்கன்ற பட்சத்தில் உங்களுடைய கிட்னியோட திறன் ஒரு 1.5 liters ப்ரொடியூஸ் பண்ணுன்ற போது வி ட்ரை டு ரெஸ்ட்ரிக்ட் டு 1.25 liters அந்த மாதிரி. இட்ஸ் நாட் அபவுட் நீங்கள் எவ்வளோ தண்ணி குடிக்கிறீங்களோ எவ்வளோ யூரின் போகிறது கிடையாது. எவ்வளோ யூரின் போதோ அதுக்கேற்ற மாதிரி தண்ணியோட இன்டேக் வந்து வி அட்ஜஸ்ட். அண்ட் டயட் பர்சே டயட் பொறுத்த வரைக்கும் கிட்னி பேஷண்ட்ஸ் வந்து ரொம்ப ஏர்லி ஸ்டேஜஸில் இருக்கும் போது கொஞ்சம் ப்ரோட்டீன் ரெஸ்ட்ரிக்ட் பண்ண சொல்லி வெஸ்டர்ன் கைட்லைன் சொல்லுது. பட் நம்மளுடைய இந்தியன் ஃபுட்டில் பார்த்தீங்கன்னா ப்ரோட்டீன் இன்டேக் இட் செல்ஃப் இஸ் வெரி லோ. ஸோ for a lot of people it might be a shocker that in kidney experts வந்து we don't tell to restrict protein in Indian population per se. இன்னும் ஒரு கட்ட அதிகமாக போனோம்னா டயாலிசிஸில் இருக்க பேஷண்ட்ஸ்க்கு we tell them to take all kinds of proteins that they can take. Mutton, chicken, non-veg, any form of protein is good for them. ஏன்னா if you have known somebody with டயாலிசிஸில் இருக்க ஒரு பேஷண்ட் பார்க்குறீங்கன்னா ஆரம்பத்தில் எப்படி இருக்காங்களோ ஒரு 6 months later அந்த வியாதியை வந்து அவங்களோட உடம்பு உரிக்கிடும். அதோட முக்கியமான காரணம் வந்து ப்ரோட்டீன் இன்டேக் இல்லாமல் இருக்கிறது. ஸோ தீஸ் ஆர் சம் ஆஃப் த மாடிஃபிகேஷன்ஸ் தட் வி அண்ட் லைஃப் ஸ்டைல் சேஞ்சஸ் தட் வி டெல் them to incorporate in their life.
தேங்க்யூ டாக்டர் சுபஸ்ரீ. நம்ம நிறைய பேர் பார்த்தோன்னா நல்ல ஃபோன்லாம் வச்சுருக்கோம். ஒவ்வொரு ஃபோனு சாதாரணமாக ஒரு ஃபோன் வாங்குறதுனாலே ஐ திங்க் 10,000 rupees நம்ம செலவு பண்ணுற மாதிரி இருக்கும். நம்ம யூஸ் பண்ணுற நிறைய கேட்ஜெட்ஸ் பார்த்தீங்கன்னா குறைஞ்சது 5,000 and above தான் இருக்கும் நம்ம சாதாரணமாக யூஸ் பண்ணுற கேட்ஜெட்ஸை. ஸோ அப்படி இருக்கும்போது அந்த இப்போது பிபி அப்பாரட்டஸ் அந்த இதனுடைய விலைலாம் பார்த்தீங்கன்னா ஒரு 1,500 3,000 ஒரு நல்ல குவாலிட்டியான ஒரு பிபி அப்பாரட்டஸ்ன்றது நம்ம வாங்கிக்கலாம். இப்போ நிறைய பேருங்களுக்கு இப்போ வந்து என்ன கைட்லைன்ஸ் நீங்கள் பார்த்தீங்கன்னாலும் நீங்கள் உலக சுகாதார நிறுவனம் இல்லை வேர்ல்டு ஹைப்பர் டென்ஷன் லீக் இல்லை இந்தியன் சொசைட்டி ஆஃப் ஹைப்பர் டென்ஷன் எந்த இது நீங்கள் பார்த்தீங்கன்னாலும் அவங்க சொல்கிற ஒரு முக்கியமான விஷயம் வந்து அந்த பிபி இருக்கிறவங்க என்ன பண்ணணும்னு சொல்கிறாங்கன்னா அவங்க ஒரு பிபி அப்பாரட்டஸ் வாங்கி வச்சுக்கணும். அவங்களும் வந்து ஹோம் பிளட் ப்ரெஷர் மானிட்டரிங் சொல்லிட்டு அவங்க வந்து சொல்கிறாங்க. அவங்க அந்த வீட்டில் இருக்கும்போதும் அவங்க வந்து அந்த பிபி வந்து செக் பண்ணி பார்க்கணும்னு சொல்கிறாங்க. இப்போ இதை பற்றி இன்னும் கொஞ்சம் டீட்டெயிலாக சொல்கிறதுக்கு நம்மக்கிட்ட திருச்சியிலேருந்து டாக்டர் எஸ் சேதுராமன் அவர் வந்திருக்காரு. ஸோ அவர் வந்து ஹோம் பிளட் ப்ரெஷர் மானிட்டரிங்னா அது வந்து ஒரு பிபி இருக்கிற பேஷண்ட்க்கு இல்லை அவங்க குடும்பத்துக்கு எப்படி யூஸ் ஆகுன்றது பற்றி அவர் சொல்லுவார்.
வந்து வீட்டில் ஆல்ரெடி யூ ஆர் டேக்கிங் ட்ரீட்மெண்ட் ஃபார் பிபி தே ஆல்சோ ஷுட் செக் அண்ட் ஆல்சோ தே ஹாவ் டு ஸ்க்ரீன் தி அதர் ஃபேமிலி மெம்பர்ஸ் who are obese or elderly patients. The silent, without any symptoms, BP can exist. For example, a BP with 190 by 120 can exist without any symptoms. These people suddenly goes for cerebral hemorrhage. தட் இஸ் ஒய் அவர் ஓல்டு பீப்புள் நல்லா இருப்பாங்க வீட்டில், திடீர்னு பார்த்தா கை கால் வராது, கொமட்டோஸ் ஆயிரும். இதுக்கு காரணம் இந்த பிபினால் பிரெயினில் ரப்சர் வர்றது இல்லை. அதனால் பிபியை வந்து அவங்களுக்கு சிம்டம்ஸ் இல்லைனாலும் பிபி பீப்புளை வீட்டில் செக் பண்ணிக்கிறது நல்லது. பட் அதுக்கு வந்து வி மஸ்ட் ஹேவ் சம் இனிஷியேட்டிவ். இதை பண்ணணும் அப்படிங்கிற ஒரு எண்ணம் இருந்தால் தான் பண்ண முடியும். இல்லைன்னா ரொட்டீனாக எந்திரிக்கிறது, சாப்பிட்றது, போகிறது அப்படிங்கிறத தவிர இதை ஒரு ஹேபிட்டாக, ஒரு ரிச்சுவலாக வச்சுக்கணும் பிபி செக் பண்ணுறத. அதுவும் பீப்புள் ஹூ ஆர் டேக்கிங் பிபி டேப்லெட்ஸ் ஷுட் செக் ரெகுலர்லி ராதர் தேன் தே கோ டு த டாக்டர் ஒன்ஸ் இன் 6 months or 1 year. That is not enough. They can check the BP in the house itself. For that we have got so many meters. One is a mercurial manometers, another is a battery operated manometers, others a dial type BP apparatus that costs very little amount, only 2,000. We are spending a lot for so many things. Each family should have a BP monitoring should be kept, and there are certain standard procedure as explained. The patient should take rest, he should sit, the back should be rested, arms should be on the some resting on the table, and then they will be in a quiet mood. The BP should be taken in the house itself. They can note down the BP, the date, time, and the BP. Or 10 or 15 readings they can take, and next time they visit the doctor, they can show, these are all my BP, sir. Accordingly, the doctor can adjust the dosage as well as he can instruct them properly. That is, so the checking a BP in the house is mandatory. It's not a luxurious thing. We should spend some time. Like that, we are having glucometer, self-monitoring of glucometer for blood sugar. We can have a self-monitoring of the blood pressure. That should teach even from the children. We must teach how to take a BP. These are all certain fundamental things we should have to adapt in our day-to-day life.
ஐ திங்க் எல்லார் வீட்லேயும் ஒரு பிபி அப்பாட்டஸ்ன்றது சார் சொல்கிறதுக்கு அப்புறம் எல்லாமே வச்சிருக்கணும்னு நினைக்கிறேன் நான்.
எவ்வளவோ திங்ஸ் வாங்கி வைக்கும்போது,
எஸ் சார், கரெக்டாக சொன்னீங்க.
தேவையில்லாத பொருள் எத்தனையோ இருக்கும்போது ஒரு பிபி அப்பாட்டஸ் அதை யூஸ் பண்ணணும். அதுதான் மெயின். வாங்குறது, எல்லா பொருளுமே வாங்குறது, இட் இஸ் வெரி ஈஸி. பட் தே ஆர் நாட் புட்டிங் இன் யூஸ் பண்ணணும். தட் இஸ் அ மோர் இம்பார்ட்டன்ட்.
எஸ் சார், தேங்க்யூ சார். சார், நம்ம நிறைய பேர் வந்து டாக்டர்கிட்ட போனாலே நிறைய விஷயங்களுக்கு பயப்படுவோம். ஒரு முக்கியமான விஷயம் வந்து என்னென்னா, டாக்டர்கிட்ட போனோடனே நம்மளுக்கு ஒரு சின்ன பதட்டம் வரும், ஒரு ஆங்ஸைட்டி இருக்கும், ஒரு மாதிரி டாக்டர் என்ன சொல்லுவாரோ, வேறு ஏதாவது சொல்லுவாரோன்னு சொல்லிட்டு அந்த ஒரு பயம் இருக்கும். அதனால் நிறைய பேருங்களுக்கு நம்ம பிபி பார்க்கும்போதே எனக்கு காலையில் நல்லா தான் இருந்துச்சு, பட் நீங்கள் வந்து இப்போ செக் பண்ணும்போது வந்து எனக்கு வந்து அதிகமாக இருக்குது டாக்டர் அப்படின்ற மாதிரி ரொம்ப ஆங்ஷியஸாக நிறைய பேஷண்ட் வந்து நம்ம வந்து பார்க்குறோம். நிறையவே இருக்கிற ப்ராப்ளம். இந்த ப்ராப்ளம் பேர் வந்து ஒயிட் கோட் ஹைப்பர் டென்ஷன் சொல்லி பேர். ஸோ இதை பற்றி சொல்கிறதுக்கு டாக்டர் கண்ணன், அவர் சவிதா மெடிக்கல் காலேஜில் ப்ரொஃபஸர் ஆஃப் மெடிசனாக இருக்கார். அவர் வந்து ஒயிட் கோட் ஹைப்பர் டென்ஷன்னா என்ன, அதனால ஏதாவது பாதிப்பு வருமா, அது வந்துச்சுன்னா அந்த பேஷண்ட் என்ன பண்ணணும் அப்படின்றத பற்றி ஷார்ட்டாக சொல்லுவார்.
காலை வணக்கம் அனைவருக்கும். ஒயிட் கோட் ஹைப்பர் டென்ஷன் என்னென்னா, வீட்டில் செக் பண்ணுற ப்ளட் ப்ரெஷர் நார்மலாக இருக்கும். பேஷண்ட்ஸ் வரும்போது, கிளினிக் வரும்போது நம்ம செக் பண்ணால் யூஸ்வலாக ரொட்டீனாக செக் பண்ணும்போது 120, 80, 130, 80 தான் இருக்கும். ஆனால் அன்னைக்கு வரும்போது பார்த்தா 160, 100 இருக்கும், ரொம்ப ஜாஸ்தி இருக்கும். என்ன கூட இருக்கேன்னு கேட்டால், இல்லை நீ உங்களை பார்த்ததுமே டென்ஷன் ஆயிடுச்சு எனக்கு அப்படின்னு சொல்லுவாங்க. அதான் ஒயிட் கோட் ஹைப்பர் டென்ஷன். அதான் கிளினிக்கில் மாத்திரம் கூட இருக்கும், ஹாஸ்பிட்டலில் போய் செக் பண்ணால் கூட இருக்கும். அது மாதிரி இருக்கிறது வந்து ஒயிட் கோட் ஹைப்பர் டென்ஷன் பேர். அதாவது டாக்டர்ஸ்லாம் ஒயிட் கோட் போடுவோம்ல, முன்னாடி ஒரு காலத்தில் எல்லாருமே ஒயிட் கோட் போட்டுருப்போம். அதை பார்த்ததுமே அவங்க டென்ஷன் ஆகிடுவாங்க. ஸோ பிபி கூட இருக்கும். அந்த மாதிரி பேஷண்ட்ஸ் என்ன பண்ணுவோம், நாங்கள் கிளினிக்கில் ஒரு 10 minutes 15 minutes உட்கார வச்சு அந்த பேசிக் மெத்தட் கரெக்டாக, அதுக்கு முன்னாடி சூடான சாப்பாடு சாப்பிட்ருக்கக்கூடாது, ஸ்மோக்கிங், ஆல்கஹால்லாம் இருந்திருக்கக்கூடாது, டென்ஷன் அவசரமாக வந்திருக்கக்கூடாது, அவர் காரோ பைக்கோ ஓட்டியிருக்கக்கூடாது. கொஞ்சம் ரிலாக்ஸ் பண்ணி ஒரு 1/2 hour கழித்து திரும்ப செக் பண்ணி பார்த்தா நார்மலாக இருக்கும். 140, 80, 120, 80க்குள்ளே தான் இருக்கும். அப்போ நம்ம பேஷண்ட் கிட்ட சொல்லிடுவோம், உங்களுக்கு ப்ளட் ப்ரெஷர் நார்மலாக இருக்குது, ஒன்றும் ஒரி பண்ணாதீங்க. பட் வீட்டில் போய் நீங்கள் செக் பண்ணுங்கள். சார் சொன்ன மாதிரி ஆல்ரெடி வீட்டில் பிபி மிஷின் வச்சுருப்பாங்க, அதில் போய் செக் பண்ணி ரெக்கார்ட் பண்ணி ஒரு 2 or 3 times செக் பண்ணி பாருங்கள். கூட இருந்ததுன்னா வந்து காட்டுங்கன்னு சொல்லுவோம். மோஸ்ட் ஆஃப் த டைம் பார்த்தீங்கன்னா வீட்டில் செக் பண்ணுற ப்ளட் ப்ரெஷர் 120, 80, 130, 80 தான் இருக்கும். வீட்டில் கூட எப்படி செக் பண்ண சொல்லுவோன்னா, நீங்கள் எப்போ ரிலாக்ஸ்டாக இருக்கீங்களோ அப்போ தான் செக் பண்ணணும்னு சொல்லுவோம். காலைல அவசரமாக ஆஃபீஸ் போகிறப்ப செக் பண்ணணும் அவசியம் இல்லை. சண்டே ரிலாக்ஸ்டாக இருப்பாங்க, அந்த டைம் செக் பண்ணோம்னா நார்மலாக இருக்கும். ஸோ ஒயிட் கோட் ஹைப்பர் டென்ஷன்கிறது என்னென்னா, வெளியே வரும்போது மாத்திரம் ப்ரெஷர் கூட இருக்கும், வீட்டில் இருக்கும்போது நார்மலாக இருக்கும். பட் அந்த மாதிரி இருக்கவங்களையும் ஒரு ரிஸ்க் ஃபேக்டர்னு இப்போ சொல்கிறாங்க. அந்த மாதிரி இருக்கவங்க கூட டென்ஷன், ஆன்சைட்டி, மன உளைச்சல் இருக்குதுன்னு சொல்கிறாங்க. ஸோ மன உளைச்சல், டென்ஷன்லாம் குறைக்கணும், நிதானம், பொறுமை, அமைதி இதெல்லாம் இருந்ததுன்னா ப்ரெஷர் கண்டிப்பாக குறையும். உப்போடு சேர்த்து நம்ம டென்ஷன், ஸ்ட்ரெஸ் எல்லாம் குறைச்சிட்டு அக்செப்ட் பண்ணிக்கணும். முன்னாடி எப்படின்னா ஒரு காலத்தில் ஸ்ட்ரெஸ் இருந்ததுன்னா நம்ம வந்து ஸ்ட்ரெஸ் இருக்கே நம்ம பயப்படுவோம். இப்போ எப்படின்னா ஸ்ட்ரெஸ் இருக்கா அதை அக்செப்ட் பண்ணி அதோடு நம்ம லைஃப் ரன் பண்ண கற்றுக்கிட்டோம்னா இந்த டென்ஷன், ஸ்ட்ரெஸ் வராது. டென்ஷன், ஸ்ட்ரெஸ் வராதப்போ ஆட்டோமேட்டிக்காக அந்த ஒயிட் கோட் ஹைப்பர் டென்ஷன் குறைஞ்சிரும். நாளடைவில் நம்ம பிளட் ப்ரெஷர் வராமல் நம்ம தடுக்கலாம்.
தேங்க்யூ சார், தேங்க்யூ, வெல் செட். இதே மாதிரி நம்ம வந்து பார்க்குறச்ச நிறைய பேஷண்ட்களுக்கு இப்போ டாக்டர் கிளினிக்கில் வந்து பார்க்கும்போது பிபி வந்து நார்மலாக இருக்கும். பட் அவங்க வீட்லேயோ அவங்க ஆஃபீஸ்லேயோ பார்க்கும்போது அப்படியே உல்ட்டாவாக இருக்கும், அதை விட அதிகமாக இருக்கும். நான் எப்போ டாக்டர்கிட்ட போனாலும் எனக்கு நார்மலாக தான் இருக்குது, பட் வீட்டில் செக் பண்ணும்போதோ இல்லை வேறு இடங்களில் செக் பண்ணும்போதோ எனக்கு அதிகமாக இருக்குதுன்னு சொல்கிற ஒரு குரூப் இருக்குது. அது கொஞ்சம் கம்மியான குரூப் தான். ஸோ இந்த மாதிரியான ஹைப்பர் டென்ஷன் வந்து மாஸ்க்டு ஹைப்பர் டென்ஷன் சொல்லுவோம். ஸோ அதை பற்றி சொல்கிறதுக்கு டாக்டர் எம் நடராஜ், ப்ரொஃபஸர் ஆஃப் மெடிசன், திருவாரூர்லேருந்து வந்திருக்காரு. சார்.
மாஸ்க்டு ஹைப்பர் டென்ஷன் அப்படின்னா யூஸ்வலாக பேஷண்ட்ஸ் நம்மக்கிட்ட வரும்போது பிபி நார்மல் லெவலில் இருக்கும். ஆனால் அவங்களுக்கு வந்துட்டு பின்னாடி அவங்க நார்மலாக பிபி ட்ரக்ஸ் எடுத்துகிட்டு இருப்பாங்க. பட் நம்மக்கிட்ட எப்போ செக் பண்ணாலும் நார்மலாக இருக்கும். பட் ஆனால் பார்த்தீங்கன்னா அவங்களுக்கு ஒரு டார்கெட் ஆர்கன் டேமேஜ் அப்படின்னு நடந்திருக்கும். டார்கெட் ஆர்கன் டேமேஜ்னால் எதர் ஹார்ட்லேயோ இல்லை ஒரு கிட்னிலேயோ ஏதோ ஒரு இடத்துல ஒரு டேமேஜ் ஆகிட்டு இருக்கும். நம்ம அது எவாலுவேட் பண்ணும்போது பார்ப்போம். பட் ஆல்வேஸ் நம்ம நினைப்போம் அவங்க கண்ட்ரோலாக தான் வச்சுருக்காங்கன்னு. இல்லை, வீட்டில் போயிட்டு அவங்க பிபி அதிகமாக இருக்கவும் நிறையா வாய்ப்பு இருக்குது. அது வந்துட்டு மாஸ்க் நமக்கு தெரியாமல் இருக்கலாம். இதை நம்ம இது பண்ணணும் அப்படின்னா ஒன்று ஹோம் பிளட் ப்ரெஷர் மானிட்டரிங் பண்ணலாம், இல்லை ஆம்புலேட்டரி பிளட் ப்ரெஷர் மானிட்டரிங் அதுவும் பண்ணலாம். யூஸ்வலாக அதை வச்சு வி கேன் ஐடென்டிஃபை. நம்மக்கிட்ட வரும்போது ரிலாக்ஸ்டாக இருப்பாங்க, வெளியில் போய் வேறு ஏதாவது ஸ்ட்ரெஸ்டாக இருப்பாங்க, ஃபேமிலி டென்ஷன்ஸ் இருக்கலாம். ஸோ இதனாலேயும் நம்மளுக்கு ஏறி இறங்குறனாலையும் அவங்களுக்கு நிறையா உறுப்புகள் பாதிக்கப்பட வாய்ப்பு இருக்குது. ஸோ இதையும் நம்ம ஐடென்டிஃபை பண்ணணும். நிறைய டைம் நம்ம மெடிசன் கொடுத்துட்டு அவங்க நார்மலாக இருக்காங்கன்னு மட்டும் விட்டுறாமல் அவங்களுக்கு வேறு எதுவும் பாதிப்புகள், உள்ளுறுப்புகள் பாதிப்புகள் ஏற்பட்டிருக்கான்னு பார்த்துட்டு அதை கண்டினியூஸாக மெஷர் பண்ணி அப்படி வீட்டுக்கு போயும் அவங்களுக்கு அந்த மற்ற கண்டிஷனால் ஏறக்கூடிய பிபியை கண்ட்ரோல் பண்ணுறதுக்கும் நம்ம வந்து மெக்கானிசம் அண்ட் மெடிசன்ஸ் அதுக்கு ஏற்ற மாதிரி அவங்களுக்கு அட்வைஸ் பண்ணணும். இதுக்கு மெயினாக வந்து இந்த 2 பிளட் ப்ரெஷர் மானிட்டரிங், ஹோம் பிளட் ப்ரெஷர் மானிட்டரிங் இஸ் எசென்ஷியல். சார் சொன்ன மாதிரி இன்னொன்று ஆம்புலேட்டரி பிளட் ப்ரெஷர் மானிட்டர் 24 hours போடலாம், வீக்லி ஒன்ஸ் போடலாம். இதை வச்சு நம்மளுக்கு அந்த கிராஃப் கொடுத்துரும். அதில் எப்பப்போ ரைஸ் ஆகுது, நார்மலாக ஒரு டிப்பு, நைட்டான டிப் இருக்கணும், அது இருக்கா இல்லையா, இதை வச்சு வி கேன் ஐடென்டிஃபை அண்ட் அட்ஜஸ்ட் த டோசேஜ் இந்த பேஷண்ட்ஸ்க்கு. இது நிறைய டைம் நம்ம பார்த்தோம்னா பிபி நார்மலாகவே இருக்கும், ஆனால் அதாவது டேமேஜ் வந்திருக்கும், அது இதனால தான் இருக்கலாம். ஸோ இதையும் நம்ம ஐடென்டிஃபை பண்ணி ஆகணும் பேஷண்ட்ஸ்க்கு.
தேங்க்யூ சார். யாருக்கும் வேறு எதுவும் டவுட் இருக்குங்களா? வேறு ஏதாவது கேட்கணுன்னு விரும்புகிறீங்களா? somebody can volunteer? Yes sir, please sir. Sir, give the mic to him. மைக் ஆன் பண்ணுங்க. எஸ்
சார், வெரி பேசிக் கொஸ்டின். நார்மலாக டாக்டர் கிட்ட போனால் பிபி செக் பண்ணுவாங்க 1 time. பட் இங்கே வரும்போது 3 times செக் பண்ணாங்க. வாட் இஸ் த பெஸ்ட் மெத்தட் டு செக் பிபி அட் ஹோம்?
டாக்டர் ரோகிணி மேடம்.
ஓகே, ஐ வுட் சே தட் இப்போ நம்ம வீட்டில் நம்ம செக் பண்ணுறோன்னு இப்போ நிறையா பேசணும். நம்ம ஹோம் பிபி மானிட்டரிங் அது ரொம்ப ரொம்ப முக்கியம். ஏன்னா எல்லார் வீட்லேயும் ஒரு பிபி அப்பேரட்டஸ் இருந்து நம்மளே செக் பண்ணுறது தான் அதில் எல்லாத்தோடையும் நல்ல வழி. நம்ம ரியலி ஒரு ஹைப்பர் டென்ஷன் இருக்கா இல்லையான்னு கண்டுபிடிக்கிறது. வெளியில் ஹாஸ்பிட்டலில் வரும்போது அது தனி ஒரு ஸ்ட்ரெஸ் அண்ட் ஸ்ட்ரெயின் நம்மளுக்கு இருக்கிறனால அது கொஞ்சம் அதிகமாக இருக்கும். அதனால தான் இங்கே உங்களுக்கு 3 தடவை செக் பண்ணி அதில் ஒரு மீன் எடுத்துருக்கலாம். ஆனால் நீங்களே உங்கள் வீட்டில் வச்சு ஒரு அப்பேரட்டஸ் வச்சு நீங்கள் எடுத்தீங்கன்னா அதுதான் ரியல் பிலீவபிள் வேல்யூ. அதுவுமே நீங்கள் எடுக்கும்போது ஒரு குவைட் ரூமில் ஒரு 10-15 நிமிஷம் ஒரு ஸ்ட்ரெஸ் இல்லாமல் நீங்களாக உட்காந்து ரிலாக்ஸ்டாக இருந்துட்டு அதுக்கு பிறகு நீங்கள் செக் பண்ணி அந்த வேல்யூ நீங்கள் ரெக்கார்ட் பண்ணிவிட்டு அதை நீங்கள் நோட் பண்ணி அதை ரெகுலராக வீக்லி ஒன்ஸ் அந்த மாதிரி எடுத்துகிட்டு பிறகு உங்கள் டாக்டர்கிட்ட நீங்கள் வந்து செக் பண்ணும்போது அதுதான் கரெக்டான வேல்யூ உங்களுக்கு வரும்.
தேங்க்யூ மேடம், வெல் செட் மேடம். வேறு யாராவது கேள்வி கேட்கணுன்னு விரும்புகிறீங்களா? ஸோ அப்படி இல்லைன்னா நம்ம வந்து சார் நம்ம நிறைய டைம் வந்து நம்ம பிபி பேஷண்ட்ஸ் வந்து நிறைய டெஸ்ட் பண்ணுவோம். அதில் பண்ணுற பிளட் டெஸ்ட் பண்ணுவோம், யூரின் டெஸ்ட் பண்ணுவோம், இசிஜி எக்கோ அது மாதிரி பண்ணுவோம். அதில் ஒரு டெஸ்ட் வந்து இந்த அல்ட்ராசவுண்ட் ஒரு இது ஒன்று டெஸ்ட் பண்ணுவோம். இல்லை சில டைம் பேஷண்ட்டே அவங்க அல்ட்ராசவுண்ட் பண்ணிவிட்டு நம்மக்கிட்ட கொண்டு வந்து காமிப்பாங்க. சார் எனக்கு பிபி இருக்குது, அது கூட எனக்கு இந்த லிவரில் வந்து ஃபேட்டி லிவர்னு சொல்லி எனக்கு வந்து சொல்கிறாங்க. ஸோ அப்படின்னோன்னா அவங்க நிறைய நம்மளுக்கு முன்னாடி கூகுளில் சர்ச் பண்ணி நிறைய விஷயம்லாம் தெரிஞ்சுக்கிட்டு தான் வருவாங்க அவங்க. ஸோ வந்துட்டு இது பண்ண ரொம்ப ஆங்ஸைட்டியோடு வருவாங்க. ஸோ அது மாதிரி வர்ற பேஷண்ட்டுக்கு என்ன பண்ணலாம்னு சொல்லிட்டு டாக்டர் ஏ அரவிந்த், டீன் ஓமந்தூரா மெடிக்கல் காலேஜ், மெடிக்கல் கேஸ்ட்ரென்டாலஜிஸ்ட் நம்மக்கிட்ட இருக்கார். அவர் சொல்லுவார்.
ஹலோ சார் சொன்ன மாதிரி ஃபேட்டி லிவருங்கிறத பார்த்தீங்கன்னா அது ஒரு டிசீஸ்ன்னு சொல்ல முடியாது, பட் குவைட் காமன். ஆக்சுவலாக பார்த்தீங்கன்னா நாங்கள் ஜிஹெச்சில் ஒர்க் பண்ணும்போது பார்த்தீங்கன்னா நார்மலாக மாஸ்டல் செக்கப்பில் மட்டும்தான் வந்து பார்த்தீங்கன்னா யூஸ் டு டூ அல்ட்ராசவுண்ட் அப்டமன் ஃப்ரீ ஆஃப் காஸ்ட். ரொட்டீனாக பேஷண்ட் வராங்க, ஒரு சிம்டம்ஸ் இருந்தாலும் அல்ட்ராசவுண்ட் பண்ணுவோம். பட் பார்த்தீங்கன்னா மாஸ்டல் செக்கப் வந்து ஒரு 250 rupees கொடுத்து பண்ணுவாங்க மினிமலி. அதில் பார்த்தீங்கன்னா மோஸ்ட் ஆஃப் தி பேஷண்ட்ஸ் தே ஹேட் ஃபேட்டி லிவர். சரிங்களா? ஸோ மெயின்லி டயட் ஹேபிட்ஸ்னால தான். காமன் திங் இஸ் பிகாஸ் ஆஃப் தி ஃபுட் தே டேக், ஜங்க் ஃபுட்ஸ். இப்போ சின்ன பசங்க பார்த்தீங்கன்னா ஒரு பக்கம் பெப்சி வச்சுக்கிட்டு ஒரு பக்கம் சிப்ஸ் சாப்பிட்டுட்டு தான் டிவி பார்ப்பாங்க. ஈவன் சில்ட்ரன்ஸ் இட்ஸ் வெரி காமன் நவடேஸ் மாஸ்டர் செக்கப்பில். ஸோ அதர் ரேர் காசஸ் வந்து பார்த்தீங்கன்னா அல்ட்ராசவுண்ட் பண்ணி பார்க்குற போது ஃபியோக்ரோமோசைட்டமா அந்த மாதிரி சில ரேர் டிசீஸில் கூட வி கேன் கெட் ஹைப்பர் டென்ஷன். சரிங்களா? ஸோ ஒரே ஒரு எக்ஸ்ட்ரா பாயிண்ட் வந்து கவர்மெண்ட் சர்வீஸ் ஃபார் தி பாஸ்ட் 36 years. இப்போ ப்ரீவியஸ்லி பார்த்தீங்கன்னா நம்மலாம் வந்துட்டு டாக்டர்ஸ் உட்காந்துருப்பாங்க, பேஷண்ட்ஸ் வருவாங்க, ட்ரீட்மெண்ட்டுக்கு வருவாங்க. இப்போ சார் சொன்ன மாதிரி ஒயிட் கோட் ஹைப்பர்டென்ஷன் எல்லாமே பார்ப்பீங்க. இப்போ ப்ரெசென்ட் கான்செப்ட் என்னன்னு கேட்டிங்கன்னா மக்களை தேடி மருத்துவம். Nowadays, we go to the patient, area divide பண்ணிப்போம், we go to the patient houses, we examine the patients. வீட்டிலே பிபி பார்ப்போம், வீட்டிலே blood sugar பார்ப்போம், anything we findனா அங்கேயே treatment is given free of cost. இந்த சிஸ்டம் வந்து தமிழ்நாட்டில் மட்டும்தான் இருக்குது. This is being praised by the WHO and our government got an award also for that. Thank you.
Thank you, sir. இப்போ பொதுவாக இப்போது ரீசெண்ட் டேஸில் பார்த்தோம், அதுவும் இந்த கோவிட்க்கு அப்புறம் நிறைய இது பார்க்கும்போது என்னென்னா நைட்டுன்றது ரொம்ப வளர்ந்துக்கிட்டே போகுது. இப்போது ஈவினிங்கிறதே ஒரு 10 மணி வரையும் இருக்கிறது ஈவினிங் மாதிரி ஆகிடுது. தென் நைட்டு படுக்க போகிறதே 12-1 மணின்றது ரொம்ப சாதாரணமாக. அஃப்கோர்ஸ் அவங்க காலையில் 6-7 மணிக்கு எழுந்திருக்கிறதுன்றது வேறு விஷயம். பட் அவங்க குறைவான நேரம் தான் தூங்குறாங்க. இது இல்லாமல் நிறைய டைம் நம்ம பேஷண்ட்ஸ் வரும்போது என்ன சொல்கிறது, பிபி கொஞ்சம் அதிகமாக இருந்துச்சுன்னா சார் எனக்கு சரியாக தூக்கம் இல்லை அப்படின்றதும் ஒரு காமனாக ஒரு கம்ப்ளைண்ட்டாக சொல்கிறது நிறைய டைம் நம்ம பார்க்குறோம். ஸோ இந்த தூக்கத்தினுடைய முக்கியத்துவம் என்ன, பர்டிகுலர்லி இந்த ஒரு பிபி இருக்கிற பேஷண்ட்டு, அதை பற்றி ப்ரொஃபஸர் ரங்கசாமி, ப்ரொஃபஸர் ஆஃப் மெடிசன், ஸ்டான்லி மெடிக்கல் காலேஜ் சொல்லுவார்.
குட் ஆஃப்டர்நூன் ஆல். தூக்கன்றது ரொம்ப ரொம்ப ஒரு முக்கியமான விஷயம். எஸ்பெஷலி பேஷண்ட்ஸ் வித் ஹைப்பர் டென்ஷன் குறைந்தது ஒரு 6-7 மணி நேரம் குறைந்தது ஒரு தூக்கம் கண்டிப்பாக தேவை. இப்போ உள்ள வாழ்க்கை சூழ்நிலையில் ஸ்ட்ரெஸ் அதிகமாக இருக்கிற சூழ்நிலையில் மினிமம் ஒரு 6 to 7 hours ஆஃப் குட் ஸ்லீப், அன்டிஸ்டர்ப்ட் ஸ்லீப் இஸ் வெரி வெரி எசென்ஷியல் டு கீப் த பிபி அண்டர் கண்ட்ரோல். அப்பார்ட் ஃப்ரம் தட் ரெகுலர் எக்ஸசைஸ், எக்ஸ்பர்ட்ஸ் எல்லாரும் சொன்ன மாதிரி ரெகுலர் எக்ஸசைஸ், cutting down the salt, very very important. Regular exercise minimum ஒரு நாளைக்கு ஒரு 40-45 நிமிடம், வாரத்தில் ஒரு 4 நாட்கள் அதை கடைபிடித்தாலும் போதும். ப்ளஸ் ரெடியூஸ் த ஸ்ட்ரெஸ் அட் தி மோஸ்ட் பாசிபிள் லெவல் அண்ட் a very good sleep. ஆக்சுவலி ஸ்லீப்புன்றது நம்ம நினைக்கிற மாதிரி பகல் தூக்கம், இரவு தூக்கம் ஒரு 6 மணி நேரம் குறைந்தது இருக்கிறதால் மிக மிக நல்லது. பிபி கண்ட்ரோலில் வச்சுக்கிறது. தேங்க்யூ.
Thank you, friends. I think now the public interaction is over. It is not the public interaction, only doctors to doctor interaction, because many of the people who are seated on the back row, I think some of them I have seen them also, but they did not raise any question. Venkatesh, do you have any specific question, Venkatesh? Why not you do that? Why not you ask? Ketach. Okay. Is there any question from other people?
So, avanga kekren.
Yeah.
எதனால் பையனுக்கு 25 வயசு ஆகுது, அவனுக்கு வந்திருக்கு எதனால், காரணம் என்ன கேட்கலையா?
Quick answer.
சீக்கிரமாக முடிச்சிடமா? சிறு வயதில் பிபி வரக்கூடாதுன்னு கிடையாது. அதை நம்ம தெளிவாக சொன்னது 25 வயசில் வர பிபி பிரச்சனை, அது யாருக்கு வேணாலும் வரலாம். அது முக்கிய காரணம்னா உப்பு, உணவு வகைகள், நம்மளோட உடற்பயிற்சி இல்லாமல், தூக்கம் இல்லாமல் இருக்கிறது. 25 பிபி வகைப்படும். காரணம் இல்லாமல் ஜெனட்டிக்காக வர்றது. இன்னொன்று உடம்புல இருக்கிற ஹார்மோன் பிரச்சனையால் வருது. ஹார்மோன் பிரச்சனையால் வர்றதான்றதை செக் பண்ணணும், அவ்வளோதான். மற்றபடி எந்த வயதில் வேண்டாலும் பிபி வரலாம்.
அதை தடுக்க முடியாதா? ஆரம்பத்திலே தடுக்க முடியாது.
ஹார்மோனும் கிட்னியும் ப்ராப்ளம் இருந்தால் பிபி ஏறலாம். அது தடுக்க முடியறதுன்றது ஹார்மோன் என்ன சுரக்குதோ அந்த ஹார்மோனால் ஏறுற பிபி, எந்த ஹார்மோன் என்ன கிட்னி பிரச்சனைன்னு கண்டுபிடிச்சி அதை நம்ம தடுத்துட்டோன்னா பிபி ஏறதை கட்டுப்படுத்தலாம்.
இப்போ அது மாத்திரை எடுக்கணுமா?
நம்ம கண்டிப்பாக எடுக்கணும். அது என்ன வகையான பிபின்றத மருத்துவ ஆலோசனை பெற்று என்ன கரெக்டான மருந்தோ அதை கொடுத்தா கண்டிப்பாக குணமாகும்.
சரி. இப்போ அவன் மேரேஜ் பண்ணோன்னா கஷ்டப்படுறான். இப்போ எனக்கு இப்போ இருக்கு.
இப்போ நம்ம எல்லாருமே இப்போ பார்த்தீங்கன்னா சுகர்ன்றது ரொம்ப காமனாக ஆயிடுச்சு. நீரிழிவு நோய் ரொம்ப காமனாக, அதே மாதிரி ரத்த அழுத்தமும் ரொம்ப காமனாக ஆயிடுச்சு. இப்போ இருக்கிற சூழ்நிலை எல்லாருமே அதான் சொன்னோம், ரொம்ப நிச்சயத்தன்மையற்ற ஒரு சூழ்நிலையில் நம்ம வாழ்ந்துட்டு இருக்கோம். இப்போ யாருக்கு வேணாலும் பிபி வரலாம். அதுக்காக பிபி இருக்கிறோம் கல்யாணம் பண்ணிக்கூடாதுன்னு இல்லை. நல்ல உடற்பயிற்சி, உணவு வழக்கங்கள் கரெக்டாக இருந்து மருந்து உட்கொண்டுட்டா எந்த பிரச்சனையும் வராது, இயல்பான வாழ்க்கையை வாழலாம்.
சரி சரி, தேங்க்யூ சார்.
I think Dr. Vasantakumar, Indian Society of Hypertension President, wants to talk. Please.
Thank you. I appreciate the patience of those of you who are sitting here who are not doctors. Because most of the times you don't want to listen to the doctors because doctors tell too many things and there is always a gap between the doctor and the doctors think that patients don't listen to the doctor. So this always happens, is it not? Can I see the people who are actually not doctors? Can you raise your hands? Thank you. So it's wonderful. So first of all, let me congratulate you for the patience that you have. The second thing is, now we talked so much about hypertension. So what is very important for you right now is, those of you who are young, please check the blood pressure of your own once. If it is normal, well and good, you don't need to check until another 6 months. And those of you who have blood pressure, who are already on medication or not on medication, keep checking it once in a way from nearby clinic, or many of my colleagues told about the availability of the home blood pressure monitoring, especially if you are in a combined family when there are 2, 3, 4 people. It makes sense to have the BP apparatus. And another thing is, all my colleagues are here who spent a lot of time for you. One thing, I'm also taking the opportunity to tell my colleagues that we always learn from the patients also. Every patient is different. I mean, we should not call him a patient now. You are coming to meet a doctor, whether you are educated or uneducated. Sometimes if somebody is educated, we take them granted that they will listen. No. Many times, educated people, young people, it doesn't enter there so easily, although the doctor thinks he has done the business or the advice. Otherwise, if you see the rural people, less educated people, sometimes they are better off. They listen to you carefully, they follow the instructions because they don't try to use their own brain too many times. So what I want to tell you is, please take things seriously, whatever has been told, and just try to see how you can help your society, your family, people around you. Some of you are living in community. Please spread this message to others because we are only 15, 20 people here. If you spread this message, the whole purpose of Dr. Narsingan and Dr. Chandrasekhan, all of us spending time here, it means a lot for all of us. So thank you for giving me this opportunity. Thank you, sir.
Thank you. When do you want to leave? When do you want to leave? 5 weeks. No, you can be here some more time. He's going to be here for some more time. I think we finished. So thank you very much, friends, for having accepted our invitation and graced this occasion. Please be seated. Wait for the interactive scientific program which is going to happen now for the next 1-2 hours or so. We will listen to our experts in various fields. I think some of our doctors are actually still enjoying the coffee and all. They are just gossiping. I think Gracie, can you just go out and call our friends, our doctors, because they recognize you more than me. So why not you go there and call them? No, everybody together. Yeah. Yeah. Call. Yeah, see me.
All right, thank you so much, doctors. Thanks for all the power-packed information sharing and knowledge sharing. I hope it was all useful to everyone present here today, both doctors and the non-doctors present here. So moving on, we're going to be having a few more interesting talking sessions. We're going to be having fireside chat sessions happening. But before that, I'm going to call up on stage a very important person among us today, Mr. Sachin Nair, the General Manager of Marketing, IPCA Laboratories Private Limited. He's going to come up on stage. Can we have him on stage with a huge round of applause, please? We'd like to have him on stage to welcome all the doctors.
Good morning, doctors. On behalf of IPCA Laboratories, I would like to welcome all the delegates and faculties for the Hypertension Awareness Program as a scientific event on the occasion of World Hypertension Day. It's my pleasure to extend a warm welcome to Dr. S.N. Narsingan sir, WHL Vice President, and also Dr. Vasant sir, ISH President for this event. In fact, and I also like to welcome all dignitaries of the Tamil Nadu chapter of Indian Society of Hypertension. We in IPCA are the leaders in the management of hypertension, having leading brands in and different antihypertensive molecules like clothianidone, CTD. We have got Blockpro, Bisoprolol, and a lot of other brands. At the same time, we also are the leaders and forefront in the management of hypertension and also do a patient awareness programs very often with the leading organizations across India. In fact, I would like to tell you that it's the third year we are doing this program with Dr. S.R. Narsingan sir for this WHL event. So I welcome all of you once again for this CME as well as patient awareness program. Thank you very much.
Thank you, Mr. Sachin Nair, for the wonderful welcome note ensuring the initiation of today's event. And moving on, I'm going to be calling up on stage once again our very special person with us today from WHL, Dr. S.N. Narsingan. Once again, is going to come up on stage and take over the academic session. Can we have Dr. Narsingan on stage, please? With a huge round of applause, ladies and gentlemen.
I think, can I request the audio-visual people to change the first program there? Can you do that? Well, now we are moving on to the scientific program. The first topic is going to be on obesity and hypertension. Are we underestimating? To deliver this lecture, may I now request Dr. S. Chandrasekhar, who is a professor of medicine and head of the Department of Internal Medicine, Government Stanley Medical College, and now he assumed office as the Secretary for the Indian Society of Hypertension, the Tamil Nadu State Branch. For this talk, may I have the pleasure of inviting Dr. Nambirajan and Dr. R. Kannan to the dais, please. Dr. Nambirajan and Dr. R. Kannan, please, to the dais. Over to you, Dr. Nambirajan, please.
So, very good morning. Dr. Chandrasekhar is a professor and HOD of Stanley. He doesn't need an introduction, so I don't want to waste the time. So he'll be talking on obesity and hypertension. Over to you, Chandrasekhar, sir.
Yeah, ladies and gentlemen, good morning to everyone. So today my talk is on obesity and hypertension. Are we underestimating? So first I would like to thank Dr. S.N. Narsingan sir for having me here. I'll start with a global scenario. So once it was thought as a small epidemic, I'm talking about the obesity, now it has reached a pandemic proportion. And we do have almost in some of the countries like 1/4 to 1/2 of the populations are suffering from a condition. Whether we call it as a condition or illness or disease, still a question mark. But this obesity is quite commonly prevalent in most of the countries across the globe. There are some alarming projections. So this is one from the World Obesity Atlas 2023. It says that so almost 1,249 million people are right now affected with obesity. The projections are a little bit alarming, and every 5 years you get 5% of the increase of this obesity population across the globe. The scenario is not so different or satisfactory when you see the trajectory of the Indian data. So again, not only in urban areas, but also in rural areas, we do have this problem of obesity. It doesn't spare any sex. Both men and women, both are affected. In fact, children are also affected much in the data surveillance done across the India. So I'm going to show some of the projections, like two studies which were done by Narang, to show the prevalence and determinants of hypertension in apparently healthy school children. Many times we assume that when a school children comes, we assume that they are normal. But this is a population-based cross-sectional study which was done in schools across 4 states, Haryana, Goa, and Gujarat, and Manipur, where almost close to 15,000 school children were screened, and they found a very alarming data. The overall prevalence of high BP, not pre-hypertensive kind of thing, high BP. So it's almost to 20% in boys and 26.5% in girls. So this is a very alarming data, because we think that like these are all the younger generations, I mean the future of India, like they have a condition called high blood pressure even at their adolescent age group. So this is quite a sad part of this study. And they have shown that the people, these children who are having the hypertension, they do have a lot of other comorbidities, particularly the weight part of it. Almost 75% of the children who are having high or high normal BP are either overweight or obese. So again, this makes us to think strongly. So we need to intervene, because our children are going to become the permanently they may harbinger of some non-communicable disease, mainly due to these obesity complications. So we do have any evidence. So this is again another elegant study from National Health and Nutritional Examination Survey. So they do periodically in United States, they do take the data of the US population, and they assess for the health and nutrition status. So this NANI study is being done at regular intervals. So we have got the 3rd edition of NANIs, which got released again recently, couple of years back. So to show that like how prevalent is this hypertension in different patients with a different BMI. So they have found that irrespective of the sex, with the increasing BMI, so the blood pressure goes up. So this is again another data. It's a large population-based study, lakhs of people. So the prevalence of high blood pressure in adult with a BMI more than 30 is 38.4% for men and 32.2% for women. So this is again, because the obesity is becoming a common menace in our society. So with the increase in the BMI, the likelihood of developing hypertension goes up. So this is again another study. We all talk about whether we should check the BMI, or BMI does not indicate the presence of fat which the patient has got. It does not indicate adiposity. So that is one has to remember. We all check BMI, but it does not indicate adiposity. The best indicator or best marker, anthropometric measurement which we can do is the waist circumference. So here is another study which is done again by Lu And he has presented a nice study wherein every 10 centimeter increment in waist circumference, and he related to the risk of developing a hypertension. So now let us see the results. For every 10, he has divided into 4 quartiles, and every 10 centimeter increment in waist circumference resulted in a significant odds ratio of developing hypertension. So this is again, it proves that the body weight plays a very important role in the pathogenesis of hypertension. So, ladies and gentlemen, we have learned certain things, that the continually increasing BMI, even in normotensive, may account for the increasing prevalence of hypertension. We all know that, and we have got ample data and study to endorse it. The one thing which we need to know, as far as we are from this part of the India, the association of the BMI and hypertension is stronger for South Asian population, even at lower cutoff points for overweight and obesity. So we do have a lower cutoff, we all know. 25 is the cutoff value for obesity, and we Indian, we do have 23 as the cutoff value for the obesity. So we have got even a lower value. Even at that lower value, we do have more exponential increase in the risk of developing hypertension. Lower body weight is associated with better longitudinal BP control. One good thing which we have learned again is when a person is obese, the risk is high. When the person brings down the body weight, the risk becoming lower. So we have got some ray of hope wherein how we can define it. Let us move forward. So I begin with obesity-associated metabolic disturbances. As I already alluded, it's a systemic problem. It affects almost all the systems in our body, starting with your mind, brain, your joints, your kidney, your lungs, your sleep, your skin. All these things gets affected. But our focus today is only on the cardiovascular system. So somebody is obese, they are of course at risk of developing atherosclerotic cardiovascular disease, hypertension. That's why I'm here today. And of course, it's a strong indicator of risk factor for atrial fibrillation. And again, recent data shows that obesity is an independent risk factor for the heart failure, as well as the hospitalization for the heart failure. So this is again another recent one which you have learned in the past. Let us see how this obesity and hypertension are interlinked. There are so many reasons. So something like a common soil theory, we do have so many factors which can cause both hypertension and diabetes. Somebody with unhealthy nutrition, physical inactivity, or somebody is having the adiposopathic insulin resistant in the muscle, in the liver, in the peripheral tissues. Somebody with sleep apnea, or somebody with some socio-economic stress. All these things could contribute to the on top of which we have some epigenetic factors also can play an important role in the causation of hypertension in patients with obesity. Let us move on to briefly pertaining only to the obesity part of it. Whenever somebody is having obesity, we literally mean that the increase in the fat mass, both in number as well as in size. So let us see what happens when it increases in size or in number. So that we call it as adiposopathy or fat mass disease. So let us see the complications one by one. So when a patient is having adiposopathy, that is called a sick fat disease. So we all know that a fat is a big endocrine organ. It secretes a lot of endocrine organs, and it is involved in these endocrine organs, hormones are involved in various pathways, various neural pathways and satiety pathways. So there are so many things are involved. Of course, there are so many hormones are also involved, like leptin, adiponectin, and P-peptide, so the visfatin, so there are resistin, there are so many hormones are also involved. So eventually what happens when there is a abnormal size of the adipocyte, when there is a abnormal adipocytes, that could result in various, not only the endocrine problem, but also the metabolic problem, which can result in elevation of the blood pressure, diabetes, and of course, the metabolic syndrome, dyslipidemia, and so on. At the same time, like there is another thing. So somebody is having a fat tissue, which is not only the size and number, so the mechanical effects of the fat mass. So many times we may not think about the mechanical effects of the fat mass. Of course, we all know that like it can cause joint degeneration or sleep apnea. It can aggravate or daily physical day-to-day activities may be limited if somebody is having a huge body weight with fat. So let us briefly see what does the fat mass disease can result in and how does it result in high blood pressure. We all know that like a sleep apnea, we have listened to Dr. Parati yesterday, like about how the sleep apnea is being implicated in patients with obesity. So another thing, postulation is, hypothetical thing is like the patients who are having a high fat, particularly the visceral fat, around the viscera, around the blood vessels, the abdominal fat, it can cause renal vessel compression. So what does it happen? When it happens, like it can result in impaired natriuresis and the patient can develop a high blood pressure. So not only that, it can also deposit it in the peripheral vascular. So usually the fat deposits around the vessel. So you are likely to get more peripheral vascular resistance also that can contribute to the causation of high blood pressure. So these are all some of the postulations. Of course, any patients with the adipocytes which are increased in number and size, there will be more work. You need more oxygen, more ATP, so the heart has to work more, your cardiac output goes up, your plasma volume goes up, and eventually it can result in high blood pressure. So what about the adiposopathy, which I already told that like a sick fat disease, where the interplay of the hormones and the free fatty acids and immunological mediators, which could culminate in high blood pressure. So these are all the factors which can be attributed to the causation of high blood pressure when they develop a sick fat disease. Like namely, it can result in increase in the free fatty acids, and it can also have leptin. So in fact, the patients with sick fat disease, they can have a leptin resistance. So that is the one like that is causing the problem with the patients with obesity. Similarly, reduced adiponectin, and more importantly, all these things, patient with obesity, usually they'll have a increase in the renin angiotensin aldosterone axis. Particularly, the sympathetic nervous system would be more active in patients with obesity. And of course, it can result in inflammatory milieu that can result in the endothelial dysfunction and that can cause decrease in the nitric oxide. So all these things like could contribute to the high blood pressure we see in patients with obesity. So this is what this slide again shows. So how this, the overnutrition or obesity, which could result in hypertension, but not only hypertension, but it's a component of the metabolic syndrome, what we see, the hypertension, diabetes, the central obesity, dyslipidemia, all these things, like even the obesity can cause dysbiosis, and that can mediate increase in the free fatty acids, and that can create a inflammatory milieu and can result in endothelial injury and free oxidant injury. So these are all the ways by which obesity can result in hypertension. So what is the recent concept we have? Like recently we have the role of the mineralocorticoid receptor activation in patients with obesity. So whatever the pathway by which this sick fat disease or the fat mass disease, like it again finally culminates in the activation of the mineralocorticoid receptor activation. So once the patient is having a mineralocorticoid activation, they can have more aldosterone secretion and more cortisol and more sodium and water reabsorption, and which could result in hypertension. So all these things, like because obesity is the center stage where it is surrounded by all the other factors, like you have a patient with obesity can have a diabetes, can have a hypertension, can have dyslipidemia, metabolic syndrome, all this. It's a complex. Of course, obesity, as I already told, like it's an independent risk factor for developing even a kidney disease. So the concept has been slowly changed, and it is drifted to a condition called cardiovascular kidney metabolic health, which we shortly call it as CKM syndrome. So what does this syndrome says? If somebody is having a no risk, I mean, where the stage 0, like where the patient will have a healthy life. So they need to have a good sleep, good maintenance of the body weight, good normal lipids, normal blood pressure, normal glycemia, and of course, their smoking cessation and regular monitoring of the BP. All these things are necessary. So we call it a stage 1. When there is a dysfunctional adipose tissues were present, they may exhibit a overweight or obesity, and they may have a pre-hypertension and pre-diabetes stage. Whereas in stage 2, they start exhibiting the risk factor to develop either a cardiovascular disease or CKD. Whereas in stage 3, like they'll have a subclinical CVD or subclinical CKD, and in stage 4, I will finish in 2 minutes. So stage 4, where they exhibit the overt CVD or CKD. So ladies and gentlemen, how do we tackle this menace of the obesity-associated hypertension? Of course, the physical activity, the lifestyle changes are the core. So they need to indulge in regular physical activity, of course, healthy lifestyles. Of course, on the pharmacotherapy part of it, we do have a lot of drugs, mainly the RAS inhibitors, AC inhibitor, ARB, CCBs, beta blockers. So that's not going to change, but the lifestyle measures are the more important thing. Of course, we do have challenges with even with the pharmacotherapy, like somebody with increase in the decreased natriuresis or increase in cardiac output. Obesity is one condition where the patient is likely to develop drug-resistant hypertension. So all these things which we see commonly in patients with obesity. Do we have any other choice? Like we do have some of the drugs which are quite promising in the recent days. Say for example, patients who are on liraglutide, sema or tirzepatide causes significant weight loss, and that has been clinically translated into reduction of the blood pressure, both systolic and diastolic. So we do have ample evidence, and we do have these promising agents definitely would change the picture in the future years to come. And do we have any other option? Like, of course, we do have bariatric surgery also. Once the bariatric surgery, there are many surgeries are there. Like we have the sleeve surgery, bypass surgery, Roux-en-Y, and all these surgery, like once it is done, once the patient begins to lose weight, at least 10% from the baseline, they will feel the need for reduction or tapering of the blood pressure medications. So there are some studies also which have shown that where 50%, close to 50% of the people, 46.9% of the people, where after the bariatric surgery, they were forced to taper, reduce the dosage of BP medications. So again, we do have some knowledge gaps, particularly the hypertension in the childhood and adolescent, and of course the long-term effects of these weight-losing drugs, and of course bariatric surgery. To summarize, excess weight gain is associated with visceral obesity, and that could raises the high blood pressure. And abnormal kidney function has got a key role in obesity-associated hypertension. And sympathetic activation is another key factor, like in obesity may be mediated by hypoxia, chemoreceptor activation, baroreceptor dysfunction, and adipokines. Of course, we do have some good medications right now available with us, such as lira or sema or tirzepatide may play a significant role in the management of obesity-induced hypertension. Thanks for your attention. Thank you.
Thanks, Chandrasekhar, for a lucid talk. You have taken us right from the physiology of the obesity to especially the cardiovascular complications, right from the atherosclerotic to hypertension and other things. As you said, it is not a simple weight, it's the adiposopathy, the new terminology, and all the pathophysiology you have mentioned. What is the shortest way to maintain the BMI? I think none of us in the crowd, only few percentage, less than 5% will be with the normal BMI. Hope Narasimhan sir would agree. None of us would be in the normal BMI range, sir, here. So what's your basic...
So I would like to, instead of medication, I would like to stick on to the lifestyle things. That is very simple, easy to practice, and it can be followed without any complications. I think we should stick on to the lifestyles. So we should come back to our the Pati Vaidyam, so-called. So we need to walk and take healthy food, regular exercise, sleep, smoking cessation, abstinence of alcohol. So I think all these things, of course, DASH diet, all these things definitely would help us to prevent or avoid complications.
Yeah, why
Of course, to maintain a BMI.
I think we can go in for a 2-time meal plan also. So unless why Gatlina obesity will kill us.
Okay. Thank you very much for the nice presentation, sir. Actually, obesity is a silent epidemic. We are all undergoing through the epidemic. Only thing is we have to prevent the complications. Sir has nicely illustrated all the important points. Now the topic is open for discussion. Any questions from the audience? If there are no more questions, shall we go to the next session, sir? Yes, sir. Thank you very much, sir. Thank you for the opportunity. We'll go to the next session.
Thank you so much, doctors. Thanks to our first speaker, Dr. S. Chandrasekhar, on the wonderful presentation. Moving on, we're going to be moving on to the second topic, for which I'm going to call the moderators first, Dr. D. Aishwarya and Dr. Aditya. I request you both to come up on stage. And the speaker for this particular topic, which is diet and life intervention, Tamil Nadu specific insights, is going to be Dr. M. Subhashri. Can we have her on stage with a huge round of applause, please? And also a huge round of applause to our moderators of this topic.
So thank you. So today's topic is actually very close to my heart. Like every intervention starts from the plate. My chief and my HOD always used to say. So I want to know more about these things. And to this thing, I want to introduce the Subhashri madam, who was no introduction is needed here. Like she's very famous and consultant. I even sent 3 to 4 cases, madam. They're very good. Now, she's a consultant nephrologist and transplant physician at Prashant Super Specialty Hospital. Over to you, madam.
Thank you so much, sir, for the kind introduction. And a very good morning to all. At the outset, I thank Professor Chandrasekhar sir for giving me this wonderful opportunity today. My talk is on diet and lifestyle interventions in hypertension. It's more of an English rendition of what we spoke over the last 1 hour with all our experts on diets. Nevertheless, it's always a delight to talk in front of all my teachers who have shaped my career over the last decade or so. So I'd be talking a little on why do we need diet and lifestyle modifications. I'll touch a little on obesity, the dietary interventions, lifestyle modifications per se. Enough has been heard regarding the prevalence of hypertension since yesterday, but what is important to notice is that the 5th National Family Health Survey and ICMR studies surveys have shown that there's a greater prevalence of hypertension in more developed states. What is more of concern is in the less developed states, there's higher prevalence of hypertension in young age. Hypertension is a major contributor of cardiovascular morbidity and mortality in India and worldwide. And that hypertension, the Ministry of Health and Family Welfare says, in the India, around 150 out of 1,000 population have hypertension as of 2024. So why do we need lifestyle modifications at all when we have a lot of drugs in our armamentarium to treat hypertension? It is still the primordial intervention to prevent and delay the onset of hypertension so that it reduces the cardiovascular risk and mortality. It is the first line of therapy still in patients who have got grade 1 hypertension. And medications get combined with your lifestyle modifications if the BP is not under control or if the patient presents with end organ damage, which would include your heart, kidney, or the brain. So in patients who have got high blood pressure, who have not got BP under control, don't just stick to lifestyle modifications and do not delay pharmacotherapy in these individuals. The implementation strategy, it requires training the clinicians to support patient lifestyle changes. When you have your patient in your OPD, sit and talk to them regarding to what is their lifestyle, what is the occupation, the family background, all those to be included. Obesity and hypertension, we thought initially obesity meant something like in the far end, but what is very concerning is we see obesity in children also in the current era. The obesity is again strongly linked with increased risk of hypertension, cardiovascular disease, and there are a lot of glomerular diseases also associated with obesity, and it is definitely an increased risk factor for mortality. Meta-analysis data states that the risk of hypertension is twofold in somebody who has got high BMI, waist circumference, or waist-hip ratio. It also adds to the risk of insulin resistance, diabetes, dyslipidemia, altogether called the metabolic syndrome. But what is important to notice is all these improve if the patient is going to resort to weight loss. So guidelines still recommend that weight loss is the first line non-pharmacological treatment in overweight and obese individuals. So BP reduction has a substantial impact on the, weight loss, as much as 10% of weight loss can help in reducing your BP by 3 systolic and 3 diastolic. The mechanism behind this, it decreases sympathetic activity, increases your insulin sensitivity. What is important to notice is not to go get yourself enrolled in crash weight loss programs. A sustained weight loss is going to be the key here. A gradual loss with a dietitian support is going to be associated with a better long-term outcome. So the effective strategies would involve calorie restriction. Of course, we have the drugs semaglutide, tirzepatide, etc. And we also have bariatric surgeries who are not going to be able to be treated with the above said strategies. So the outcome is that weight loss reduces the need of antihypertensives and also reduces the cardiovascular morbidity and mortality. Now, how do you advocate weight loss and hypertension? Integrate it in your daily lifestyle. Replace your, going to your first floor or second floor in elevator, switch it to walking the stairs. Start it early. And what you're going to aim at is a sustainable weight loss, by which I mean a modest long-term weight loss along with calorie restriction is going to be the key. Behavioral strategies will involve looking into what exactly is entering your plate and in the body, your mindful eating, all that is going to be a very integral part of weight loss. Target abdominal obesity. We need to apply ethnic-specific BMI and waist circumference cutoffs. By and large, all population waist to height ratio less than 0.5 is going to be the target. Personalized plans based on tailoring it to the age, sex, baseline weight, and most importantly, the comorbidities, where you also need the clinician's support and your dietitian's support. Leverage technologies. We do have a lot of apps, and it can be a simple task like text messaging your friend who's also in the journey of weight loss. So the target for Indian population is that a waist circumference of less than 90 in men and less than 80 in women, and a waist to hip ratio should be less than 0.9 in male and 0.85 in female. So what are the exercises that we need to resort to for treating hypertension and cardiovascular risk prevention? It needs to be started as early as possible, spanning from childhood to old age, as mentioned yesterday. And the benefits involve lowering BP is as effective as treating somebody with antihypertensive medication. It helps you improve the cardiorespiratory fitness and cardiometabolic health, reduces inflammation, thereby it impacts a lot of modifiable cardiovascular risk factors. Evidence states that one metabolic equivalent increase in your cardiorespiratory fitness decreases the hypertension risk by 8%. It can be any form of exercise, all form of exercise, right from aerobic, resistance, or isometric training. Exercise plus medication has an additive effect. It has a greater reduction in BP than compared to meds alone. So what are the exercise or physical activity recommendations for an adult ranging from 18 to 64? They should be active on all days of the week, 150 to 300 minutes of physical activity of moderate intensity or 75 to 150 of vigorous intensity. What is more important is combine it with resistance exercises such as your muscle strengthening. For older adults, again, what is expected is at least 30 minutes of physical activity every single day. If they're not able to resort to 30 minutes at the beginning, start with just 10 and then progressively increase. You need to incorporate different activities such as aerobic or endurance activities, resistance exercises. What is more important is flexibility activities such as yoga, tai chi, etc., and balancing activities, because these individuals are more prone for falls. Diet and hypertension. We all know the DASH diet and the Mediterranean diet, which is rich in fiber, fruits, vegetables, lean protein, low in salt, sugar, and saturated fatty acids. So these diets decrease BP and cardiovascular risk and also help you with better weight control. A lot of talk is about a vegetarian diet, that it reduces BP primarily because of the plant proteins, the glutamic acid, antioxidants, etc., which causes better vasodilation, insulin sensitivity, and gut microbiome. Omega-3 fatty acids, 2 to 3 grams per day, helps you in lowering your BP, triglycerides, and heart rate. So fish is always better than animal protein any day. Gut microbiome is another topic which has been of particular interest across various specialties, right from infectious disease, nephrology, cardiology, and it also is presumed to be having an impact on BP at the moment. A little emphasis on salt. lower dietary salt has been shown to reduce BP in hypertensive individuals as low as 5 systolic and 2 diastolic. But what is important is it also reduces BP in normotensive individuals. So it is always better to take lower salt even if you're not hypertensive. Now, how did we come to this conclusion? This study looked into a control diet which was low in fruit, vegetables, dairy and fat content which was similar to US diet. And then there's a DASH diet. And people were allowed to consume for 30-day period in random order of different 3 sets of salt. Now, DASH diet by default is going to help you in reducing the BP. But what is important to notice is that when a patient or when a person is on DASH diet plus also reduced salt intake, the relative reduction of BP was much more in patients who had very less salt intake. So if you're a salt enthusiast, you must be knowing about the Amazonian Yanomami tribe, these are people who depend on the hunter-gatherer diet, by which, they just take 0.25 grams of salt per day. Hypertension was a rarity in this population previously. But when we urbanized and exposed to high salt, they did suffer from hypertension and all of its consequences. So the key here is salt reduction. There's a lot of talk about salt substitutes in the market, which one to be taken, which should not be taken. So these are salt which contain low sodium and taste almost like your regular table salt. It does help in reduction of hypertension, stroke, and cardiovascular events. It can range anything from modified sodium chloride, organic or inorganic salts. The most commonly used one is potassium chloride, or it can be other taste enhancers or amino acids, etc. But what is very important about salt substitutes is the red flags. You have to be very cautious before you're advocating salt substitute. You need to know whether the person who is in front of you is a person with CKD or AKI, heart failure, somebody with diabetes, is the person on RAS inhibitors or NSAIDs, because all these people have an increased risk of hyperkalemia. This is a paper that we published a couple of months ago because diet in CKD population is always a problem. So if you're going to be somebody who's catering to the needs of a CKD patient in your day-to-day practice, I recommend you to look into this review article where we talk about the diet across ages, right from childhood to adulthood, and also across different stages of CKD, what should be the protein intake, salt intake, etc. Sugar and cardiometabolic health. The other white substance in our food is the sugar. We know it's mostly hidden in the processed food. It is linked with increased risk of hypertension, NAFLD, cardiovascular mortality risk. There is something called greedy gut effect. So if you're going to have a food that is rich in sugar and salt, there is increased expression of sodium glucose transporter expression in the gut and the kidneys, which worsens your BP and metabolic profile. And this is where your much proclaimed SGLT2 inhibitors come into play in reducing the BP and also kidney protection. So the recommendation is reduce or minimize salt as much as possible in its raw form or in processed food. Fiber intake and blood pressure. The fiber is mostly found in your whole grains, fruits, vegetables, etc. Evidence states that fiber helps you reduce a little bit of your systolic BP by around 1.3 millimeters. A high fiber diet does reduce all-cause and cardiovascular mortality by 30%. The mechanism behind it is that when there is fiber, the gut microbiota act on it and produce short-chain fatty acids. These SCFAs promote vasodilatation and help you in lowering the systolic BP. So the recommendation is somewhere around 25 to 29 grams per day has greatest risk reduction. The dose response benefit has an additional cardiovascular and BP lowering benefit if the intake is going to be more than 30 grams per day. Alcohol and blood pressure. We did have a small snippet in the morning during the discussion. Hypertension risk with any amount of alcohol, BP, the risk of hypertension increases in men. In women, if it's going to be more than 2 drinks per day. Binge drinking is something that is significantly associated with high BP. So reducing alcohol consumption does have maximal benefit if somebody is going to be used to more than 6 drinks per day. Again, there's no safe limit. Light or moderate drinking, which was previously thought to be protective, is not currently thought so. Any amount of alcohol increases BP. So the best practice is zero alcohol. If consumed for men, it should be less than 2 standard drinks per day. For women, less than 1. And 1 standard drink is 10 grams of alcohol. Strictly avoid binge drinking when you're partying. And always remember, no amount of alcohol is considered completely safe. Now, you're not used to alcohol. What about the non-alcoholic beverages and blood pressure, the coffee, tea? 2 to 3 cups of coffee or tea helps you reducing in stroke and dementia risk. But anything beyond 2 cups increases the cardiovascular mortality in somebody who has already got grade 2 or grade 3 hypertension. The other beneficial beverages would include beetroot juice, which reduces the systolic BP, predominantly because it contains nitrates. The other beverages could include hibiscus tea, pomegranate juice, and cocoa. Avoid at all costs your energy drinks, which gives you a sugar, like a spike in sugar at that moment, but also increases your BP, your heart rate, metabolic strain. Licorice root tea is something also is associated with high spikes in systolic blood pressure. So 3 to 4 cups is fine, or safe or moderately beneficial. Add nitrate-rich beverages, which includes your beetroot or pomegranate juice. Intermittent fasting, another lifestyle which a lot of us are trying to resort to. The potential benefit is that it triggers metabolic switch to ketone production. So it decreases the sympathetic activity, decreases inflammation, and improves glucose regulation. It may help in reducing the BP and body weight. Now, what is the evidence with regards to intermittent fasting is that we just had Ramadan a month ago, and what it is also a form of intermittent fasting that these people resort to. So there is decrease in BP in post-Ramadan in patients who are already diabetics, hypertensive, and normotensives. But remember, it does not change BP in somebody who has already got chronic kidney disease. So does it fare well compared to a calorie restriction? No, the difference is not so very significant. And but there's no major harm in patients, renal harm in patients who are already falling in moderate risk groups. But remember, we do not have long-term data at the moment, and it is not yet proven safe in high-risk individuals such as end-stage kidney disease or somebody who has got uncontrolled hypertension. Stress and sleep, which is a luxury at the moment, a lot of us cannot afford to. Stress reduction techniques, at least 3 hours per week, is something that we all need to have it in a daily planner per se. Alternatively, a 45 minutes yoga or a meditation could help you as well. Or a simple task of like listening to music 25 minutes a day can also help in reducing stress. Sleep. Weight management is very important because we know patients who are obese are going to have OSA, which leads on to hypertension. So duration of sleep should be optimal, 7 to 9 hours per day. Sleep hygiene. Do not have anything on your bed, especially your laptop or your cell phones when you're going to sleep. And stimulus control techniques. If you're not going to sleep for the next 20 minutes, get out of the bed and then start doing something till you feel the urge to sleep again. Restrict daytime naps. Also ensure that shift workers also have a good amount of sleep cycle on their day-to-day lifestyle. Sleep disorder is something that, as Sir mentioned previously, is something that has to be looked into, in especially somebody who's presenting with resistant or nocturnal hypertension. Smoking and hypertension, smoking causes acute BP spikes. It's an independent risk factor for cardiovascular disease and atherosclerosis, causes white coat or masked hypertension. But what is very important to note is that e-cigarettes also raise BP. It's not a safe alternative. Behavioral interventions, digital health and hypertension. A lot of people here must be wearing a smartwatch or a fitness watch. So we need to have all these digital health also incorporated in our daily lifestyle. Self-management in terms of mindful eating, what you do on a day-to-day basis in terms of physical activity. Oral hygiene. Chronic periodontitis is something that is associated with hypertension and even kidney diseases. So all this have to be looked into. Your digital health tools such as your wearables, apps help you in personalizing care. But always remember, when you put in money to buy your gadgets, that they're actually validated. Nevertheless, a clinician's involvement is essential. It does not replace a technical support. So to conclude, with regards to dietary and lifestyle modifications, we need a patient-centered and collaborative approach, use of digital tools in terms of managing physical activity, body weight, food and drinks, body and mind, and finally other factors also. So that's the summary slide of which I spoke for the last 10-15 minutes or so. Thank you very much. I'll be happy to answer any questions.
It was really an excellent presentation, madam. Just one small doubt I have, madam. Recently, this intermittent fasting and cardiac risk, that paper has been came in the AHA. So regarding that, any clarification, madam? Intermittent fasting, if we do, means they have the advanced glycation end products, and patient can be having the cardiac risk. Patient has brought me to the thing. Any idea regarding that, madam?
So intermittent fasting is something like basically you restrict the calories per se. Okay. Though we do try to incorporate intermittent fasting, all these lifestyle modifications actually should be done after consultation with the clinician is what I strongly believe in. Even if you're going to go to the gym, even if you're 25, doing a baseline test of what's your BP, what is your creatinine, all that is very essential. That's one. Now, though I said that post-Ramadan, the BP actually falls down, that is exactly when we see patients coming with recurrent episodes of acute pulmonary edema. Now, that's because when they break the fast, it should be a nominal diet. But what a lot of people do is they start binge eating and there's a lot of salt in the food that they consume. So it does probably impact the cardiovascular status of the patient is what I feel.
Thank you for this very beautiful lecture, ma'am. And what I would like to ask regarding micronutrient deficiency, like most of us, whether we are malnourished or overnourished with macronutrients, when it comes to micronutrients, almost all of us are deficient. So how do you use vitamin D or folic acid or any other micronutrients like B12 or whatever in your practice when it comes to controlling hypertension? Like how do you look upon that?
That's quite an interesting question because, by default, I do not prescribe any macronutrients to any of my patients because your diet, a balanced diet is always better than any of these products to begin with. That's one. But if you look into this micronutrients, the calcium, magnesium component actually has an impact on the systemic vascular resistance, in turn the BP also. So one such component is magnesium. So if the magnesium is not enough, then we try to tell them to take it in the dietary form to begin with, because it helps you to maintain the vascular, the elasticity of the blood vessels, which in turn impacts the blood pressure. That's one. The other thing is, especially at least in patients who have got CKD, like yesterday OSP is talking about, does addressing the calcium actually help in patients who have got high BP in CKD? The damage has already happened in the vasculature because there's already stiffening of the vessels and all that. So it may not have a major role per se. So in the bottom line would be, if you're already a healthy person where you're trying to address the micro and macronutrients at the primordial level, it should happen in your diet per se, in terms of your nuts, seeds, your whole grains, fiber, all that. If it's not sufficient, then probably you need to change your cook or the way that you cook in your home. If that is still not sufficient, then probably yes.
If any of you have any questions.
Yeah.
Yes, sir.
I think it's a very good lecture for me. Hello. I think how are you going to implement to the population? See, 70% of the people are low-income group. They can't get more than rice. You think they can get a lot of vegetables to eat? Most of them take liquor. How are you going to implement all your schemes into the public? Because hypertension is a very common in the low-income group. They just earn money for the living, but half of the living they send it for alcohol. Government gives 24 kilos pre-rice. That's only staple diet they take. All your micronutrients, your salt restriction, your fruits consumption. Is it how are you going to put it to the public? As a doctors, what you have to tell the society, to the government, to implement on one side we are giving all tablets to control hypertension. On the other side you are opening up all the things, and then how is it going to matter? See, it becomes more theoretical. It's only apply for 5% of the population, maybe like doctors or senior group of people. We all talk about the lifestyle modification, this, that, diet, exercise. But practically, if you're a minister, what are you going to do?
That's an excellent perspective, sir, actually. And your point is actually well taken. I think we need to start more of public education to begin with, because the amount of spend on alcohol, it has like, there's absolutely no nutrients or micro or macro whatsoever. There's no calories involved. So probably we need to start with public education to begin with. That is one thing. And as I mentioned earlier, at least in CKD population, where the general notion is that you need to reduce a protein intake. In somebody who has got kidney disease, that's not the scenario in Indian setup. So educating your fellow specialty friends and your patients with regards to what exactly should be the diet tailored to your needs has to come from every individual physician to begin with. And in terms of health policy, I believe, I think a couple of days back, the Tamil Nadu government has actually come up with a scheme where they actually incorporate protein intake, provide at free of cost for patients who are on dialysis. The general notion is not to take protein, but a simple policy of just adding a couple of boiled eggs or a glass of milk, we believe it's going to change the lifestyle in a big way for at least for the CKD patients.
Okay, we had an excellent discussion. So thank you, madam. We'll close the section. Thank you.
Thank you.
Thank you so much, Dr. M. Subhashri, on educating us with diet and thanks to our moderators as well, Dr. Aditya and Dr. Aishwarya. Moving on, we're going to be having the third panel discussion right now, for which I'll call upon stage the speaker, Dr. K. Kannan, and the moderators for this topic is going to be Dr. I. Rohini and Dr. M. Natraj. Can we have all three of them on stage, please?
Good afternoon, friends. Today, I'll try to make it as brief as possible. We are going very late. So, this is how our points to consider. What are the challenges of hypertension and heart failure? How it evolves, and how it starts, how it goes, and how we start with the preserved ejection fraction and the transition occurs to a reduced ejection fraction. What you do to prevent this transition and progression to heart failure. And what are the target blood pressure targets, what has been set recently based on guidelines in the J curves? What are the vulnerable groups which you should take more care? What are the guidelines of the ECC and ESC and ACC and the Indian Society, and how concluding remarks? So basically, to understand hypertensive heart disease, it's very important to know that it's a constellation of structural and factual changes and three components, both the ventricle, the atrium, and the coronary arteries. So phenotypically, if you see heart failure, we have systolic or diastolic, or you have a no heart failure or heart failure, endothelial dysfunction, and also you have the other main conditions like atrial fibrillation, arrhythmias, which can contribute and worsen a heart failure, and LVH as an entity by itself. And you should always know that strict control of blood pressure is going to reduce the morbidity and mortality with these heart failure patients. So among the heart failure patients, you say, if you take hypertensive heart disease, accounts for 1/4 of heart failure patients. So this is a bigger challenge in women. And if you take the SPRINT trial, is one trial which has shown that strict control of blood pressure or a more intensive control of blood pressure goes a long way in lowering the incidence of heart failure. And effective hypertension management can reduce 64% reduction in the incidence of heart failure, which shows that we should be very careful to diagnose and treat. So hypertensive heart failure is in acute form, we see as acute pulmonary edema, is predominantly redistribution. So when a patient comes with a pulmonary edema with a raised BP, your requirement of diuretics is less. You should concentrate more on vasodilators and reduce the blood pressure so the sympathetic drive will come down. And so if you also know that in the hypertension registries, heart failure was there in 11 to 23% of the patients had elevated blood pressure. So it's not very uncommon to have a patient with hypertension with heart failure. So initially the hypertrophy is concentric. And so it interferes, if you see the relative wall thickness, you can say it's a concentric or an eccentric type of hypertrophy. But if it is not controlled, BP is not controlled, or if there is a sense of comorbidities like an obesity, older age, concomitant diseases, and then it moves more to an eccentric hypertrophy. And also you should remember that besides LVH and diastolic dysfunction, other pathological factors in the vascular system, starting from the arteries to the capillaries, also play a role. So as you can see from the slide, you start off with a concentric hypertrophy, and then it slowly moves to an eccentric hypertrophy and systolic heart failure. And based on that, Maselli has classified into degrees of hypertensive heart failure. If you have first stage, if you stage degree 1, you have no hypertrophy, but you have LV dysfunction. Then you have an LV diastolic dysfunction and LVH. And then you have clinical heart failure with preserved ejection fraction. And last, you have an reduced ejection fraction. So during the cycle of evolution of the hypertrophy from the concentric to the eccentric goes the worsening of heart failure. So you look at the relative wall thickness and you say 0.42 less or more than 0.42. You measure the posterior wall to the LV capital thickness. And there are some patterns of LV which occurs in particular groups of patients. For example, one which is all black and yellows are all patients who have concentric hypertrophy pattern. One which has got in blue are all eccentric pattern. For example, coronary disease and obesity will have more of eccentric remodeling, whereas the other patients with isolated systolic hypertension, female and blacks, go for a concentric hypertrophy. So why this LVH occurs is just based on the Laplace law. That is, if you want to have the compensation for the increased LV tension, it's only by the muscle thickness, and which leads to a concentric LVH. And not only it's a muscle, the interstitium also becomes thickened. So there's a mismatch between the ischemia, mismatch with the circulation, leading to ischemia and fibrosis. And also, because of elevated LV and diastolic pressure, there's left atrial dilatation, fibrosis. There is also predisposed these patients to atrial fibrillation. And the coronary flow is also reserved, it also comes down due to the changes in the vasculature and perivascular fibrosis, small vessel narrowing, endothelial dysfunction. Every part of the vascular tree, it contributes to the diastolic dysfunction which these patients undergo. There are also other changes which occurs, not just LVH. You can have even the twisting motion of the LV, which we measured with the strain imaging. That also goes down. And peripheral vasorelaxation also plays a role. So it's not just confined to the LV, it's confined to the vascular tree as such. As we initially discussed, all the three components contribute to the hypertension heart disease. So that once it goes from there, then the transition occurs from a heart failure which is LV concentric to an eccentric, and this occurs even at the molecular level, where the mitochondrial system, angiotensin 1, and oxidative damage, shear stress, everything contributes, which becomes from the concentric, it goes to LVH. And the most important thing which contributes is the cardiac fibrosis. It plays a central role in the loss of contractile function. And there are other components of neurohormonal imbalances, immune responses, gut microbiota, and also metabolic dysfunction, which occurs in the LV, which all contributes to the transition concentric to an eccentric to an LV dysfunction. So this RAS plays a very important role because initially it may be helpful, later it contributes to the detrimental stage and also promotes the same pathway also promotes apoptosis. And then you have the role of reactive oxygen species, which also increases oxidative stress. So another important component which plays a role are the roles of natriuretic peptides and the catecholamines, both of which becomes overstimulated, associated with neural hormonal dysregulation and water and salt retention. It leads to a progression of cardiac injury, which loss of myocytes, fibrosis, change in LV function will shape with dilatation, reduced efficiency of myocardial contraction, and finally to heart failure with reduced ejection. This is a summary of what is the transition occurs in patients with hypertensive heart disease. They go from a thickened heart to an eccentric hypertrophy and heart failure. So most patients with concentric hypertrophy develop heart failure, preserved ejection fraction. But despite the absence of myocardial infarction, some can progress to reduced ejection fraction. This is what is one takeaway. Then the changes in the heart failure preserved ejection fraction is changes with the extracellular matrix also that cause fibrosis of myocardium and then the LV thickness. It is possible for some patients the eccentric hypertrophy can progress to heart failure preserved or reduced ejection fraction as well. And the epidemiological studies have shown that risk of heart failure was increased twofold in hypertensive women and threefold in women, with hypertension accounting for 39% of heart failure cases. But what is more important is the prevention and accurate treatment of hypertension and other risk factors was associated with 35 years heart-free survival in men and women respectively. It is very, very important. If you control well with the risk factors, you have 35 years heart-free survival, and in subjects over the age of 45 years, and 86% low risk of incident heart failure across the remaining life course. So it's not just confined to the initial part, it's also a memory effect which can help you with prevention. So there are some vulnerable groups which is important to know with these group of patients need to be treated aggressively. So first you should do is patients who have got LA enlargement in the absence of mitral valve disease could be a marker of diastolic dysfunction. You look at biomarkers like uric acid, metalloproteinases, natriuretic peptides. They also predict the patients who are going to go for heart failure. And for every 10 millimeter reduction systolic BP, the heart failure declines by 12%. What is more important is, even population-based studies, we are reduction of BP by 2 millimeters. It has got so much impact in overall reducing the mortality and morbidity of heart failure. So there is no specific class of drugs which is used in prevention. All drugs which lower BP have got a role in prevention, those specific class, but as per guidelines, they should be followed. So these are the group of the landmark trials which has tell us why heart failure treatment is important. So first study was cardiologist, which in non-diabetic hypertensive patient, you reduced by less than 130 millimeters, and compared to the usual 140, you got a better reduced incidence of study outcomes. And then the next one, during ACCORD, which is a major trial, where you took diabetic patients with high cardiovascular risk, you looked at BP targets less than 120, they had neutral effects compared to standard therapy. Then you have CHARM Preserved trial, where you used a BP target of less than 130/80. What you do attain is reduce hospital admissions in chronic heart failure. And the ALDO diastolic heart failure trial was used for lowering BP less than 130, but improves the diastolic function. Then the SPRINT trial, which was done in non-diabetic persons with intensive antihypertensive therapy, significantly reduced the composite endpoint of myocardial infarction, acute coronary syndrome, stroke, heart failure, and cardiac death. So these trials have, this has led to the STEP trial, where the patient was used in elderly patients more than 60 years, and you reached a target less than 130/80. These group of patients are also benefited with lowering of therapy, which shows that irrespective of the category of patients, diabetic, non-diabetic, elderly, young, all these patients, definitely control of blood pressure goes a long way in the prevention of heart failure treatment. So targets of treatment, the heart failure have reduced and preserved ejection fraction system. The BP thresholds and targets do not differ. What is recommended, the standard is recommended for all. There are some conditions where you present low BP that may indicate an advanced heart failure condition, with a poor prognosis being a surrogate marker for a severe LV dysfunction, low cardiac output in heart failure with reduced ejection fraction. In patients with, if your patients are behind hypotension, whether asymptomatic, you're treating heart failure, reduced ejection fraction, there's no need to reduce the dosage. But if you have a symptomatic and severe persistent hypotension, decreasing the dosage is recommended in this group of patients. So European guidelines and US guidelines have recommended a BP target less than 130/80 with a word of caution with a BP less than 120/70 for hypertensive patients at risk of heart failure. So your targets for this group of patients between 120 to 130. And caution, elderly people is recommended, but if a target of 130/80 is well tolerated, you look at 130/80 in this group of patients as well. So whenever you're targeting hypertension, you're looking at the morning BP. You look at morning BP less than 135/85, but then you also have to control nocturnal blood pressure, the step 2, where you have to look at the salt. Is there a circulating volume is more? Is the vascular disease is more? Is the obstructive sleep apnea contributing or insomnia contributing? So night blood pressure, you try to make it as less than 120/70. This is the only way. You just not just control of daytime BP. You have to look at the nighttime BP as well to control blood pressure. This is a spectrum of patients that we see. Though we use the 4 pillars for all, there are some special categories. You have atrial fibrillation, those who have increased heart rate. The treatment changes in this group of patients, and the intensity of the treatment also has to change. So there are some group of patients we don't control, but in this reduced ejection fraction, what is preferred, doxycycline is preferred to even a calcium channel blocker, and that is the one takeaway message of the JACC. So that's what I like to say, and this is combination of drugs. During the treatment, you have to see what type. You use the standard drugs, then you use a diuretic, and then you do different class of drugs depending on percents or reduced ejection fraction. So points to systolic or diastolic BP, contraction abnormalities, atrial fibrillation, and coronary artery disease. We have to always ponder in during the treatment. Risk factors of hypertension, duration of hypertension is very important. Old age, male sex, obesity, diabetes. The management focuses on strict BP control with lifestyle modification and treatment of comorbid conditions. Prognosis depends on the degree of hypertrophy and cardiac dysfunction. And eccentric versus eccentric has been greatly discussed. And this was the takeaway. You have hypertension, you can either go for a concentric hypertrophy or an eccentric hypertrophy, and depending on symptomatic, this transition can occur plus or absence of MI. And when you have a myocardial infarction, if you have a size of more than 40%, you have 60% where the prognosis is really bad, and you can have a markedly decreased cardiac output in this group of patients. So the revised recommendations that if you look at in patients with symptomatic heart failure with reduced ejection fraction, lowering effects are recommended to include outcomes are ACE inhibitors, if not, and if ARBs, RNAs, beta blockers, mRNA, SGLT inhibitors in this group of patients. In patients with symptomatic heart failure with reduced or ejection fraction or mid-range ejection fraction, BP lowerings to improve the outcomes, you will take is all the 4 categories. And then if the patients with symptomatic preserved ejection fraction, SGLT inhibitors are given the only drugs in addition to diuretics which are given class 1A indication. So RNA has been demonstrated to have the greater BPL effects. In preserved ejection fraction, SGLT inhibitors have maximum effect. RNA has only reduced death and hospitalization. Heart failure reduced ejection fraction, mostly the hospitalization reduction is a major way it acts. In reduced ejection fraction, all 4 pillars are being used. The newer drugs that we have in this basket are Finerenone, and based on the DKD study and the heart failure study, has shown that in heart failure, which is greater than EF greater than 40, it reduces the first hospitalization by 22%, cardiovascular deaths or first heart failure hospitalization by 17%, and cardiovascular death or recurrent hospitalization 18%. So this is one of the newer drugs which has been used in heart failure with preserved ejection fraction. The dual ET receptor antagonist, small interfering RNAs, and selective aldosterone inhibitors are newer drugs. And then you have a flash pulmonary edema in a patient with, as we already discussed, what is more important is to reduce the afterload, and because all of this contributes more to this pulmonary edema. So this is what is the summary slide of hypertension heart failure. Multiple factors play a role. You have mass, you have stiffness, you have RV hypertrophy because of the pulmonary hypertension. Then you look at the preserved ejection fraction, all the risk factors that role. It's a multi-system disorder which requires special attention in all aspects. Thank you so much.
It was very Yes, you did finish in a very short period of time and ran through the entire details. We were running to catch up literally. So very beautifully put up. And I like the fact that how you stressed on diastolic dysfunction, because we get to see that so commonly in the wards. And not much importance used to be given in earlier days. And now we know that we need to chase this as well, especially when you check for LAE. Like what you stressed in the ECG perhaps, or even later on an echocardiogram, and ECG is more easily available to us, wherein we can check on this and we can catch the LVH at an earlier stage and ensure that we prevent further complications. Thank you very much, sir.
So a nice, quick and extensive talk on the heart failure, sir. Your doubts are actually a patient who is euglycemic and who is hypertension. Initially, he had diastolic dysfunction with heart failure, preserved ejection fraction. After strict control of BP also, he landed later in a reduced ejection fraction. What could be there? Anything like metabolic memory watch we talk in diabetes, anything?
See, hypertensive heart disease, if you see, it is the progression that we show, 2 things we played a role. One is the role of the other risk factors, and then the persistence of severe hypertension. Both can take a heart failure LVH to a reduced ejection fraction. If other risk factors are operating, definitely that could have occurred. Otherwise, if you have strict control of blood pressure, the progression is very...
So not a diabetic, sir, not a diabetic. But mild obesity is there, mild obesity. But he landed up in reduced ejection fraction.
They have taken 7 risk factors, they have studied actually, 7 risk factors associated. One of them is obesity. See, all these risk factors can operate independently or in addition to the hypertension, with hypertensive heart disease. One of them is obesity. Okay. So that itself can play a role in reducing the ejection fraction to a slight extent. But if strict control of hypertension, the recommendations are based on evidence how you had a regression of, we have not got a regression of LVH in all patients. If you see even LVH treatment hypertension, we see so many patients, we don't have a regression of LVH in all. we say probably the nocturnal BP was not controlled, or he had an obstructive sleep apnea and everything. So this signs of progression is based on what is evidence, what we are doing for treating patients with heart failure. And so that's what is more important takeaway is you do an echo for these patients and just see the posterior wall thickness and compare with the LV cavity. You keep a ratio of 0.42. If less than 0.2 means these group of patients are slightly worse prognosis in terms of arrhythmias, heart failures, and events. So this is a very simple echo. You take a short axis and you take an image and keep it. That is number one. Number two is you look at the entire risk factor profile. That is what is very important. When you control hypertension means you control all the other risk factors. And then the control of blood pressure, you look at the assessment at daytime and nighttime. Both should be assessed by an ambulatory PP to say it's really under control. And then you have to look at, is the patient on an ideal combination of drugs? Because there are so many comorbids we discussed, atrial fibrillation. Patient may have low heart rates, patient may have COPD. So this is on the right combination of drugs. If he is on the right combination, you control the comorbidities, you got the BP well under control, ideal drugs, disease modifying drugs, scientifically evidence proven drugs, then the chances of progression is slightly lesser than what you would otherwise have.
Fine, sir. Over to the floor for any questions.
Thank you.
See if there is no questions, we will close the session. Thank you, sir. Thank you very much.
Thank you, doctors, and thanks, moderators. It was an extensive work, I should say. Thanks to Dr. Kannan once again. Moving on, we're going to be having the last panel discussion of this particular session, for which I would like to call upon stage the speaker, Dr. P. Parandaman, who is going to be talking on management of hypertension in pregnancy. And the moderators would be Dr. Prince Pius and Dr. P. Ravichandran. A big round of applause to all three of them, please.
So topic is management of hypertension in pregnancy. The speaker is none other than our Parandaman. He needs no introduction. This hypertension in pregnancy depends on the type and severity, maybe a pre-existing hypertension or gestational hypertension, or maybe eclampsia or pre-eclampsia or superimposed, many types. So let us hear from Dr. Parandaman. Yes.
Good afternoon, sir. Thank you, chairpersons, for the wonderful, good introduction. At the outset, I'd like to thank Professor Narasimhan, sir, having given me this wonderful opportunity to talk on hypertension in pregnancy. My outline of talk presentation will be, what is hypertension? What are types? Management, what is the management principles? And anti-hypertensive drug medication, non-pharmacological medications like lifestyles, and of course, novel therapies in management of pregnancy hypertension. By definition, the pregnancy hypertension or hypertension pregnancy requires at least 2 elevated readings of more than 140/90 at an interval of 4 hours apart. If the same non-pregnant woman, 1 to 2 weeks apart, in pregnancy only 4 hours apart, if 2 elevated blood pressure more than 140/90 is defined as hypertension. The home blood pressure monitoring is recommended by American College of Obstetric Gynecology, but what ideal is ambulatory blood pressure monitoring. And of course, there are few risk factors. Those who develop PRIME, nulliparous women, all these things are obese individuals are very common. When you say 140/90, the new target came out with the American Heart Association, American College of Cardiology, that lower the blood pressure even lesser to 130/90, it decreases the mortality in pregnancy by several randomized controlled trials. The hypertension pregnancy encompasses a chronic hypertension, that is hypertension before pregnancy or before 20th week of pregnancy. Maybe gestational hypertension develops only 20 weeks after pregnancy with no proteinuria. Preeclampsia where gestational hypertension with proteinuria, and the preeclampsia may be the placental preeclampsia, maternal preeclampsia. If any person develops before 34 weeks, it's a placental preeclampsia. Any person develops after 34 weeks, it is a maternal preeclampsia. And eclampsia may be overlapping with the chronic hypertension, or it may be some individuals, 8% of individuals, they develop eclampsia after the delivery. The goals are tight, less than 140 by 90, but as already alluded, the randomized controlled trials, 152 randomized controlled trials, including CHPI, controlled hypertension pregnancy studies, came out with a result that less than 130 by 85 is better outcome. So if you have a less tight control in pregnancy, because of the endotheliosis in pregnancy, endotheliums are vulnerable for injury, even slightly higher normal blood pressure, they may develop serological complication, bleeding. That is the reason why you have to be tighter control when compared to the older recommendations. So the two things are happening in the pregnancy. What is the problem in pregnancy? The hypertension, the placentation problem. The vascular remodeling, the spinal artery remodel is not occurring. So whenever placental problem, the release of hormones released from the placenta, that causes increase in blood pressure. And there are several mechanisms for that, like the release of antibodies to vascular endothelial growth factor, antibodies to placental-derived growth factor, and antibodies to the other cells are produced. Thereby, vasoconstriction occurs. The vascular remodeling of the spinal artery doesn't occur. The increased resistance to the flow to placenta, the placental perfusion decrease. Thereby, the fetal outcome is poor. These are complications, the venous thrombosis, stroke, CKD, CAD, and of course placental, these two the infant with a decreased growth in the uterus. So the risk estimation, is it possible to identify overall people develop complications? Yes, overall develop preeclampsia even before they develop preeclampsia. So you do the marker that is called this soluble FMS like tyrosine kinase. One elevation will be there even before the proteinuria. Even before the proteinuria, this elevation will be there. This is a marker that this patient go for preeclampsia. You detect it, control blood pressure, you can prevent the complication. See, when you go for the management, there are two principles of management. Prevent the progression of severe hypertension, to prolong the pregnancy till you get 37 weeks. So that there is fetal outcome is good. That is a two principle behind it. So what it means? So you control blood pressure. When you have high blood pressure, you cannot give all the drugs. Only selected drugs are indicated, like beta blocker, hydrolyzing nifedipine, and these can be given. Suppose if you have high blood pressure, give intravenous. Slightly mild to moderate hypertension, you give oral drugs. When you talk about the beta blocker, the most important drug is labetalol. It acts by both blocking the alpha and beta, but predominantly beta action. And what it does, in addition to that effect, it is the one which decreases the proteinuria, and the prenatal outcome is improved with this drug. That is why it is safer in pregnancy and hypertension. Avoid atenolol. Calcium channel blocker is a very potent drug, again safer, cheaper, it is a tocolytic activation. It will not cause the abortion. It's a tocolytic that decreases the contractility of the uterus, so you need not afraid of the complication. Hydrolyzin may be used when other drugs are not effective. This can be used, but it has got some amount of the prenatal mortality with this drug, so better not to use those who are having heart disease. Alpha-methyl dopa is a first-line drug, like labetalol, but labetalol has taken over the first line when compared to the side effects of the alpha-methyl-dopa, you go for labetalol. Diuretics not actually indicated. It is contraindicated in preeclampsia because there is a volume contraction preeclampsia. If you give diuretic, further impedes the circulation, but it's indicated only in CKD or heart failure during pregnancy. RAS inhibitor is contraindicated. It decreases because expression is more in the kidney. So it blocks the kidney development. So agenesis of the kidney, and of course fetal demise can occur. So when you have hypertension, that is when blood pressure more than 170 by 110, so you have to go IV drug. Ideally, this you can give labetalol, IV labetalol, or nicotine can be given. And if it is blood pressure is under control, you change over to oral. And sometimes, you can acute pulmonary edema. The pregnant women can come with acute pulmonary edema. You bring down the blood pressure with the supportive measures and with the NTG. After once patient is stabilized, probably you can convert to oral drug. If a patient with eclampsia seizure, IV drug, magnesium sulfate is a drug of choice. When you see the patient with the HELP syndrome, terminate the pregnancy. Don't wait for all these things. And the management of preeclampsia is, of course, this is when to terminate the pregnancy. You try to maintain the pregnancy up to 37 weeks. After 37 weeks, preeclampsia, deliver, no problem. If patient is unsafe, unstable, you try to deliver even earlier. If it's less than 34 weeks, give dexamethasone for lung maturity and deliver. Even the patients have developed less than 34 weeks, develop severe complication, terminate the pregnancy. That's the only solution. So this picture will clearly tells you when to terminate. If anybody is more than 37 weeks blood pressure, termination of pregnancy. If anybody is having eclampsia, terminate the pregnancy, irrespective of the week. But a person is a mild preeclampsia, less than 37 weeks, you wait. You continue the pregnancy, manage with the drugs. Similarly, when you have less than 34 weeks is unstable, you terminate the pregnancy. So magnesium is a wonderful drug for the prevention, not only decrease the blood pressure, prevention of seizure and neurological complication by blocking the calcium channels of the brain, selective calcium channel blocker, and as well the NMDA receptor blocker, and is very superior to even this phenytoin and diazepam for the management of seizure. And of course, this also inhibits the acetylcholine calcium dependent release and multiple actions for magnesium sulfate. That is why it is a preferred drug. And initially start with 4 milligram, 4 grams, 4.5 grams, and dissolve in 200 ml of water. You give the normal saline water also. You give over 20 minutes, and after that you give 4 grams every fourth hour in alternate products, so that you continue to maintain, sustain the effect of magnesium sulfate, but be careful that it can produce renal failure and neurological problem, neurological deficit. So you have to closely monitor the serum levels of the magnesium sulfate. Again, this is serum the prevention of seizure. If you give magnesium sulfate, prevent seizure, directly acting on the neurons. And not only that, it is an anti-agonistic activity against the NMDA receptor. There is superior efficacy, especially when in the seizure is concerned. But however, this American College of Obstetric Gynecology recommends if you treat the hypertension when BP is more than 160 by over 110. That is not ideally indicated, but you have to start. Now the current recommendation by the American Heart Association, American Cardiology, that bring down lesser than 140 by 80, if possible 130 by 80. And postpartum eclampsia, some 8% of individuals, even without hypertension during antepartum, they develop hypertension during postpartum. And 50% of the antepartum, they continue to have BP even postpartum. That is more dangerous. All complications will be there. So you get there is antihypertensive drugs. We are talking about the hypertensive drugs. Now non-hypertensive drugs, aspirin. The end of the first trimester, if you give aspirin, it prevents the incidence of preeclampsia by 18%, 14 to 18%. The reason is the high catechol, that is the coagulating abnormality is taking place in pregnancy, hypercoagulated state. It is supposed to prevent the thromboxane-mediated vasoconstriction. It prevents preeclampsia by 18%. Aspirin, yes, the dose is small, dose is sufficient, 70 gram, but it stopped before 36 weeks. But if you consider some recommendation, you can continue till pregnancy, but ideally better you stop at 36 weeks. Calcium supplementation. If you don't give calcium, our patient is hypokalemic because calcium is required for the uterine contraction. Everything immediately with calcium. If calcium less, uterine contraction will be PPH, postpartum hemorrhage will be very common. So give calcium, pump in calcium. It is very important. If calcium is not given, it increases the blood pressure by stimulating the parathyroid hormone and renin secretion. Thereby, it is very essential. So there are recommendations. There are new papers published. The calcium supplementation decreases the blood pressure. Statin. We generally don't use statin in pregnancy. That the studies proved that it is supposed to act by stimulating the the oxygenase expression and increases the placental growth and decreases the blood pressure. There's a study, but it's not recommended, but it has got an effect on that. Folic acid, yes, very important. It is supposed to bring down the serum homocysteine. That is the one which increases the hypercarbonate state, and also it acts only by the DNA, the genesis and multiplication fundamentally. Selenium. Selenium is an antioxidant. It is one of the major components of glutathione reductase. It is an antioxidant. So that is your supplemental selenium bring down the blood pressure. Vitamin D, immunomodulator. Not only that, so many actions on vitamin D. It because of pathophysiology of the preeclampsia depends on the immunity. So definitely it improves. And omega-3 fatty acid, yes, more than 250 grams per day of EHA, EPA and DHA improves the outcome. And the lifestyle modifications, we are distributing everything, exercise. When patient having severe hypertension, bed rest and minimal activity at home. When you have mild to moderate, probably moderate exercise. So, or upper body exercise. Physical activity is mandatory, and you can do aerobic exercise and not a physical state exercise. And of course, diet plays a major role. So, high fiber already alluded by all presenters. See the probiotics. Probiotics improves the blood pressure. Calcium supplementation, yes. So you have to use probiotic. There are so many recommendations. Fruits and vegetables, not more than 400 grams per day helpful fruits. And high fiber, 30 to 40 gram, 30 gram, 28 to 30 gram. Fluid management, don't be overloading, especially preeclampsia. That fluid management is a complication. Avoid smoking alcohol. And prebiotics, of course, use multivitamins useful for pregnancy because they need to growth of the fetus. You need to give antioxidants is essential. So this is a summary of all the slide. So what not to do, what to do, when to do, and how to do. So and see now we have had novel therapies. The pathophysiology of the preeclampsia defines the immune mechanism. There is decreased growth factors, angiogenesis factor, increased anti-angiogenesis, anti-growth factor. So that imbalance is a main pathology. So what you do, you prevent all by injecting recombinant the protein of the vascular endothelial growth factor and the placental growth factor. You give injection, or you can give inhibit the soluble FMS like tyrosine kinase activation, inhibit. And RNA interference you can give, and selective absorption of all the antibodies can be done with the absorption technologies. So these are the newer drugs which is useful in pregnancy, the small molecule interfering, and you have to cut down the soluble factor like FMS like tyrosine kinase 1, so thereby decrease the blood pressure. Small molecule, see sildenafil. Sildenafil is one which is used for the erectile dysfunction that enhances the cyclic GMP levels, and that decreases the blood pressure and enhances the fetal growth. So that is recommended. And apheresis, if you are not able to do anything, whatever all the bad substances there in the blood, you do all the take out all the antibodies so that the complications reduce. Friends, take home messages. Prevention of hypertension should start before pregnancy by lifestyle and exercise. That shows 40% reduction in preeclampsia. And recommendation, tight blood pressure recommendation by ACH and ACC. And low aspirin dose is recommended. Metformin prevents preeclampsia. And all the recommendations are advocating to give IV drugs if patient is in severe condition, and IV magnesium is eclampsia. And of course, this is my final slide. Lifestyle prevents hypertension before pregnancy. early screening detects preeclampsia during pregnancy, and guideline-directed management prevents seizure and other complication during pregnancy and after pregnancy. Friends, let us save fetus and mother from the dreadful complication of hypertension. Thank you very much for patient listening.
Thank you, Parandaman sir, for your extensive and elaborate points regarding the pregnancy and hypertension. You have enlightened the olden method of treatment as well as newer medicines. It's very useful. And only one thing, sir, a patient who had pregnancy-associated hypertension, preeclampsia and eclampsia delivered, is there next pregnancy, what is the precaution to be taken, or the time interval between the subsequent pregnancies will, if postpone it, will be of useful?
Yes, it's a very nice, very practical question. So any person, like almost close like a diabetes, 30% they continue to become diabetes, 30% they don't develop, but after 5 years, 30% don't develop. Same thing applies here. There has to be individuals, they don't develop hypertension, keep monitoring. If develops hypertension, control it with a drug. With a drug, we should not interfere with the feeding. And postponed pregnancy, if it is a severe eclampsia, pre-eclampsia has occurred during the pregnancy, better avoid the next pregnancy, unless it is essential. If the mild pre-eclampsia, probably give a gap of 2 to 3 years, stabilize all the physiology, then probably they can plan if it is required. This is all only frequent monitoring and close vigilant to this thing.
Thank you, sir.
Hello.
Can they continue the drugs previously they are taking?
Yes. Most of the drugs, what is used during pregnancy, like labetalol, methyldopa, nifedipine, can be continued, except methyldopa is a good drug, even postpartum, but only thing is that depression is very common. So better avoid methyldopa post-delivery. Other drugs can be used.
Parandaman, what about amlodipine?
Amlodipine, yes. Now the new recommendation, the studies there were short studies showed that amlodipine and diltiazem and non-hypertensive.
Amlodipine is a category C recommendation now for
yes.
pregnancy.
Yes.
Quite safe to use. Only data is limited.
Yes.
You are talking about the nifedipine. Is it a short acting or a long acting?
It's a retard preparation. Retard, long acting preparation.
Not mentioned that.
Sir, type and yes, intermediate acting, but it is not short acting. It definitely is not short acting. Only retard preparation or that is sustained
Preventing
action.
hypertension in pregnancy, does it prevent hypertension in the child?
Prevent, sir?
In the offspring?
Possible, sir. Yes, sir. Anything is possible. The chances of developing offsprings, chances of developing hypertension.
No, we have a primordial prevention in diabetes. You prevent diabetes in
yes,
mother.
we have to study, you have to follow. Yes,
No.
sir. Is there any studies, sir? Please, sir.
Is it possible?
I think it's possible.
Sir, known hypertensive on anti-hypertensive drugs like AC inhibitor and ARB, now pregnant. When to stop and when to restart?
Actually, there is that particular areas I covered because of short time. I just rushed the slide. You should not start ACE inhibitors, ARB in a fertile woman. Any fertile woman, please avoid because incidental pregnancy can occur. So, if at all conceived during that, no other go, we have to monitor and you have to keep continue. I mean, not that you have to tell the risk because you already taken, already conceived, already now 3 months over, and chances are there, but still we have to pray for it. Postpartum. Postpartum not immediately required, sir, because now these drugs get. You continue nifedipine, calcium channel blockers, the beta blockers. Better continue, better avoid. I think there is no recommendation that ACE inhibitor ARB can be started immediately. Probably a protective effect, probably once every 6 months over, probably you can restart.
Thank you, Parma. Thank you. Sorry for the interference. I think we are running behind schedule. I requested my friend Dr. Lakshmanan to cut short the panel discussion, and he has prepared nearly about 14 questions for 7 panelists. I have told him to ask only one question per panelist so that things will become all right. Because his contribution will be again a lengthy contribution. So I thought I should probably restrict the participation of the panelists and allow this gentleman to talk. You can announce.
So before we move forward, thanks to our previous panel discussion, and Dr. Parandaman did a great job with a wonderful presentation. A big round of applause to him and all the 4 round of panel discussions. Moving on, I request Dr. S.S. Lakshmanan to take over as the panelist.
I'd like to call the panelists to the dais faster. Yeah. Dr. Rajesh, are you here? Yeah. Balaji, Satyakumar. Dhananjayan? Okay, fine. Aravind? Yeah. I think without wasting the time, we'll start with the questions. Because once you make a diagnosis of hypertension, normally it's a lifelong treatment. You take a tablet, you have to keep continuing it lifelong. So the doctor has to measure the blood pressure very properly. He must be doubly sure that the patient is suffering from blood pressure. I would ask Dr. Shanmugam to make it very short answer. What's the importance of measuring the blood pressure in your clinic?
The importance of measuring blood pressure accurately is very, very important, because that decides what the doctor is going to advise the patient, whether this is a lifestyle modification or a pharmacotherapy or both. And another thing, to tell the patient you are normotensive or you are a hypertensive, or sometimes you may have a hypotension also. But depending upon this only, and also the target organ damage can be assessed by the severity of the high blood pressure also. Therefore, in that case, we may have to investigate the patient further, and depending upon the target organ damage, you may initiate the lifestyle modification as well as the pharmacotherapy.
Yeah, I think, Shanmugam, the importance is how do you measure the blood pressure in the clinic, in your patient?
Yes.
What do you tell the patient?
No, this is the way to measure the blood pressure. That is, the validated blood pressure apparatus should be there, and the patient, everyone knows that patient should be sit quietly for at least 5 minutes, rest back, then legs down on the floor, not crossing also. The previous 15 minutes or 30 minutes, he should not have coffee or exercise or alcohol or smoking. In addition, he should empty the bladder, that is most important, and correct size and the cuff. And if it is nowadays you don't have the mercurial, therefore you straight away go to the automatic electronic system. At least check 2 times or 3 times and take the first one always we omit. Therefore you take the second and third and get the average. If the BP variation is between the right and left, you take the highest one, and always feel the pulse of all the 4 limbs. That is most important. Many people, they do not do that.
Thank you, Shanmugam. I think doctor office ponane odane avasarama BP check pannadinga. That's a very important message. You go, wait, talk to the sister, wait for some time, and then ask the person to check the blood pressure. I'd like to ask Dr. Rajesh, what is the weight code hypertension, mass hypertension? Very brief, because it's already answered in the previous discussions.
Yeah, so white coat hypertension, we all know that the clinic, that is the office blood pressure is always on the higher side. So whenever we check the patient's blood pressure, it will be above 140/90. But in the other places, for example, in the patient's home or in the patient's workplace, outside the office, the blood pressure will be absolutely normal. So this is one thing called as white coat hypertension. And the masked hypertension is also known as the reverse white coat hypertension, where in the clinic, the blood pressure seems to be normal, less than 140/90. But in general, if the patient goes in his workplace or in his residence, what happens? The blood pressure is always elevated. So what is the relevance is that the masked hypertension has a higher risk of developing other complications of hypertension, just like how regular hypertension, the primary hypertension. And white coat hypertension also, previously it was thought it was very benign, but again, there are data to show that these patients on a longer term, they can develop hypertension. And again, the cardiovascular risk is also, it's not that very elevated, but again, compared to the normotensive patients, it is really elevated. So this is the difference between white coat and mask.
Very important is the importance of home blood pressure monitoring, and tell the doctor that you don't suffer from true hypertension. And sometimes OP record பார்த்தீங்கன்னா BP 180, 100, 160, 19 இருக்கும். எக்கோ பார்த்தா LVH இருக்காது. Left hand hypertrophy. That means we really know that the patient's weight effect. I think ask Balaji, you are a diabetologist. How do you manage your diabetic patient with blood pressure?
Yes, sir. So nowadays, managing diabetes and hypertension comes together. So it's need a multifactorial approach. Like what we manage diabetes and hypertension, more or less everything is similar. It starts with lifestyle intervention. So we all heard about the DASH diet and restriction of salt of less than 5 grams, and more takes about fruits and vegetables, and restricts the carbohydrate and more amount of protein. And regarding the exercise, 150 minutes of regular walking and other regular activities, aerobic activities, and some amount of resistant exercises. And finally, moving on to the drugs. So a strict control of a target of less than 7 of HbA1c based on the age will be the diabetes control. And your BP target will be less than anything 130/80. And we usually use ARBs and ACBs as the first line of treatment drugs in diabetes with hypertension. And regarding the drugs of control of diabetes, we have a target of less than 7. And based on the age, to avoid hypoglycemia, the target can be extended. And finally, just examine the patient and look for any complications, retinopathy, nephropathy, and neuropathy, and any target organ damage. And the most important aspect of thing is education. So unless otherwise you educate the people about the do's and don'ts of these targets and how to achieve this, nothing can be achieved.
Thank you, Balaji. I think almost 70 to 80% of diabetics also have hypertension. So BP இருக்கவங்க sugar இருக்கவங்க கண்டிப்பாக you must check your status for diabetes. And doctor சொன்ன மாதிரி normally we give combination pills. Usually we start minimum 2 drugs for blood pressure, mostly in a patient with diabetes. Thank you, Balaji. I think important questions comes to the senior physician, Satyakumar. What is the ideal blood pressure in the following situations? Pregnancy, CKD, heart failure, and post-stroke.
I think
Make one line.
Yeah, regarding pregnancy, already Dr. Parandavan had given an extensive thing, so I can skip that. Next is you asked about heart failure. Heart failure, we have got 2 things. One is with preserved ejection fraction. The other one is reduced ejection fraction. Reduced ejection fraction, we have this beta blockers, then valsartan sacubitril combination, and then mineralocorticoid receptor antagonists, along with the SGLT2 inhibitors, what they call as Fantastic Four. I think cardiologists call it Fantastic Four. All these 4 drugs are given in heart failure with reduced ejection fraction. It is given even if in the absence of high blood pressure. So when we are giving these drugs, if you titrate, I think the blood pressure can be brought under control. In preserved ejection fraction, you can use AC inhibitors followed by calcium channel blockers, and diuretics if necessary when patient has got any features of pulmonary edema. In the elderly you asked, and elderly, again now the recent guidelines say it is less than 130/80, above 65 years of age. But then if the patient is 80 years and if there is above 80 years and they have got frailty, always it's better to keep the blood pressure target at a higher level, maybe 140/80 or even 150/80, depending on the patient's frailty. But if the patient is very healthy, you can still aim for less than 130/80. That's about the elderly. And what else, sir? You asked about
post-stroke?
Post-stroke, yeah. Post-stroke, it's again, you have to see whether it's ischemic or whether it's ischemic stroke or intracerebral hemorrhage. If it's ischemic stroke, the first 40 to 72 hours one target, and then later on the target will differ. So if it's acute stroke, that is the first 40 to 72 hours, depending on the patient's thrombolytic status. If you are going to thrombolyze, you keep the blood pressure under 185/110 millimeters of mercury. And if it is going to be intra-arterial thrombectomy, then the ideal blood pressure will be less than 105 millimeters of mercury. Suppose you are not doing either, if the patient is going to be managed conservatively, it's what you call as permissible hypertension. That's keep the blood pressure only less than 220/120. You don't bring it down much further for the first at least 48 hours, because you need to have the ischemic, ischemic areas. You need to have some, permissible hypertension so that the perfusion will be present. And then if you are coming for intracerebral hemorrhage, there the high blood pressure has to be brought under control in a very faster way, even in the acute phase. It should be around 140/90. Suppose if the BP is very high, you can use IV drugs like IV labetalol and esmolol. Suppose if the BP is not very high, oral drugs can be tried like AC inhibitors, and diuretics are the drugs of choice.
Thank you, Sadhkumar. I think pregnancy ideal blood pressure is 120/80, but the threshold for treatment people say 140/90. And the CKD, we try to keep the blood pressure 130/80. Heart failure again 130/80, but not to bring down the blood pressure systolic less than 120. Post-stroke, slightly lenient. People, you get discharged from the hospital after treatment for a stroke, after 2-3 months' time. Try to keep the blood pressure 140/90. Elderly, very elderly people, above the age of 85, I think the blood pressure target is between 140 to 150. Suppose below 85, a fit person like Shanmugam, sprint trial, Accord, they all said, we can have a blood pressure less than 130/80, like a normal person, if they can really keep them fit, walking and things like that. So it's all dependent, as Sathyakumar said, is a frailty which is important. I think Venkata Krishnan is not here, no? I think you can take up the question, Venkata Krishnan's question. What are the hypertension emergency? What is elevated blood pressure? What is hypertension emergency and what is hypertension urgency, and what are the drugs used in ICU? Anyone want to take it up? Okay, fine. Thank you. Okay, come to Dhananjayan. What is the lifestyle modifications you advocate to the public? Very important question. And what is the role of sodium restriction? And what are the adverse effects of the alternative therapies? You people take homeopathy, Siddha, then native drugs. And people secretly take painkillers, NSAIDs. முட்டுவலி மாத்திரை சாப்பிட்டே இருப்பாங்க, பிபி மாத்திரை போடுவாங்க, முட்டுவலி மாத்திரை டாக்டர் தெரியாது. So we'll all talk about it with Dhananjayan.
Thank you, sir. As we are discussing all through in this World Hypertension Day about lifestyle management, it's very important as far as public, not for all, for we doctors also we have to practice it, that we can, as a primordial prevention also, even if you don't have any risk factors or anything, we should try to practice it. Basically it is, one is exercise. It doesn't only mean that aerobic or anaerobic, both combined, and reduce the BMI. That is the single most factor which reduces the blood pressure to the tune up to 13 to 20% of, and the mortality reduces. And about the, after exercise, your diet. Diet plan should be, as discussed, DASH diet, which includes fruits, vegetables, and lean meat and grains, cereals, and then with reduced salt and restriction of sugars. And where we mean that we avoid that red meat and fatty items and fried items. And this is shown to decrease BP to the tune of 6 to 8%, 8 millimeter. Okay. Then coming to our habits, we should cultivate good habits. And smoking and alcohol, all the important risk factors for hypertension, and also it interferes with the management of hypertension and the drug effect also. And alcohol, even though previously it was told moderation of alcohol, but now evidence has appeared, and what is advocated is for the maximum benefit to be attained, absolute abstinence from alcohol is important. And peaceful sleep, as already discussed, we should have a peaceful sleep, and for an adult, around 6 to 7 hours of sound sleep. Not, it doesn't mean that the time duration, it should be a sound sleep. And if you are disturbed or in stress, you can go in for a morning walk or yoga or meditation and other things. That also plays a vital role here. And regarding other lifestyle interventions, you are for exercise.
Dhananjan, I think you have done that.
Yes, sir.
Go for the other salt restriction.
Salt restriction is very important. That is 5 grams per day as per Indian. And we are used to maximum salt, but we should try to reduce it. And practically speaking, we should, for a patient perspective, we discuss for salt in the dishes, we can avoid salt in the rice, something like that. And if they are at high risk, we can go in for low sodium formulations, which are very well available. And
Next one.
the other
Next
thing
one.
is
alternative drugs. Make offline.
all the counter drugs. And see, as sir has already told, they might have taken NSAIDs, which hinders the efficacy of the drugs which are used for hypertension through prostaglandin inhibition. And also other, we should have a good history regarding what are the drugs they are taking, like antidepressants, and then sympathomimetics or illicit drugs, and everything will have a role. And OC pills, that also has a role in it. And native medicines is very important. So alternative medicines, there is we don't have a proper formulation data on that, and sometimes they are being contaminated or adulterated with the heavy metals also. So it may have an effect of renal function, and then patient may land up with hypertension. And the interaction of that drug with the drugs we are giving for hypertension, the drug-to-drug interaction is also is a place to study. So we have to avoid that. And many over-the-counter and the native medicine like ginkgo biloba, and then ginseng and licorice, etc., will have a effect on, will cause hypertension, and then have an effect on other drugs we are giving, such as blood thinners and other things. So
Thank you, Doctor.
better to be avoided.
Thank you, Doctor. I think you made a very big answer. I think we are salt sensitive. Indians are salt sensitive, you must remember. So if you take more than 5 grams, probably we develop a lot of blood pressure problems. I think you must not give children up to the age of 2 years, no salt. You know, animals don't give salt. Dogs are dogs, anyone know? Naiki salt poringla? It runs here, there, a lot of sweat comes out. So people say summerla salt kammi aidumenu nenikranga, but we are salt sensitive. So salt handling by our kidneys are very poor. So we have to avoid salt. In short, you must tell them, uppu, urga, appalam, vadagam, karuvadu. Finished. If you could try. Some people say, I cannot eat without urga. Wash பண்ணி சாப்பிடுங்கன்னு சொல்லிடுவேன். தண்ணியில் நல்லா வாஷ் பண்ணியாச்சுன்னா உப்பெல்லாம் போயிடும். அவங்களுக்கு அந்த ஊரை துண்டை பார்க்கணும், அவங்களுக்கு தான். தேங்க்யூ டாக்டர் தனஞ்சயன். I think we'll come to Dr. Arvind. I think we'll concentrate on how do you manage blood pressure in acute myocardial infarction in the ICCU?
Sir, in an ACS patient, when we are managing blood pressure, first thing is if the patient is a candidate for an STMI or a non-STMI. In a STEMI patient who's not going to go for a primary PCI, who's going to go for a thrombolysis, the BP should be less than 180, 110, or else that is going to be a contraindication for your thrombolysis. And the blood pressure reduction in the first 1 hour should not be more than 25% reduction should not be done. This again, and post 1 hour, the slow reduction the blood pressure can be done. The high blood pressure in this scenario is going to cause two things. One is the free wall rupture, and it is also going to increase the myocardial oxygen demand. The usage of drugs also should be short-acting drugs. The long-term therapy should not be initiated at that point of time. Preferably, IV drugs can be used at that point of time to reduce the blood pressure, sir. Once the patient is stabilized, then the long-term therapy can be started based on the ejection fraction. We don't need to add beta blockers if the EF is more than, it is going to be more than 40%. We can only use ACE inhibitors. When it falls less than 40%, you can add a beta blocker. Along with it, a spironolactone MRS can be added. Sir.
The message is long-acting antihypertensive drugs, please avoid an acute MI. Suppose you give one long-acting like your telmisartan. We may not know what's going to happen to the blood pressure swing after 6 hours or 7 hours time. I think the point is well taken. But what's the prognosis in a patient who got a blood pressure, high BP and myocardial infarction? A patient with hypotension and myocardial infarction.
Sir, the hypotension and myocardial infarction is the worst thing that can happen to the patient.
One should remember, if the patient get admitted with a high blood pressure and myocardial infarction, he is pretty safe. He's pretty safe. Small dose of beta blocker, especially metoprolol or IV, small dose of
Sir, IV metoprolol is the best option. Sir. You can give 2.5 milligram. You can escalate it every 10-15 minutes as per it is required.
So that's a very important point I thought he should stress. Long-acting antihypertensive drugs should not be used in the acute MI period. A lot of times I see doctors use AC inhibitors, ARBs, in the acute MI period. Very, very controversial. We don't use it. You can also tell how do you manage a patient with a partial hypertension? No? Elderly people, you give blood pressure medications, they go for partial hypertension.
Sir, first I would say the non-pharmacological measures are very important there, sir. Adequate hydration should be there. If you have to give them venous stockings, give them venous stockings so that there is no pooling there. How do they sleep? What posture they maintain to sleep? Those corrections and those knowledges are more important in this people. Then comes our pharmacological intervention, sir. Adding a drug like a amiodarone or a fluorocortisone should be an last option, and it should not be the first thing that we follow in these patients.
Yeah, very important thing is elderly guys, they have a supine hypertension, and then when they get up, the blood pressure drops down. I think as rightly, options are very less. Stockings, very cumbersome. Midodrine is a good drug. It actually blocks only the veins, constricts only the veins. So you get the blood pressure rise without much adverse effects.
Sir, even abdominal stockings can be done. Sir.
Yeah, we can have binders.
Yeah, abdomen and lower limb, all those things.
Yeah, binders. Come back to Shanmugam. Shanmugam, what is this home blood pressure monitoring and the ambulatory blood pressure monitoring? I think nobody spoke about the ambulatory blood pressure monitoring.
No, ambulatory blood pressure monitoring is in some of the countries mandatory to confirm the hypertension, because many people told no, you got an office blood pressure is higher than the home blood pressure. Therefore, you have the white coat hypertension. And the another person told no, you got the masked hypertension where the home blood pressure is higher than the office blood pressure. And invariably, most of the people, due to various reasons of the anxiety and new environment, office blood pressure is higher than the normal. Therefore, to have a confirmed one, and also many people have got a target organ damage, and also many people have got the non-dippers, that is the nocturnal dipping is not there. Usually, you should have more than 10% or 20% compared to the daytime. That is not found in the home blood pressure monitoring. Therefore, to say that no, the ambulatory blood pressure is more useful and correlative with the cardiovascular risk factors compared to any of the home blood pressure or the office blood pressure. Therefore, it is at least once in a time you have to measure the ambulatory blood pressure, and especially in pregnancy you can use it, in diabetic you can use it, and also in CKD you can use it. And patients who are very anxiety, who are unable to come to a diagnosis whether this is due to anxiety related or something, then people who are having a very high skilled work, sometimes the pilots or something people, it's better to have everything analyzed and tell that you are a normotensive or you are a hypertensive or you are a having masked hypertension, etc. So in this way, this will be very, very useful. And home blood pressure monitoring is very, very useful for monitoring, and also because it is economical now, every people should be having the home blood pressure apparatus so that they can utilize it very frequently and consult the consultants.
Thank you, Shanmugam. I think ABPM is a wonderful tool because the blood pressure in the night can be measured only by ABPM. Normally, you can't get up and then measure your blood pressure. Most of the Indian hypertension, my studies, have severe nocturnal hypertension. Even before microalbuminuria, the first complication occurs is non-dipping. I think one should, hypertension should have ABPM in their treatment plan. Thank you, Shanmugam. I think we would call Dr. Vasant Kumar to the stage as he is leaving to Hyderabad. Sir. Dr. Vasant Kumar, come to the dais.
Ladies and gentlemen, Dr. Vasant Kumar, who is the president of the Indian Society of Hypertension, is now leaving. Let us give him a big hand for his help in conducting this meeting also.
Two more questions to the audience. What is resistant hypertension? What is secondary hypertension? Are they similar or different? Balaji, make it fast. One sentence.
Sir, secondary hypertension is any underlying cause for hypertension. So it may be like secondary causes like pheochromocytoma or Cushing syndrome or other things. So resistant hypertension is completely different. It may be uncontrolled BP after adding 3 drugs or 4 drugs. Even still, if the BP is not controlled, it's called resistant hypertension.
All secondary hypertension are resistant.
Yes, sir.
That's a carrier message.
Yes, sir. Absolutely.
Yeah, please. So in a practice, when your BP is not coming down with the maximum 3 drugs, please rule out all the causes of secondary hypertension. I think Narsigan said, I found out a case of a boy with diabetes, the Cushing syndrome. He had already had a diagnosis of heart failure, diabetic nephropathy. He had a blood pressure of 180 by 120. The minute we attacked the pituitary gland, everything disappeared. His sugar disappeared, BP disappeared. He became as thin as Dhananjayan. So that's a very important thing, that one should know that the resistant hypertension indicates to you to please check the patient for secondary hypertension. Very important. That's the message. Satyakumar, what is the advice? The elevated blood pressure, a child with elevated blood pressure, somebody asked in the morning a question. My boy has got a blood pressure. Is it different from the public? I think probably this is a final question. Kindly.
You're trying to ask me about the adolescent blood pressure?
Yeah, adolescent plus childhood.
Yeah, childhood blood pressure is very different. It's very different from the adult hypertension in many ways because the index of suspicion is always low in a child. We don't normally measure the blood pressure routinely, so it's very difficult to diagnose it in a child, especially children less than 12 years of old. So now the many periodic associations have recommended the measurement of blood pressure at least once in a year for all the children above 3 years of age. But then it's very difficult to measure blood pressure in a child because as recently, as my colleague said, you have to make the child sit straight and then sit quietly and then put the arm on line with the heart and all that. It's very difficult to measure in a child. So nearly it takes about 20 to 30 minutes to measure BP in a child. And then the BP also keeps changing because it's not static for a child. The blood pressure depends on the age, sex, and height. So every year, as the child grows, the normal BP also goes up. And so it is recommended that children who got blood pressure above the 95th percentile, 95 and 95th percentile, above that, they are taken as hypertensives. And if they are between 90 percentile and 95, it is pre-hypertension. But then again in a child, the secondary causes are many, especially children who are less than 6 years of old. For adults, it's only 5 to 10%, but in the children, the percentage is very high. Whenever you come across a child, especially children who are less than 6 years, look for any renal causes like polycystic kidney or renal artery stenosis or glomerulonephritis, or endocrine causes like Cushing's, thyroid disorders, or pheochromocytomas, and coarctation of aorta. Sometimes children, they have got retinoblastoma or nephroblastoma. All these children, they can have hypertension. So you have to go thoroughly for secondary causes in these children. And for these children less than 12 years, the dosage is very important because every few months the child grows up and puts on weight. So the dosage adjustment is very important. So keep on checking the child's weight, and as per the weight you have to give the drug for a child. So these are all the challenges in a child. Coming to the adolescent age now, and up to 18, 17 years or 18 years old, nowadays the obesity, childhood obesity has become more. So the causes are like in an adult. So even the BP levels are also like in an adult only. But then even in the children nowadays, the usage of alcohol, even around 14, 15, 16 years old children, or addictions are there. And abroad, then this for females, the contraceptive use also has come, contraceptive usage. So all these things have to be looked into, at least not in our country. But then for children, the obesity is a major problem, and drug abuses are also present in our society. So these things should be looked for, and children should be advised, in the school itself. Sir was telling how we are going to implement it in the society. I think it should start in the schools itself, right from early stages of schooling. I think it should be added about lifestyle modifications. It should be taught in the schools. And in the midday meal programs also, I think now they are giving a very healthy food. So all these things should be encouraged. And then in children, exercise, in the schools, earlier days, there used to be a PT class. At least 1 hour of exercise used to be there, but nowadays it's not there in many of the schools. I think all these things in the society, it should be brought in. The dietary advice should be given in the schools, and physical exercise also should be encouraged in the schools. So that way, I think the adolescent BP also can be controlled, rather prevented.
Thank you, doctor. I think you have said very well. Below 18 years, mostly secondary hypertension. Secondary hypertension. Rule out all causes secondary hypertension. And as you said, last week I had a boy who was brought from a hostel with a 210 by 120 blood pressure. Cocaine abuse. Now very commonly seen in the public. And if you really say public intervention, I asked the nephrology madam in the afternoon, in 1970, Finland has the highest mortality, CV mortality, 80%. Now, it was only 6%. This man, a man from Carmelina, he completely removed all the saturated fatty items around the school first, then around the malls. Then in a small city, he removed every place, no saturated fat at all. Then slowly, government thought the incidence is coming down. They implemented throughout Finland. So by 40 years, they could bring down the incidence of the cardiovascular disease, coronary artery disease, by so many percentage in a country. I think we should all do some, as you rightly said, it should start from schools. The meals given in the school should be a healthy meal. They also should know what is the carbohydrate, what is protein, and also said important exercise. They very, very nicely said. I think last question, what's the starting drug you use in your practice? CCB or ARB? Only one line. Mike.
If it is a young, no, I start with
Only
ARB.
one line.
Elderly, start with calcium channel blocker.
There's an indication for ARB, you don't do it.
Pardon?
They are contraindicated in elderly, ARB?
No, not contraindicated. Because mostly it is an isolated systolic hypertension comes in the elderly.
If it is if the patient is a diabetic, I will be starting with either an AC or an ARB.
Otherwise?
Otherwise, also still we can start with an AC or ARB. Otherwise, we have other options also. We can use a low dose diuretic or a low dose calcium channel blocker. All these can be used.
You don't use chlorothiazide, chlorothalidone.
Chlorothalidone can be used.
That's
Only
a
thing
initial
I'll be a little cautious with the hydrochlorothiazide, but chlorothalidone in a low dose 6.25 can be used.
The only medicine which is proved to prevent left ventricular hypertrophy is chlorothalidone. Yes. Very, very sad situation that we don't use such a cheap drug just for want of fear of hyponatremia. The only drug may be followed by ARBS. Neither your CCB or a beta blocker never prevents you develop the left ventricular hypertrophy. Other people? Cardiologist?
When it comes to me, it is always cocktail. By the time they come to me, it becomes a cocktail, sir. And,
what could be the starting drug?
Sir, it's always ASARB, sir. Like he said, sir, in my practice, when I see patients who come with cardiac problems, I handle a lot of these hyponatremias with CTDs and I have to stop, sir.
So I use ARB as first
Okay,
choice.
ARB consensus becomes higher. The sales of ARB is going up. Every day there's a rise in ARB sales, especially the telmisartan. Last final round, target blood pressure 130 by 80 or 140 by 90? Treatment threshold.
138, sir.
130 80.
So less than 130/80, sir.
Your father-in-law is given 140 90. Where is he? He is here.
Less than 130.
You never asked him. Our Indian ISS guideline, he says the threshold is 140 by 90.
These patients with chlorothalidone, I stop them also, sir. They get with hyponate.
Dhananjayan.
Sir,
Only one
target is
line.
130/80, but not below 120/70.
No. Threshold is 130 by 80.
130/80.
Balaji.
Yes. 130 by 80, sir.
Nobody's for 140 90, yeah? Only Narsingan. The minute it came, I called him, Narsingan, what is it? You are in the panel. You have mentioned that the threshold of treatment is 140 by 90. Let him answer.
Yeah. Now, there was a lot of controversy when we were all coming out with the so-called guidelines or the consensus statement from Indian Society of Hypertension, including the definition. I was actually in charge of the definition. I wanted the definition to be brought down from 140 to 130, and the lowest level should be only 130/80. So that is the one which was recommended by me. Out of 10 people,
And why design?
out of 10 people who were there in the panel, to identify what is the definition from Indian perspective, 7 of them voted against me, only 3 of them supported me. So they wanted to stick on to only 140/90. I think I'm now bold to talk about it because Vasanta Kumar has gone. So Indian guidelines still persist that it should be 140/90. Above that is considered as hypertension.
What about
But
you
what I practice in my clinic is that 130/80 is the goal and 138 is the threshold beyond which you should start treatment.
Thank you. I think I'll give a big hand to the panelists. They gave a nice message to you. Thank you, Narsingan, and thank you, Sanshar, for the good chance they given to me. Thank you.
I think it's now time for us to hand it over to Sachin. It's time for you to propose vote of thanks and finish it. Yeah. Can I request all the panelists as well as the speakers who had participated in the scientific session to come to the dais to receive the mementos, please? the persons who were there in the scientific program. Yeah, it's a call. She'll do it.
Thank you so much, sir. To get started with, we're first going to be felicitating the main captain of the ship, I would call, Dr. S.N. Narasingan, sir. So please go to the center of the stage, please. And we would request Dr. S. Chandrasekhar, sir, and Mr. Sachin Nair to do the honors and felicitate him. A big round of applause for putting up such a wonderful, extensive event on behalf of World Hypertension League. He's one of the main reasons behind this event happening on such a large scale today. A big round of applause to Dr. Narasingan. We have Dr. S. Chandrasekhar and Mr. Sachin Nair from IPCA doing the honors. Thank you. And I request the dignitaries of IPCA Laboratories Limited to please come up on stage and honor Dr. S. Chandrasekhar. Dr. S. Chandrasekhar, can we have you on stage, please, in the center? We have the IPCA Laboratories Limited team honoring Dr. S. Chandrasekhar. Up next, I would like to call upon stage Dr. A. Aravind. Ladies and gentlemen, we have with us one of the most important doctors today, Dr. A. Aravind. Thanks for being here with us today, sir. Up next, I would like to call upon stage Dr. K. Mukundan to receive the honor. Dr. K. Mukundan. Moving on, I would like to call upon stage Dr. P. Soundararajan with a huge round of applause, please. All right, since he's not present, let's move on to the next doctor. I would like to call upon stage Dr. Namita Narayanan. Dr. N.D. Ramanajan, please come up on stage, please. Can we have Dr. N.D. Ramanajan come up on stage? All right, since he's not around, can we have Dr. Nambirajan to come up on stage and receive the honors? Dr. R. Kannan, can we have you on stage, please? Up next, I would like to call Dr. M. Subashri. I request Dr. R. Kannan to receive the honor. Up next, receiving the honors for the day is Dr. M. Subhashri, a big round of applause to her. Also, I would like to call upon stage Dr. D. Aishwarya. Up next, please come upon stage Dr. Aditya to receive the honors. A big round of applause to Dr. Aditya for being a part of this wonderful initiative today. We have with us Dr. Aditya. Now I'd like to call upon stage Dr. P. Parandaman. Thank you so much, sir. Thanks for your presence today. And now I'd like to call upon stage Dr. Prince Pius. Now receiving the honor is Dr. P. Parandaman, followed by him. We are going to be having on stage Dr. Prince Pius. May I now request Dr. S.S. Lakshmanan to receive the honor, please. And I request the Ipca Laboratories Limited to do the honors to Dr. S.S. Lakshmanan. Dr. C. Balaji is receiving the honors right now. A big round of applause to him. Thank you so much for your presence today, sir. Up next, I would like to call upon stage Dr. K. Shanmugam. Up next, receiving the honors would be Dr. K. Shanmugam. Thank you so much for being here with us today, sir. And now I would like to call upon stage Dr. Arvind Durvasil. Can we have on stage Dr. Arvind Durvasil, please, with a huge round of applause, ladies and gentlemen. And now I would like to call upon stage Dr. R.P. Rajesh. We have with us Dr. R.P. Rajesh. Thank you so much, sir. Dr. D.B.D. Satyakumar. Can we have you on stage, please? Requesting Dr. Satyakumar to join us on stage to receive the honors. And once again, I would like to hand over the honors to Dr. S. Chandrasekhar. Dr. K. Venkatakrishnan, please come up on stage. Dr. K. Dhananjayan, please come up on stage, sir. Dr. Sethuraman, please join us on stage, sir. We have with us Dr. Sethuraman joining us on stage. Thank you so much, sir, for being here today. Dr. Siranjeevi, can we have you on stage, please? Thanks to each and every eminent doctor present here on the stage with us today. Thanks so much for your contribution towards this wonderful effort towards reducing hypertension around India. Thank you so much. I request all the doctors to please line up for a beautiful photograph. It's a wonderful moment to be pictured. So let's have you all lined up for a wonderful picture with the plaques. Such a beautiful picture. A big round of applause to every doctor present here on the stage right now. Thank you so much once again for the wonderful initiative put together by World Hypertension League and Indian Society of Hypertension. Ladies and gentlemen, let me remind you all once again that we should take a pledge to reduce salt in your diet. And before you leave, please ensure that you sign the board and take this pledge today. Also ensure that you pass on the message to your friends and family and people you know. It might definitely help them reduce hypertension. Once again, can we hear it up for all the wonderful doctors here on the stage present with us? A big round of applause to them. At this moment, we would like to thank World Hypertension League, especially Dr. S.N. Narasingan, Indian Society of Hypertension, Dr. C.H. Vasant Kumar, who's just left some time back, Dr. K. Kannan and Dr. S. Chandrasekhar, as well as the Association of Physicians of India, Chennai chapter, and IPCA Laboratories Limited for taking this wonderful, great initiative of hypertension awareness and control in India. I'm sure you all have the YouTube live viewers as well. Everyone who's been watching it, you can watch it later on YouTube as well. And hundreds of audience present here today. I hope you all got your BP and your sugar levels tested. So make the best out of this opportunity every single year. It's going to be happening every consecutive year. So please do be a part of this wonderful initiative and support us throughout. Thank you so much. And now I would like to call Mr. Sachin Nair, the General Manager of Marketing, IPCA Laboratories, to give away the vote of thanks.
Okay, anyhow, it's my time now to recognize the support, enthusiasm, and the interest in education for the general public as well as for the doctors that has been initiated by IPCA Laboratories, and it has been wonderfully performed in the last 3 years. This was the third year, and they have been doing whatever I wanted. They have been in a position to do it. And I must thank the IPCA Laboratories in general and Sachin in particular today. At the same time, I would like to thank Sandeep, who has been working with us in the last 3 years for making a lot of arrangements. And I think I disturbed him many times to get into the smaller details, and he had done it. Hats off to you. And next time, I have a plan that we should interact with the Rotary people. So let us have a continuing education program only for the non-medical people. We'll involve the Rotary so that it will be well attended. It will be well attended. So nice. Thank you very much, ladies and gentlemen. We'll now adjourn for lunch. Thank you. I must thank you. I have forgotten. I have forgotten your name. Deepika, yeah. I must also thank Mrs. Deepika. Yeah. Deepika Shiram, and in fact, no, I was very particular to call you here because the first time when we conducted the meeting here, you were so meticulous in carrying out all the activities, what all I wanted. And at the same time, I was very happy at that time. I thought I should probably utilize your services today. And thank you very much for coming here. Thank you. Thank you very much.